Government Medical College, and she will take us through a case. Mind it, all cases are based on diabetes, and they will have some angle of diabetes, a case or a research work which they are doing. Dr. Naushi.
Good morning, everyone. I'm Dr. Naushi. Today I'm going to present a case about an old man with abnormal movement. He came to our ER, and then and later we admitted the patient, and after that an 82-year-old man admitted with involuntary repetitive tonic movement with clonic component of right upper limb without involving the face and lower limb, with intact awareness for last 4 hours in the morning. And the movement lasted for 3 to 4 seconds, reappeared in less than 10 seconds, continuously lasted for 4 hours, and it was even present in sleep also. And patient was not having any other previous history of health history, and the patient was an ex-smoker and non-alcoholic. And there was no associated symptoms like weakness or sensory symptoms or any focal deficit on the affected limb or anywhere else, and no past history of similar illness, and no substance abuse or recent new medication, and systemic illness was present. And by the presenting history, we came to a diagnosis of Epilepsia partialis continuosa, because the patient was having the seizure on a conscious stage with a history of 4 hours, and it was reappearing again in a short time. And then we thought of the Epilepsia partialis continua, what will be the reason of the Epilepsia partialis continua, if it is CVA or something else. For that we went to the other further investigations, and on further investigations for all vitals normal, everything was ECG, X-ray, everything was normal. But we found that the patient was having dehydration, and CPG was high. It was showing in machine high, and RBS was like 722 mg per DL, and urine ketone was negative, and ABG, no acidosis was present. And for exclude the CVA diagnosis, CT brain we did, and in that there was no hemorrhage or acute infarct was present, and hyponatremia and pre-renal AKA was also found. So by seeing all these things, we concluded that it may be EPC, and then we started treatment with fluid management and electrolytes correction, and continuous IV insulin with CBG monitoring we did, and there was no medication for seizure we started, but within 2 days we found that remarkably improvement on patient without any anti-seizure drug. So we came to a final diagnosis by the presenting history and the investigation and the response to the treatment. We came to a diagnosis of Epilepsia partialis continua due to hyperosmolar hyperglycemic state, leads to new diagnosis of diabetes mellitus in that patient. It was an acute symptomatic seizure. So now we are going through a brief discussion of Epilepsia partialis continua. Epilepsia partialis continua is a simple focal motor status epilepticus with frequent repetitive muscle jerks, and it is also referred to as aura continua and encompassing sensory, cognitive and emotional variants, and it can be defined by time or duration also, and it can be in a lasting 1 or more hour, and it can also be intervals not above 10 seconds also. But the main point in the Epilepsia partialis continua is the key point is the patient will be conscious during the seizure time. And time course of APC, like now I am not going so much deep because we have a time limit. And now I am coming to the local etiologies, because EPC, what all are the etiologies are like Rasmussen encephalitis. In Rasmussen is a very severe condition, and it will affect one hemisphere. And tick-borne encephalitis, neoplastic causes like brain tumor, meningioma, and other inflammatory causes like subacute sclerosing panencephalitis, HIV, AIDS, tuberculosis, and all. And stroke is a most common cause of EPC. And other causes like brain trauma, perinatal birth injury, and multiple sclerosis are there. And systemic etiologies are like mitochondrial diseases and autoimmune disorders, and metabolic disorders are also there. And our patient is coming under metabolic disorders, that is like non-ketotic hyperglycemia.
You need to conclude, Dr. Manaushi. Yeah, you have half a minute.
And it is like mostly non-ketotic hyperglycemia presenting with newly diagnosed diabetes. And this is another 1-2 cases like we got in our hospital. This is also patient presented with a known case of diabetes, and patient was having right upper limb jerky movement, and the patient was irregular medication, and the patient also responded with only the hyperglycemic management, and we concluded it as an EPC. And another, this patient is also came to our hospital with the same complete right upper limb jerky movement, and patient was not diagnosed with diabetics, and now we came to a diagnosis like EPC with a newly diagnosed type 2 diabetic. So just I just want to highlight the one point, like whenever patient comes with a seizure, we have to see the metabolic causes also and treat according to the causes. Thank you.
Thank you. In hyperosmolar non-ketotic state or hyperosmolar state, we generally expect the sodium to be high, hypernatremia, but you showed the sodium to be 129. Could you explain that?
Sir, in seizure, because of the electrolyte imbalance in the brain, it becomes hyponatremia, because that seizure is also...
Do you know anything about assay interference in sodium assay? Any conditions that can have a
Yes,
pseudo hyponatremia is a laboratory artifact?
Yes, sir. It may be false positive hyponatremia also, because the patient
How
is having...
bad?
Because the patient is having the hyperglycemia, sodium is, sugar is high in the blood, and because of that, sodium will be showing the low.
And also associated with hyperproteinemia.
Hyperproteinemia.
So what is a preferred term for non-ketotic hyperglycemia now? What is the term we should be using?
Hyperosmolaric hyperglycemic syndrome.
Okay, so you should use the hyperosmolar
Glycemic
hyperglycemic
syndrome.
state, not the non-ketotic anymore. Okay, because every time they may not have ketos, they may not be non-ketotic. Another thing is that you have not mentioned the potassium in your report. So is potassium important, and how would you manage according to potassium levels? Is it important?
Yes, ma'am, potassium is important, but first, if potassium hyperkalemia is present, then first we have to manage the hyperkalemia, and then we will go to the glucose hyperglycemic management. Normokalemia and hyperkalemia, then we hypokalemia. Then we will go with the insulin with the potassium.
Judges in the mic, please. In the mic.
You are giving intravenous insulin. You have to give for managing the hyperglycemia. What does it do to the potassium?
Potassium will reduce, and then if it is
why would it reduce? Which potassium would reduce?
Intracellular potassium will reduce.
Potassium shift, there would be intracellular shift of
Shift
potassium.
will be there. And potassium hypokalemia will be there, then we won't give insulin. We will do the fluid management of the patient.
The last question from Dr.
So the 2 points has been said by Nilanjan sir. One is calculation of sodium level. That was not hyponatremia. You should set it a corrected sodium level for glucose level. Other artifact may be there, that is a theoretical. Second is, madam, practical question, how to manage. So whenever you are managing anything with insulin, always predict what will happen with insulin. So always start, in case of hypokalemia, first the potassium replacement, don't start insulin. My takeaway message is, in hyperosmolar, hyperglycemic, you will have a spectrum of movement disorder, starting from seizures, focal seizures, chorea, athetoid, or even a hemibalismus. So keep these things in mind. They can present as a red herring for diabetes. Okay? Thank you.
Thank you, judges. Thank you, Dr. Naushi. We move on to the second presenter for the PGT session. A big round of applause for our first presenter of the day. And we have a wonderful audience this morning, this winter morning at Kushalpalli. Dr. Alamgir, who is another DNB Medicine PGT at Devan Mahatma Government Medical College. And Dr. Alamgir will be talking about his PG dissertation, the initial findings of his PG dissertation. Dr. Alamgir. क्या हुआ क्या हुआ
Good morning, respected judges, my seniors, my teachers,
हो गया
my colleague.
presenter view में
Today,
presenter
myself Dr. Alamgir. Today my topic is a study of liver disorder in patient with type 2 diabetes in a tertiary care hospital. This is also my thesis topic in postgraduate training. Aims and objectives. Aims: to study the different types of liver disorder in patient with type 2 diabetes in a tertiary care hospital, Devan Mahatma Government Medical College. Objective: to study the clinical profile of different liver disorder in patient with type 2 diabetes. Number 2, to associate the different liver disorder with type 2 diabetes. Methodology: a hospital-based prospective observational study. Study population: all known patients with type 2 diabetes or newly diagnosed diabetes patient admitted in medicine ward, male and female, and those patients are admitted in outpatient department of Devan Mahatma Medical College. Sample size: considering the reported prevalence of a study of hepatic steatosis in type 2 diabetes patient was 88%. That is sample size n equal to z alpha square pq by small l square. My total study population is 180. Inclusion criteria: all patients with type 2 diabetes with features suggestive of liver dysfunction who are willing to give consent are included in this party. Exclusion criteria: those patients are other than liver disease are my exclusion criteria. That is alcoholic patient, hepatitis B or C virus positive, or those patients are thalassemic or autoimmune hepatitis patient. Result: total 180 patient. Till now I collecting 50 patient. Out of 50 patient, aspartate transaminase level is more than 3 times is 6%. Alanine transaminase is more than 3% is 4%. Thrombocytopenia is 16%. And showing USG whole abdomen, liver show NAD 62%. Hepatomegaly 8%. Grade 1 fatty changes 14%. Hepatomegaly plus fatty liver 6%. And coarse ecotexture is 8%. And showing fibrosis, I show fibrosis by APRI score and fibrosis 4 score. And fibrosis is 16% and cirrhosis is 4% and controversial 1%. Discussion: the prevalence of liver enzyme increases is 6%, hepatomegaly is 8%, grade 1 fatty liver is 14%, thrombocytopenia is 16%, liver fibrosis is 16%, and cirrhosis is 4% in association with type 2 diabetes with varying frequency. The majority had grade 1 fatty liver and fibrosis rather than cirrhosis. Conclusion: liver disorder is an ignored complication of type 2 diabetes. Many type 2 diabetes patients will end up in cirrhosis of liver. USG is not adequate to make accurate diagnosis. Our data shows significant liver dysfunction in asymptomatic type 2 diabetes subject. Thank you.
Alamgir,
Yes, sir.
is this study a prospective or cross-sectional one?
Sir, actually this is prospective study.
So we should keep the basic terminology.
Sir,
So,
actually,
Can you explain what is the reason of such a low prevalence of steatohepatitis? You say raised enzyme. You should use technical term whenever we are giving at the end of the your presentation. Steatohepatitis only 6%.
yes, sir.
The maximum prevalence 14% of fatty liver, which is probably the least I have ever heard. I have ever heard.
Yes, sir.
You said in your initial prevalence prior to methodology 88%, and you are showing only 14%.
Yes, sir.
And third is, what was the reason to look for 4 parameters fibrosis index, that is FIB4 3.25? That very poor.
Sir. Sir, actually I show this by APRI score and fibrosis 4 score, and this score. Yes, sir. Sir, but
So that's maybe the reason he has got a lesser prevalence. He has not, I think, confirmed by ultrasonography or VCT in all cases. Yeah. Now, yeah, you have said that you have excluded alcoholics. How did you define alcoholic? Means differentiate alcoholism from social drinking. What criteria you used?
How much ml of alcohol per day, drinks per day? Do you have any criteria like that?
No,
to
sir.
exclude-
Total alcoholic patient.
As any teetotaler, any kind of alcohol intake.
Sorry.
Indira madam.
And another thing is, in your so you had patients in the OPD as well as the medicine ward.
Yes, ma'am.
But in the medicine ward, you excluded only those patients with alcoholic hepatitis and chronic hepatitis, viral hepatitis. But patients could have been admitted in the medicine ward for some other reasons, you know, that could impair the hepatic function. So I think your exclusion criteria should be wider.
Yes,
Okay, and another thing is, like Dr. Umesh has pointed out, your prevalence was only 4%, I think the grade 1 fatty liver, right?
Yes, ma'am.
But the fibroscan findings for fibrosis was 16%, so that is also very difficult to digest.
Sir, actually fibros are not available this year. That's why.
No, then the FIB4. By the FIB4, you are having 16%. That was somehow matching with the platelets also. Thrombocytopenia was also 16%. Anyway, why were you looking at thrombocytopenia? It's a good thing you look, but what is the reason?
What happens to platelets in liver dysfunction? Where are platelets produced, or the factors for platelets are produced from which place? The liver.
Liver, yes, sir.
Thrombopoietin is produced in the
Yes,
liver.
sir.
Thank you. Thank you, Dr. Alamgir.
Yes,
A big round of applause for Dr. Alamgir, our second presenter for the day. We quickly move on to the third presenter for the day, who is Dr. Ramamurthy, another DNB Medicine PGT at Devan Mahata Government Medical College. Our third presenter for the day, Dr. Ramamurthy. He'll be talking about an interesting case of diabetes.
Good morning to one and all. Good morning to one and all present here. Today we are going to see about the interesting case about the diabetic cranial neuropathy, which is more common in the diabetics in autonomic cranial neuropathies. But this case is little different. We'll see why the case is little different. A 56-year-old gentleman came from Jharkhand, presented with chief complaints of drooping of left eyelid for 15 days and double vision for 15 days. Patient was apparently normal 2 years back. Patient followed by patient complaints of dizziness and double vision of right eye, followed by diagnosed with type 2 diabetes. Patient is under regular medication. Subsequently, patient developed last 15 days left eye ptosis, which is acute in onset, complete ptosis with no diurnal and positional variation, double vision left eye for 15 days, right gaze without retroorbital pain. Past history, patient is known case of diabetes under regular medication, no history of systemic hypertension, coronary artery disease, seizure, bronchial asthma, malignancy. On general examination, patient is no wasting of temporalis muscle, patient is normotensive, normal rhythm, which is normal rhythm, normal volume, normal character, no radio delay, radiofemoral delay, no vessel wall thickening. The higher mental function within normal limits. On examination, on right side, patient having a pupil, normal signs, reactive to light, both direct and indirect reflex, and extraocular movements were full. On left side, patient having a round in size, 4 mm size, and reactive to light, sluggish, both direct and indirect reflex. Patient having a extraocular movement restricted on left side. We'll see the pictures and videos. Superior oblique, before we're going to confirm this is a third nerve also, we have to exclude fourth nerve by checking the superior oblique, patient looking down and looking for medially. On left side, patient having a vertical neutral gaze, patient having left eye complete ptosis. During the examination, patient having a right eye having a full ocular movement, and left eye having a restricted eye movement, except extraocular movements except lateral axis and superior oblique muscles. On neutral gaze, we can see the left eye complete ptosis. On right eye, patient having a light reflex, both direct right reflex is reactive to light. On left eye, patient having a sluggish reaction of direct right reflex. Rest CNS system within normal levels. We did investigation, patient having a fasting of 122 milligram, postprandial 224, slight hyperglycemic, HbA1c is not, slight high, spot urine less than 30, triglyceride 271 and LDL 84. We did neuroimaging, MR angiogram and MRI brain within normal limit, suggestive we rule out any aneurysm in the intracranial and infraction, ischemic CVA. My final diagnosis, partial pupil involvement of left third nerve, which involving left third nerve, which is a microscopic complication of the type 2 diabetes.
Dr. Ramamurthy, 1 minute to go.
Yes. And follow up. After 1 month, patient now left picture shows 70% improvement in the ptosis. And also patient having extraocular full, almost 90% improved, slight restriction present. Why not other site of lesion means third nerve palsy, pupil will be spared, but in this case patient pupil partially impaired. That means the classical, this is not classical presentation. So other possible site, nuclear lesions, the patient having a ptosis and bilateral pupil involvement there. Vesicular lesions, patient having along with third nerve palsy, Mint-Bennett syndrome, Weber, Benedict and Claudius syndrome will be present. Cavernous sinus means it should be involved sympathetic and V1, V2 of trigeminal nerves. Superior orbital pressure, either superior division or inferior division of the, along with 346 V1 should be involved. Orbital apex along with the 346 V1, second nerve also involved. So even though we are classically seeing in the case of the diabetic third nerve palsy, even up to 30% of people can be involved. So the people partially involved. So the partial pupil involvement, we should always rule out aneurysm. So that way we did a MRI and MR angiogram. Take a message, partial or complete involvement of third nerve palsy can happen uncommonly. So in that cases, we need a brain angiogram to rule out any aneurysm in the intracranial, especially in the subarachnoid space. Especially on follow-up, patient having ptosis and extraocular movements resolve spontaneously most of the time within 2 to 3 months with adequate control of the
Thank you, Dr. Ramamurthy. Judges, please.
Well, you said that this is predominantly a microangiopathic complication of diabetes, but when you come to the diabetic mononeuropathies, especially cranial neuropathies, what is the commonest etiology that has been mentioned in literature? First, is it unifactorial or multifactorial? And what are the common etiologies? Is it microangiopathy or something else?
So patient having a ischemic, microvascular ischemic changes, microvascular ischemic changes.
Microvascular ischemic changes. What evidence did you get of the microvascular ischemic changes?
So I didn't mention patient having a peripheral neuropathy also, sir. In
Association with
peripheral neuropathy.
And his glycated hemoglobin was only 7.2%. That was not very good also, but
yes.
not very bad.
Yes.
So could you relate that to this complication if you take it to be a complication of uncontrolled diabetes? 7.2 glycated hemoglobin having this sort of cranial neuropathy.
So we need to control a patient having a
Now, is it possible? Means the blood
No.
sugar is not too high. Its glycated
Yes, sir.
hemoglobin is not 10, 11, 12. It's
Yes.
only 7.2. Yes, we understand. You have to bring it down to under 6.5 or under 7. But can you explain this neuropathy, if you call it to be diabetic cranial neuropathy, to be due to diabetes alone, to the metabolic derangements alone?
So not diabetes alone, it is associated with metabolic syndrome and systemic hypertension also. Other comorbid conditions also creating a cranial or third nerve palsy apart from the diabetes.
In continuation to Sir's question, I would ask, what are the conditions that actually increases the chances of a microvascular complication in diabetes?
In that patient.
Yes, what are the risk factors that increases the chances of microvascular complications?
So patient,
One of them hypertension,
yes,
poor glycemic control, anything else?
dyslipidemia and smoking.
Apart from third nerve palsy, though this was not typical, as you said, there was a involvement of pupillary, which is usually sparing, I agree. There was a lateral rectus palsy also. Have you seen? There was a loss of adduction.
Yes.
Even in the last case you say, there resolution of ptosis, extraocular muscles, there was a still deficit. So so it is not isolated third nerve. Lateral rectus you forget. You showing the movement and it was still gone. Sixth nerve was.
Dr. Umesh has a wonderful, keen examination of the cases and all. Thank you, judges, and thank you, Dr. Ramamurthy, for that wonderful presentation. A big round of applause for Dr. Ramamurthy. That brings us to the end of the PGT session. I would request all the 3 PGTs to come to our photo booth for taking their participation certificates. The prizes will be announced during the inauguration. We have wonderful cash prizes for the first prize winner and also participation prizes for the other 2 participants. All the 3 PGTs to the right hand side of the stage. We quickly, and thank you judges, I can take your sheets and we can do the tabulation, or you can give us a consensus also. You want to give us a consensus, or you want us to tabulate? You can come down the stage and maybe finalize while we move on quickly to the next session. For the next session, we have on, which is the core diabetes session, and we promise we will put in pediatric diabetes also in our armamentarium. To chair the next session, we have please, judges could please give away the participation certificates to the presenters. Thank you. A big round of applause for our wonderful panel of judges also. We quickly move on to the next session, which will be chaired by Dr. Santosh Kujur. Dr. Santosh Kujur happens to be the Chief Medical Superintendent of South Eastern Railway Hospital, Adra, Purulia. Along with him, we have Dr. A.P. Mandal. Dr. A.P. Mandal is a very close associate, a senior pediatrician of Purulia town, has decades of experience and practice. And along with that, I would like to invite Dr. Rana Bhattacharya to please chair this session along with the 2 chairs for this session. And the speaker for this session is Dr. Kaushik Pandit. Dr. Kaushik Pandit is very senior endocrinologist from Kolkata, currently practicing as Wellview, also a researcher at the IPGMR Institute, and happens to be one of the main persons for the upcoming Endocrine Society of India National Conference to be held at Kolkata next year, the ESICON 2025. Dr. Kaushik Pandit.
Good morning, respected chairperson, sirs, my respected seniors in the audience, and dear friends. I always find this thing an onerous responsibility given by Pankaj for being invited in such a great gathering in a remote place, so well organized. Thank you, Pankaj. Well, the terminology of this session is very simple. I suspect my patient has type 1 diabetes. What should I do? I think in all of us, the answer is very simple. Put them on insulin and be done with it. Forget it. I wish life would have been as simple as that. But unfortunately, it's not so. Especially if Pankaj has asked this question, there has to be something else other than this simple answer. So what actually we really need to do? A lot. In fact, if you think this is type 1 diabetes, you have to do a lot. But the first thing first, we first have to establish that this is type 1 diabetes. And now, here comes the difficulty. Because establishing a diagnosis of type 1 diabetes is not very simple as it is believed to be. Because diabetes at a young age can have many causes, etiologies. And type 1 diabetes, of course, is the most important of them all, but that's not be all and end all. We can have something else apart from type 1 diabetes. Then how do you differentiate? How can you separate the grain from the chaff? Well, if you're like me, an old person, not very techno-savvy, then we go by the clinical parameters. The usual presentation, we all know that if they present with a ketoacidosis, young age, may or may not be family history, and very little with additional insults like infection, you know it is type 1 diabetes. But if you are very smart, like Pankaj, who is very techno-savvy, you have got access to so many options. Like you have got a very interesting and appropriate app, online app, which all of you can use very easy, where you just have to give some information, background information, and that calculates the probability of one particular type of diabetes. Like whether it is type 1 diabetes, whether it is maturity onset diabetes of the young, or MODY in short, which is basically presentation of something like type 2 diabetes in young, or it can be a genetic or monogenic forms of diabetes presenting mostly in very young, neonatal or very early adulthood, very early adolescence. This looks like a MODY calculator, online MODY calculator. You just have to give those age at diagnosis, sex, then currently treated with insulin, or so on and so forth, and that calculates the probability of having a MODY. If it is low chances of having MODY, then you have something like type 1 diabetes or something else, something like you have got an algorithm for that. In the same website, you find that you do it first, the MODY calculator. If the MODY calculator gives you a probability of having more than 10% or less than 10%. If it is more than 10%, you assume that this is MODY, whatever be the presentation, and you put them on some diagnostic genetic test which actually picks up the problem and tells you exactly what sort of MODY is this one. But like this particular situation where you are thinking that this is type 1 diabetes, in all probability this will be less than 10% of MODY probability, and there you have got two probabilities. Either it is classical type 1 diabetes or it is monogenic form of diabetes presenting very early. How can you calculate that one? You have got a monogenic diabetes risk score that also is based on some inputs. And based on that, you can actually dissect whether this is type 1 diabetes or monogenic forms of diabetes. So, to putting it short, it is easy to differentiate now with the access of your internet to categorize whether in a young onset diabetes, whether this is type 1, MODY, or monogenic forms of diabetes. For type 1 and type 2 diabetes, if we go into a little detail about it, and if you go into the genetics of it, the imputed genetic variants, or what is technically known as SNP, or single nucleotide polymorphisms, you'll notice that in type 1 diabetes, those SNPs are mostly, this is a Manhattan chart which charts out the probability of one particular disease with an association of an particular genetic imputation. You'll notice that in type 1 diabetes, most of the SNPs are in one particular area, that is HLA region of the chromosome, which is in chromosome 6. In contrast, you have got SNPs for type 2 diabetes, which are all throughout all 22 genes. I'm not talking about the X or Y, but all 22 other genes are full with imputed genetic variants for type 2 diabetes. So, if you find a genetic variant which is on chromosome 6, you know that you are probably dealing with type 1. So, now with the current development of technology, with the access of technology, or maybe in near future, it may be much easier than it is today to differentiate between type 1 and type 2. And of course, you have got other clinical parameters to fall back on. For neonatal and infantile diabetes, I need not go into the detail, just to say that there are many genes which have been very critically found to be strongly associated with the development of diabetes. And you have got presentation from all over the world, including a very small one from our group, and that gives you type 1 genetic risk scores, which varies on the type of autoimmunity, the type of genetic changes that is seen in that particular ethnicity. And of course, it is different in different regions of the world, and fortunately you have got one made for our regions as well. So that's, in short, how we can be getting into a diagnosis of type 1 diabetes. So let's assume that you have diagnosed this particular patient, a young boy, to have type 1 diabetes. Now, what you really need to do? Honestly, your hands are full. You have to do a lot. After establishing the diagnosis, you of course have to focus on the type of the hyperglycemia that needs to be taken care of. You can think of giving a multiple subcutaneous insulin injection, which is still the standard in our country, but not so in western part of the world, where people fall back on and swear on, so to say, on the insulin pump, which certainly gives a much, much better result, no doubt about that. So you'll have to decide whether you're going to put the person on MSII or insulin pump. Then how are you going to monitor? Is it by hemoglobin A1C or by the standard home monitoring, which is in short known as self-monitoring blood glucose, or SMBG, or the newest kid on the block, what is known as a continuous glucose monitoring, CGM. And based on that, you have got sort of targets. I mean, on the left side of the you can see in yesteryears it was only SMBG. Then we are falling back on the HbA1c, and then probably now we are on CGM. If CGM is available, probably that's best, because that gives you the best idea of how the sugar is behaving throughout the day, at what point of time, or what is the percentage when it is much up or much down, which is certainly not desirable. Both are not desirable, and how to set that right. It's much easier. So keeping that point in mind, then when that point is taken care of, then you have to think about nutritional management. Of course, I cannot go into the detail of this one, but at this point of time, I just want to remind you that you are not dealing with merely diabetes alone. You are also dealing with a growing kid. So the nutritional management of that one has to be taken into account as well. And exercise, of course, needs a little bit of mention. You have to, as a physician, prevent complications, including the real complications, the dreaded complications like diabetic ketoacidosis or hyperosmolar state, or even much commoner, hypoglycemia. How to do that one? I mean, you know that people with the type 1 diabetes suffer from hyperglycemia and hypoglycemia much more frequently than otherwise in a type 2 diabetes situation. A very important part of the treatment is diabetes education. Very, very important, in the sense that you have to empower your patients or the caregiver as to how to manage this. You cannot manage, of course. This is a day in, day out affair, and you have to make your patients and the caregivers, the family, have to understand how to manage hyperglycemia, how do they understand hypoglycemia, what to do about hypoglycemia, and so on and so forth. So this empowerment is extremely important, and of course, it has to be culturally adapted. Very important aspect, in contrast to type 2 diabetes, you have to think about psychosocial aspects and psychosocial supports, because they are the growing kids with a very tender mind. And you have to address the problem of diabetes identity, diabetes risk, and the diabetes stress. We also have to think about the mental and the sexual health of that kid, because it's changing every day. We definitely have to let the patient and the caregiver know what is the sick day management. The kids, in contrast to type 2 diabetes who are adults, are either preschoolers or schoolgoers. How do you manage that one? At what point of time they have to go to school? How can you adapt your diabetes treatment protocol into that schoolgoer? How to communicate with the school authorities? What special privileges need to be given to those that particular person? And we, of course, have to think about Ramadan or other causes of fasting, and above all, probably you'll also have to deliver this thing in a resource-poor setting like in our country. So it's not an easy task. Certainly not as easy a task in treating type 2 diabetes. So barring that, if I'm allowed a little bit of time to go ahead, if we talk about a bit about stages of type 1 diabetes. Type 1 diabetes also does not happen on overnight. It happens over a time. Unfortunately, we don't recognize that, because we really do not have the option of going for testing at an earlier phase. Like type 2 diabetes, they also develop this thing, hyperglycemia, over time, but one particular day it explodes like a volcano, and they get admitted in hospital. But if you are careful, if you following up one particular, say, person who is have got a proneness to develop type 1 diabetes, we can come to that a little later, you will know that type 1 diabetes also passes through various stages, stage 1, stage 2, stage 3, and ultimately they become diabetes. And stage 1, it's sort of where the immunity is taking over, the autoimmunity is destroying the pancreas and the pancreatic beta cells. In stage 2, the pancreatic beta cells reserve is going down and the sugar is getting a little up. And if you can diagnose them at that point of time, it's better, because there are options to prevent some problems at that point of time, or at least delay the development of type 1 diabetes in this particular person. And we must also remember, it's not merely the autoantigens that we talk about. There are now hybrid insulin peptides that are present in the pancreas, which are now believed to be the number 1 autoantigens. This thing, the standard autoantigens that we know about, that we take help of or we use, are the GAT65 antigen, the anti-insulin antibody, anti-IA2 antibody, and anti-zinc T8 antibody, which is the newest lead and probably gives you the maximum specificity. And I probably do not need to tell you that more than one antibody positivity, it gives you much higher chances of diagnosis. So only one positivity may not be completely aligned with the diagnosis of diabetes. And there also, we must also remember that various autoantigens that we know of, they are mostly intracellular, but there are some extracellular aspects or extracellular domains of those, like say ZNT8 or IA2, where these extracellular domains, the autoantibody against those extracellular domains are much more specific. We cannot go into the detail of this one, but this much we know, that at the initial phases, almost all the antibodies are fine, especially the GAT65 antibody, but with time, there is a change in the titer of the antibodies with time, and as you can see that here, oh, it's not working. Anyway, with time, the antibody levels also increases or decreases, and you know that anti-insulin antibody probably is the one which goes off last. Okay. And if you are careful and go for at least 2 antibodies, then probably it is more important that you go test for GAD antibody, IA2 antibody, and ZNT8 antibody. And if all 3 are positive, you are almost sure that this person will develop type 1 diabetes in future, even if it is not there right now. And that's what is seen from that study. And within 6 years, almost nearly 50% of them develop diabetes, and with time, by time 10 years or so, almost everybody develops type 2 diabetes if there is multiple autoantibodies that are available. This also gives us an opportunity to think that if somebody is not having diabetes right now, a young boy or girl, and having antibody, you have got the option of prevention. You can prevent diabetes in such a situation by giving some options, like some methodology. You have got the prediction risk done by, say, some special HLA typing and family history. And with an HLA typing and family history, you can probably predict much more in a better way to find out who can develop type 1 diabetes in that particular family. You have got an option of preventing that one, or at least delay the development of type 1 diabetes in such situation by giving some anti-monoclonal antibody against the regulatory T cells, which act by changing the scenario in that the pancreatic beta cells, and it goes by the monoclonal antibody, which is commercially available right now, known as teplizumab. And teplizumab has shown the benefit not only preventing, but even if you give to a recently diagnosed type 1 diabetes, that diabetes probably vanishes, at least vanishes for some time, not in all, but in some. And for crystal ball gazing, if you're thinking about, only 1 or 2 slides, so probably I can be given 1 more minute. You can think of giving or having beta cell encapsulation, which are available right now. I mean, not commercially in our country, but it's in some other country. That yes, I know the time is up. You can think of having the pancreatic beta cells being encapsulated, and that encapsulation can be nano-encapsulated, where the T cells or the antibodies cannot have an ingress, so the pancreatic beta cells are surviving and will continue to produce insulin. And you can definitely have all those, which is technically possible and can be given in type 1 diabetes to have a fruitful life without having the risk of those cells being destroyed. You now have got a commercially available pancreatic beta cell therapy, which is commercially available, which is the trade name of this one is Lantidra, which is basically a pancreatic beta cell derived from the cadaver, which is changed, and this Cell Trans company has already introduced that one. So probably in future, not me, some of you who may be typing type 1 diabetes will be using either Lantidra or something else closer to that one. I'll stop here and read my question. Thank you very much.
Thank you, Dr. Kaushik Pandit, for your wonderful presentation. Two quick questions because we are running quite late. So, two questions allowed.
Dr. Anirban Mujumdar has a question.
Anirban, please. Yeah.
Mike.
Can someone give? Oh.
Okay, Kaushik, thank you very much. I was fascinated by your lecture, and for last few months since we come to know that type 1 stage Y, stage B, stage 3, I was thinking about this. Now, my question is that we know in our cohort, say I have 50 or 60 type 1 diabetes, we know the antibody status of this, though at the time of diagnosis, we know in our cohort how many of them actually the autoantibody positive, how many of them not antibody positive. So do you think it is practically feasible to screen the family members of those who are antibody positive and convincing them to take the teclistamab in our social scenario? How you visualize it?
Thank you very much. I mean, questions are good. Questions basically mean if there is no question, you feel that either people are not interested in your talk, or they have understood everything, or they haven't understood nothing. Something in between is good. So thank you, Anirbanda, for asking this question. And that's a very logical question. In fact, that's the thinking in the Western world. If your patient is known to have type 1 diabetes, it is your responsibility to put all of their first degree relatives, siblings, parents, to undergo the testing to find out what is their risk of developing type 1 diabetes. And if they have a higher risk by the app that I have shown, then it is your responsibility to let them know that you have got options to prevent or at least delay development type 1 diabetes, especially in siblings, which have been established. And one of the person who has written this review is available here. He may be a better person to answer your questions on this regard, Dr. Saptarshi Bhattacharya, who has published a review on this particular teplizumab, which has been found to have an beneficial effect in preventing type 1 diabetes or delaying the development of type 1 diabetes or making one recently developed type 1 diabetes vanish the diabetes at least for some period of time. So that's absolutely a logical way of thinking of treating type 1 diabetes and their families.
Thank you. Thank you, Dr. Pandit. So we'll end the session here on behalf of the co-chairperson. We thank the
A big
speaker.
round of applause, and I request Dr. Kaushik Pandit to the photo booth, please. And I request the chairpersons to felicitate our speaker for the day. Quickly moving on to our next session. The chairpersons for the next session will be Dr. Sumanto Das, who is a pediatrician, a very promising pediatrician from Purulia town, and Dr. Amit Das, who also is another promising pediatrician from the town. Along with that, we will have as a chairperson Dr. Govindo Banerjee, who is medical officer, Lodurka PHC, and a very close junior, Dr. Saptarshi Banerjee. Dr. Saptarshi. And that talk is to be delivered by Professor Nilanjan Sengupta sir, Professor and Head Department of Endocrinology, IPGMER, Kolkata.
Good afternoon, everyone. Welcome to the next wonderful session by Professor Nilanjan Sengupta. Use this. So our next topic is 8-year-old boy with obesity and metabolic syndrome approach. So it's over to you, Professor Nilanjan Sengupta.
I can use this. Yeah. Respected chairpersons, dear friends, at the outset I thank Dr. Pankaj Singhania for organizing this wonderful conference at a very beautiful place and inviting me out here. I will start with a trivia question for the audience to answer. Do you know who Pesto is? He is an internet sensation these days. Anybody from the juniors, do you know Pesto? You don't seem to know. Okay. He is actually an emperor penguin chick. He's a chick-minded. In the Sea Life Melbourne Aquarium, he was born on 30th January 2024. He has now entered puberty, has molted, and has the first swim also a few days back. In September 2024, he weighed 22 kilos. Generally, adult penguins weigh around 9 to 18 kgs. He was a penguin chick weighing 22 kilos, and Pesto weighed more than his 2 foster parents combined. And in September, he was eating around 25 to 32 fish a day. With this, we come to our brass tacks evaluation of childhood obesity. We have a child, 8-year-old child with metabolic syndrome. So our duty would be to define overweight, obesity, and metabolic syndrome, because we cannot extrapolate the adult definitions in the pediatric age group. We have to quantify the degree of adiposity and, of course, go for comorbidity screening and finding out the etiology. So how do we define obesity in children? We use the weight for height or weight for length charts, and when it is more than equal to 3 standard deviation, we define obesity. Now, for classification, we cannot use actually BMI in the pediatric age group, because in the growing children, BMI is something very dynamic, because it is contributed by the growing muscle mass, growing bone mass, as well as the fat mass. So we have to fall back upon BMI percentile rather than the absolute BMI value, and a BMI percentile over 95th is looked upon as obesity, and then depending upon the BMI percentage or percentile, it can be further classified into class 1, 2, and 3 obesity. And these are the BMI charts that are used for defining and quantifying obesity. So we have defined that this child, 8-year-old child, is indeed obese. Now, obesity with metabolic syndrome. Now, the problem comes that we do not have any definition or criteria for metabolic syndrome in persons less than 10 years of age. But I think that is not a major handicap, because to me, metabolic syndrome is no disease, but a constellation of risk factors. So whether you define metabolic syndrome or not, in an obese individual, whether adult or a child, you have to search for the risk factors and address those risk factors adequately. However, the International Diabetes Federation allows us to define metabolic syndrome in children at 10 to 16 years of age if they have abdominal obesity with 2 or more of the following, that is hypertriglyceridemia, HDL cholesterol, fasting hyperglycemia, and hypertension. So after we have understood that this child is indeed obese with maybe metabolic syndrome or risk factors, we have to find out the cause. Yes, in most of the cases, it would be simple obesity or exogenous obesity, but as physicians, endocrinologists, or pediatricians, we have to find out the rare causes of endogenous obesity, which though are less than 10%, but this we have to find out. So the causes of endogenous obesity are all well known and more or less similar to that in adults. But when it comes to endogenous obesity, we have to think of certain endocrine disorders, notably Cushing's disease, or including exogenous Cushing syndrome. Then certain genetic disorders like Prader-Willi, Bardet-Biedl, Cohen syndrome, and also very rare diseases of, say, leptin deficiency or leptin resistance. Not to forget drug-induced obesity. I've mentioned about glucocorticoids, but certain anti-epileptics can also lead to weight gain, as well as antipsychotics. So the clinical evaluation is the standard process of history taking and examination will be directed, number one, to confirm a clinical impression of obesity. Number two, to assess the grade of obesity, to have the severity, to find out any etiology, and also to find out the comorbidities. Of course, the dietary history would be very important, the history of physical activity. What is very important for children these days, again, is a fallout of technology. The negative fallout is the screen time. We have to inquire about the screen time, which actually an older physicians like many of us do not think that is important, but this has become indeed very important. And of course, drug history, pubertal staging is very important. Of course, this is an 8-year-old child, but obesity can be associated with an early puberty in some cases, and in some cases with delayed puberty too. And of course, we have to search for Cushingoid stigmata. And if there are any suggestions of any genetic syndrome like Bardet-Biedl syndrome, there will be typical phenotype, or in AHO phenotype, that is Albright hereditary osteodystrophy, that is short stature, moon faces, obesity, and so on and so forth. Now, what are the red flag signs of obesity? That is rapid weight gain, early onset obesity, behavioral problems, history of intake of glucocorticoids, eating disorders, short stature with poor linear growth, evidences of hypogonadism in a peripubertal child, any dysmorphism, any visual abnormalities, and developmental delay. This, if any of these are present, this should alert you to think whether you are thinking of some causes of endogenous obesity. So methods to measure adiposity, I have mentioned about the inherent disadvantage of measuring BMI. Rather, we should go for waist circumference, and waist circumference in these children can be an important predictor of visceral adiposity, and 90th percentile is usually taken as the cutoff. So these are the 70th percentile child for the waist circumference values, which you can use. Going further, you can also use dual energy X-ray absorptiometry for quantifying body fat. Also, you can use the bioelectrical impedance analysis. After having quantifying obesity, one should go for comorbidity screening, and this child has obesity with metabolic syndrome. So the first thing we should look at is the blood pressure, whether the child is suffering from hypertension. We have to use an appropriate sized pediatric cuff, and again, you cannot extrapolate the adult values for defining hypertension in children. Usually it is taken as more than 90th percentile for that age and gender. Now, in the pediatric age group, you have to factor in gender in having the normative values of blood pressure, which generally is not done in the adult population. And that's how you stage hypertension. Then screening for diabetes, you can do the oral glucose tolerance test to see where the child stands, whether the child is having normoglycemia or having IGT or IFG or frank diabetes. And if you are using glucose, the glucose dose is 1.75 milligram per kg of body weight. That is up to 40 kg body weight, you have to use this 1.75 milligram per kg of body weight. You cannot straight away give the 75 gram of anhydrous glucose as we use in adults, but the cutoffs are similar to in adults. Now, MASLD screening is also very important, but two words of caution. In the adult population, we screen for MASLD either by the FIB-4 score or the vibration-controlled transient elastography, but the FIB-4 score or some other scores are validated usually in the adult population, and if you use VCTE, this also is validated in persons aged above 18. So this is one suggestions, the thresholds of AST and ALT, which can suggest some abnormalities or hepatic steatosis, and you can also fall back upon the conventional ultrasonography. So I think laboratory evaluation would be done not only to find out dyslipidemia, MASLD, or in appropriate cases in a little younger child, polycystic ovary syndrome, or other causes like Cushing's, hypothyroidism, pseudohypoparathyroidism, as dictated by clinical pointers. Coming to the last part, management of childhood obesity. Now, childhood obesity, especially simple obesity, is something which is better prevented than treated, because when it comes to treatment, many of the therapeutic strategies, apart from lifestyle measures, are not approved below an age threshold of 12 years. Most of the pharmacotherapeutic agents are not approved for use in children less than 12 years. Surgical therapy also, though can be done, but is preferable not to be undertaken till the child has crossed puberty, completed puberty and growth. So what will boils down is basically prevention of childhood obesity, and when it has occurred, basically this will constitute non-pharmacologic treatment of obesity, basically through lifestyle modification. So preventive strategies should start not only from infancy, but probably from the intrauterine life, optimizing maternal nutrition, because we know IUGR is associated with obesity and metabolic syndrome in later life. So you optimize maternal nutrition, exclusive breastfeeding till 6 months of age, avoid formula feed as much as possible. When at the time of weaning, give healthy foods, avoid adding extra sugar or sugary things in the diet, and avoid sugar-sweetened beverages, and when the child is able to eat, encourage more giving whole fruits than fruit juices. And most importantly, promote responsive feeding. Do not overfeed the students, children. Now is the role of parents. It's very important. Healthy dietary practices, encouraging physical activity, decreasing screen time. Role of school is also very important, for which the teachers, the class teachers and the subject teachers need to be sensitized. The school should not be vending, soft drinks in the midday meal or whatever afternoon snack or tiffin is provided. That should be a healthy one, having fruits, salads, vegetables, rather than cakes and sweets like that. And daily physical activity should be encouraged through physical education classes, as also during the recess or like that. So we all know the benefits of exercise in preventing and treating obesity, metabolic syndrome, and related disorders. This is as applicable in children as in adults. And therefore, to summarize, in a child of around 8 years, that is, this is the 5 to 17 years age group, they should be encouraged to undertake at least 1 hour of physical activity daily, and that should be at least 3 days a week. The screen time should be as little as possible. The recreational screen time should be bare minimum. At 2 years of age, the screen time should be 0. At 10 to 18 years, maybe up to 2 years, 2 hours maximal screen time, which will include the educational screen time also. Well, it's not moving. Kindly help. Oh, right. So that's screen time. Then dietary management. Dietary management, the preventive dietary management should start from day 1 of life. But however, if you want to go for a weight-reducing diet, calorie restriction is generally not recommended before 6 years of age. But after that, you can go for cautious calorie requirements. And these are the nutrient requirements for Indians. And this should be a good guide. And the 5-2-1-0 rule is a very handy thumb rule for dealing with these children. 5 servings of fruits and vegetables daily, less than 2 hours of screen time, at least 1 hour of physical activity, and 0 intake of sugar-sweetened beverages. So regarding the pharmacotherapy for obesity, I think pharmacotherapy options are available only beyond the age of 12. So in this 8-year-old child, we have very limited options. And you see the drugs that are available may be orlistat, liraglutide, semaglutide, and others. We have very encouraging data about 2 upcoming molecules, that is tirzepatide and retatrutide. Retatrutide is yet to come. Tirzepatide will be available in the near future, but then initially approval would be in adult patients, but in future we would maybe using them in children also, but beyond 12 years of age. Surgical management of obesity. Now the recommendation is that surgical management may be offered in children older than 12 years of age with class 2 obesity, and completion of puberty or growth is no longer a contraindication to bariatric surgery. But having said so, I think in children, bariatric surgery should be the last resort option, because I feel the treatment of exogenous obesity in any individual is basically, lifestyle modification, and any other therapeutic option is an adjunct. I think this is the last slide. The screen has gone off. There are challenges in managing obesity and metabolic syndrome in an 8-year-old child. First, defining obesity, because you cannot use the adult definitions. Defining metabolic syndrome, below 10 years, you do not have any definition. And the therapeutic challenge, that is, many of the therapeutic modalities cannot be used in a child less than 12 years. So it is better prevented than treated. Thank you.
Thank you, sir, for such a nice presentation. Now it's time for discussion. If anyone have any question, please.
Any questions regarding this childhood obesity issue?
So I think we see a very common situation. There is a child, family history of diabetes, lots of acanthosis, obese, and metformin is very commonly prescribed. So what is your take on that? So whether these children can actually be given metformin, it's not a recommended medication as such for obesity, but it's a very common practice. What's your take?
It's a very common practice. I don't know whether this helps in those children. Metformin should not be used, repeat, not as an anti-obesity medication. If the patient has acanthosis nigricans and the clinician is satisfied that the patient is having insulin resistance, then he or she may be justified in using metformin as an insulin sensitizer, but I think here that is just a symptomatic treatment. Addressing the root cause, optimizing body weight will improve insulin sensitivity much more than just giving metformin or any other agent that will improve insulin sensitivity. So I think any pharmacotherapy is rather an adjunctive one, maybe to help, to encourage, but the main problem, that's the moot problem, because the essential treatment would be therapeutic lifestyle change, which is much easier to deliberate upon, but much difficult to carry out in real life.
Thank you, sir.
Thank you.
We are calling off the session. Thank you.
Thank you, Nilanjan sir, and please come to the photo booth. And we request the judges, chairpersons to felicitate our speaker, Professor Nilanjan Sengupta sir. And quickly moving on to the next session, there is a slight shuffling from the schedule that you might be looking at to fit into our schedule of traveling of our guests. The next talk will be on sexual dysfunction in diabetes. To chair this session, may I request Dr. Kamal Kumar Narsaria, Dr. Minal Kanti Rajak, and Dr. R.N. Das to please be on stage. Dr. Kamal Narsaria is a very promising gynecologist from town. Dr. R.N. Das seems to be a very senior gynecologist, and maybe has, many of us are born by his virtue. And Dr. M.K. Rajak is a Block Medical Officer of Health, Custard, BPHC, and a very close associate and friend. Dr. Saptarshi.
The session of this the topic of this session is sexual dysfunction and diabetes. The speaker is Dr. Saptarshi Bhattacharya.
Very good afternoon to all of you. So thank you, Pankaj, for calling me. So I am connected to Purulia for a very long time. So I'm a student of Purulia. I was a student of Purulia Ramakrishna Mission. So it's good to come back here. And so we will be talking about sexual dysfunction in diabetes. So there are so many things to deal with in diabetes. So anybody hardly discusses about it. And more so, if we are talking about, so most of the people will think that this is sexual dysfunction means it's going to be erectile dysfunction in males. So that is again not always right. So equally important and even more neglected is female sexual dysfunction. So just to make a change, so I will start my presentation with a case of female sexual dysfunction, and then we will have two cases, 2-3 cases related to male sexual dysfunction. So I've kept it case-based so that it becomes more practical. And we need to talk definitely, because if you look into the prevalence from this meta-analysis or systematic review, so it's like close to 1/3 of males and close to like 3/5 of females actually do have satisfy the criteria for sexual dysfunction. So if we go into this case, so the slides are slightly jumbled. 36-year-old lady, type 2 diabetes, family is more or less complete, had GDM, went on to develop diabetes, BMI is 32, has PCOS, H1 is 10.4, on 3 OHAs, tell me certain OCPs. So what is the typical journey of people with diabetes and sexual dysfunction? As such, with sexual dysfunction, so just to be on the lighter side, so with teenage, we start with kuch kuch hota hai, then in 20s, it's pehla nisha, then in 30s, it can be dhoom macha de, but again, in cases like this, it can be meri adhuri kahani also. In 40s, it's kabhi khushi kabhi gum, and in 50s, kal hona ho. Thanks to Sunetra, and because she had presented this sequence of slides in one of our presentation in SpeedCon, so I told her that I'm going to borrow it for you because it was actually nice. So having said that, if we move on to the topic, so 7 in 10, we already saw that there is 7 in 10 females have actually sexual dysfunction in diabetes. And what is the definition? So is a group of conditions characterized by persistent or recurrent problems with sexual response, desire, orgasm, or pain during sexual activity. So there are again 3 broad groups. One is female sexual interest or arousal disorders, another is female orgasmic disorders, and again, the last one is genitopelvic pain or penetration disorders. So each of these has definite diagnostic criteria, and usually what you need to remember, somebody should be having it at least for a 6 months consistent symptoms, then only we'll label it as a case of sexual dysfunction. Again, so there are causes. So there are female sexual interest or arousal disorder causes which can be related to mood or anxiety. Female orgasmic disorder causes, again, something which actually is more related to erectile dysfunction. So can microvasculopathy, which is very important in diabetes, plays a role. And there can be genitopelvic pain and penetration disorder. Most of our patients with type 2 diabetes are nowadays on SGLT2 inhibitors. So you really need to be careful about whether somebody is having a candidal vaginal infection or not. So these are things which you need to be careful about, and you should take a proper history. And what is more important is that it should be open-ended and non-judgmental, and don't make any assumptions about or comments about their sexual preference or how you should not be, you should be having a neutral view about the sexual perception of the person, be it a male, be it a female. So again, there are definite diagnostic algorithms, so I'm not going to go into the details of it, but I think you should, this is not often discussed in India, but actually we don't have that drug as of now in India, but US FDA has approved a drug called flibanserin, which is recommended for premenopausal female sexual dysfunction. So if we come back to our case, what we see is that she has multiple problems. Obviously, she has issues related to general health. HbA1c is high. She is on SGLT2 inhibitors. Even sometimes OCPs can have a negative impact. She is on SGLT2 inhibitor, was found to have vulvovaginal candidiasis. She has issues related to mood and also some amount of depressive symptoms, and also concerns about her appearance. So all these things we need to address collectively. Psychological modalities are the mainstay of therapy. Then you need to look into the medical aspects also. And in certain cases, you can consider vaginal estrogen, usually recommended in postmenopausal women who have vaginal dryness, or optimal antidepressants. And flibanserin, as of now not available in India, can be also considered if it becomes available. So now we move on to male sexual dysfunction. So again, there are three broad groups. One is erectile dysfunction, one is diminished libido, and the third is abnormal ejaculation. Usually, most of the cases, it will be premature ejaculation. So if we now move on to a case, so 39-year-old software professional, ED for last 2 months, married for 2 years, 2 children aged 6 years and 2 years, diagnosed with diabetes just 2 months back. So if we now take the chance to define male erectile dysfunction, that is ED is defined as the inability to attain or maintain penile erection sufficient for satisfactory sexual performance. Again, it involves a detailed sexual history as well as medical history, and you need to have questions about onset, duration, progression, quality of erections, frequency of dysfunction, and again the setting, whether it's with one partner, whether it's with all the partners. So all these things do become important. So if we have a closer look at this particular gentleman, what we see is onset, diabetes is not that long, it's again 2 months. So onset was also 2 months back, the symptoms also came. Diabetes is 6 months, onset of symptoms was 2 months. It's intermittent, partial erection, nocturnal erections were present, normal libido. Again, so if you have hypogonadism, testosterone is low, a very important point, the libido will go down. So if it's an intermittent partial erectile dysfunction, and a person is, and there is a history of stress also, so you need to think more about psychogenic. So there are causes which can be psychogenic, there can be causes which are actually organic. So with this background, he was found to have psychogenic erectile dysfunction, again the commonest cause of erectile dysfunction. So there is no apparent organic cause. Still, diabetes will play a role. Even we know that in pre-diabetes also there can be erectile dysfunction because autonomic dysfunction can set in. And even in these cases also, as per requirement, you can consider phosphodiesterase inhibitor. But again, primarily the treatment has to be through psychosexual counseling for this particular patient. So this is the approach which was recommended by European Neurological Association. So again, you need to take a proper history, identify sexual problems other than ED, identify common causes of ED, irreversible or identify the reversible risk factors for ED, and you look into do a proper physical examination, and if required, you can consider this test. You can do a fasting plasma glucose, HbA1c, lipid profile, because there is a strong connection with cardiovascular disease, has to be done in all cases of erectile dysfunction. Testosterone total, it has to be a morning sample, so you should not be taking your samples for testosterone from a person at 2 p.m. or 3 p.m. whenever the person is coming to clinic. It has a diurnal variation, the values will naturally go down, so the sample has to be a morning sample. Also, if you see that the testosterone is low, you can also get a LH, FSH and prolactin. Other tests like thyroid function tests, CBC, KFT and LFT are also optional. So if we now go back to this case, how to approach this patient. So if we revisit the history, again, most of the cases you will be able to diagnose through history only. So libido was normal, so we are expecting that testosterone won't be very low. Nocturnal erections were decreased, same partner, no relationship issues or performance anxiety. So it's suggestive, if you see the difference, so it's suggestive more towards an organic disorder versus the psychological aspects which were associated last time. So physical examination, including genital examination, was mostly normal. Investigations were also mostly normal. And in these cases, actually, you can consider phosphodiesterase inhibitors. So there are 3 mainly commonly used: sildenafil, vardenafil, and tadalafil. We have avanafil also, which is now available. So something which is often missed is that if somebody is having a fatty meal and takes a sildenafil after that, so that interferes with absorption. So if somebody has a food, a very, very practical point, fatty food, and tadalafil and vardenafil, it does not get that much affected. Avanafil also does not get that much affected. But if somebody has been prescribed sildenafil and if it's after a fatty food, it won't get absorbed. So then there has to be a gap of at least 3 to 4 hours for proper absorption. So there is a side effect of myalgia also, which is quite common. Anybody, why myalgia occurs with tadalafil or sildenafil? So it's a phosphodiesterase inhibitor. So there are some overlaps with other types of phosphodiesterase also. Muscle is rich in phosphodiesterase 11. So that is a cause for myalgia. If it's a common side effect, also headache, flushing, vision problems can also occur. So there is avanafil is a comparatively newer one. It's better absorbed, slightly more effective than tadalafil. And there is, we often see a prescription of low dose of tadalafil. So some people actually don't even know whom to approach for a problem of sexual dysfunction. So just to make you aware that endocrinologists do treat sexual dysfunction other than urologists. So might be in some cases they might be more qualified because they have an associated problem with diabetes or some hormonal disorders accompanied with it. So there are meta-analysis and systematic reviews which suggest that low dose of tadalafil, 2.5 mg or 5 mg. So you are not giving it, so most of the prescriptions tend to be on demand. So before relationship, 30 minutes or 1 hour before that. But even if we give low dose of tadalafil, 2.5 mg or 5 mg, there are studies from 3 to 6 months. So there is actually a benefit in erectile dysfunction. So it actually does work in my practice, some of my patients are receiving and the response is quite good, better than just on-demand tadalafil. Another very important area is that if somebody is having an organic erectile dysfunction, so you need to rule out cardiovascular dysfunction. So it's again a surrogate marker of cardiovascular dysfunction. So it's all related to the blood flow and inflammation, which is partly responsible. So you really need to be careful that if such a patient should have a thorough and proper evaluation of cardiovascular dysfunction. So there is a huge overlap. So inflammatory pathways, endothelial dysfunction. So they all are interconnected and cause maybe clinical or subclinical or microvascular atherosclerosis, or endothelial dysfunction, which can cause these problems. So in such a case, you actually, if there are no risk factors, you can straight away go for therapy. But if you are planning to give phosphodiesterase inhibitor and you are not very sure that whether there is an underlying cardiac risk also, you can consider a stress test. High-risk cases should actually undergo an evaluation the timer is not working. So should undergo a cardiovascular evaluation. So in this case, so the ED was progressive for 8 months. Testosterone was slightly, so I think this is, so okay. So in this case, we control diabetes, we give a phosphodiesterase inhibitor, we did psychosocial counseling, and the person did enroll. So last case, I'll go through it very briefly. 42-year-old privately employed gentleman, weight is 96 kg, BMI is 34, family history of diabetes and cardiovascular disease, HbA1c is 8.3, dyslipidemia and MASLD. So in this case, what you see is testosterone is low and LH and FSH is low. So there is this entity which is called functional hypogonadotropic hypogonadism. Some of you might be aware, some of you might not be aware. It's usually, we are not looking at a structural abnormality in the pituitary in such cases. So it's not like a hypopituitarism or rest of the hormone axis are also going to get affected, say from a tumor or some mass lesion. But again, so this is related to metabolic dysfunction, obesity, dyslipidemia, cardiovascular risk factors only. So in this case, the diagnosis was functional hypogonadotropic hypogonadism. So testosterone supplementation does have a role. So we had in NEGM, we had a publication whether testosterone, there was a publication last year in 2024 where 2 arms were studied. One received testosterone, that was a transdermal preparation, the other did not receive, and it was non-inferior in terms of cardiovascular safety. So it's safe. So some people might have doubts about the efficacy, about the safety of testosterone supplementation. So it's safe. So there are cutoffs. So if the testosterone value is less than 250 or so, and the person is symptomatic, you can consider testosterone supplementation. But you have to be very careful if the person is planning a family. Testosterone is going to bring down the, alter the semen parameters. So in this case, we might have to think of alternative treatments like HCG and FSH. Will really require an endocrine consultation, not a urology consultation at this point of time. And the person is not a candidate for testosterone supplementation even if the testosterone is low and the person is symptomatic. So again, learning points from this is that testosterone, functional hypogonadism, getting an MRI is also plus minus, because most of the time we know that if there are no symptoms, no other hormones affected, even if you are not ordering an MRI, that's okay. Testosterone supplementation plus minus phosphodiesterase inhibitor again should, and as like in childhood obesity, also in adult obesity, lifestyle changes, choosing the right medication, maybe going for a GLP-1 analog, should be strongly considered in such cases. Finally, to summarize, sexual dysfunction in diabetes, it's very common, it's not talked about. Thanks to Pankaj for bringing up this topic. And if you are able to identify, so we are all slightly lost, somebody has come with sexual dysfunction, so we write a phosphodiesterase inhibitor and leave it at that, or get a testosterone evaluation. So you actually need to have a structured approach to all these cases, and most of these cases are actually treatable. So what if we are able to identify the right cases and approach these persons in the right way, so rather than kuch na kaho, we can move on to badhaiyo. Thank you very much for your patient listening. I hand it back to the chairperson.
Thank you, Saptarshida, for that.
Thank you, Dr. Saptarshi, for your nice informative discussion. Now from the audience, questions, please. Allowed only one. The time is short.
Please come to the mic over here. Please come to the mic. On that wonderful Bollywood tinged talk.
Thanks to Sunitra for that. They had done a similar presentation in SpeedCon.
Thank you. Just I want to ask that we know that PD5s are contraindicated in those receiving nitrates.
Right.
So in that case, what options do we have?
So if you are able to take off nitrate for around a week, we can start. But in those cases, if you need to look into the other parameters also. So if it's hypogonadism, so you can give testosterone if the person does not have any contraindication. Otherwise, psychosexual counseling. So if somebody actually is requiring nitrate, we can't give PD5 inhibitors. That is a contraindication.
Thank you, Saptarshida. I think we can end this session, and Saptarshida, please, to the photo booth for the photo session. A big round of applause for Dr. Saptarshi Bhattacharya, who has traveled all the way from Delhi to be with us. Quickly moving on to our next talk, which will be by another of our ex-station speakers. This will be on anti-obesity medications, and to chair the session, we have Dr. Shyamol Kanti Das. Dr. Shyamol Kanti Das is, Dr. Shyamol Kanti Das is the BMOH of another block, Pada Hospital, and I present this to you proudly that of the 20 blocks comprising Purulia district, we have BMOHs from around 15 blocks present in this gathering over here. A big round of applause for all our peripheral health workers who man our sessions. Along with that, we have Dr. Navonita Nath. Dr. Navonita Nath is another BMOH from Harmaddi, that's in the periphery towards Asansol, and we have Dr. Shubhro Pandey for this session, who is RMO cum clinical tutor in the Department of Medicine at Deven Mahato Government Medical College, Purulia. And for the talk, I'd like to invite Dr. Umesh Garg, who is quickly on stage already. Dr. Umesh Garg is senior endocrinologist from Agra, and one of the most tech-savvy persons among the endocrine groups that we have among the Endocrine Society of India, a very avid speaker and a very vocal person, vocal about the rights of doctors and what they should be doing. Dr. Umesh Garg and the hype and hope about anti-obesity medications. We are to move beyond nutrition and exercise.
Thank you, Pankaj and Akash, for inviting me. My primary qualification to talk on this is I am a person with obesity. So shall I have any hope or fall into the trap of not hype but overhype? So to start with, I can go to Dr. Akash. Akash, you are very interested in obesity management. shall I have any treatment? What are the positive and negative things, hopes and so next 18 or 20 minutes, I will be giving a brief points which create hope and what are the hypes. I will not go into details. I will be skipping super absorbent gel which is available in the US and also skipping the tesofensin which is available in Latin America. I'm going to, this is the issue with the, I'm not alone. I do have almost 1 billion people just like me. So I'm not alone with this problem. So I have to look for a solution. Why? What is the new anti-obesity? Actually, the topic is new. So to define a new, there is nothing which set standard. So we have an arbitrary cutoff here. For me, you, and everyone, new is which we have not seen. So the drugs which are not available in the market, we don't have experience, or that create a buzz. Buzz is actually a same word with a positive connotation as the hype. Hype is usually used in a negative connotation. I prefer being a semantic, overhype rather than the hype. The agents which qualified my definition of newer anti-obesity drugs are semaglutide by the name of Wegovy. I'm talking about anti-obesity, not the anti-diabetic that is available by Ozempic. Tirzepatide by the name of Zepbound, not the Mounjaro, and other drugs which are in the pipeline, phase 3 trials and all these. So what is hope and hype? Hope, I'm suffering, so I have a feeling of expectation or desire to get something. And I process a goal, set the goal and go through it. On the other hand, hype is actually a blatant method of creating interest, predominantly for financial, and it is promotion in a flamboyant method. It is a negative connotation, as I already said, while buzz is taken as the positive. In 2006, Dr. Richard Deo, which published this paper in PubMed, also published a book, Hype versus Hope, the obsession with the medical advances, the advances with the medical drugs for obesity, but they come at a hefty price. And we know what is the cost of, barring our neighborhood in Bangladesh where you can get due to lack of IPR, but in India, soon, in the next half year, or in the Western country, it is a very costly affair. So why this talk is on hype versus hope? Why need to talk? Because of available options. There are a lot of, as Dr. Nilanjan sir said, in pediatrics, we have a monogenic obesity, we can cause less than 5%. Setmelanotide is approved after age of 6 years. And in a very rare cases of leptin deficiency with congenital or other dystrophies, you can use recombinant leptin, that is metrileptin. So there are all of drugs which are approved for short term and long term. Honestly speaking, short term though used and given in the list, obesity is a chronic disease. You need to take on the longer chronic approved drug beyond 12 weeks. So we have agents like orlistat, we have a liraglutide, and which are not available in our part, but available elsewhere, semaglutide and tirzepatide. But these, as I already said, had a price barrier. Obesity, forget obesity, anything, even a growth hormone deficiency where in children, though adult is a different thing, nobody is ready to take Willinger's daily dose. Shall I go with the liraglutide available daily injection? I'm not ready. And there are a lot of undesirable side effects, barring from neuroendocrine tumor, optic neuritis to suicide ideation and all long more. So there is a side effect. Why I need newer anti-obesity drugs? Though anti-obesity drug qualify when they produce weight loss of 5% in more than 35% of tested candidates. But 5% is a modest. You need to take more than 10% to cause a significant health benefits, particularly in the remission. And you will see from the drugs available in Indian market, none produce this 10% cutoff. That's why I am hoping to Dr. Akash or Pankaj or any other health service provider for new anti-obesity drugs, because I need to lose 10 to 15% for the remission or other reversal of the other adiposity-based chronic diseases. So the two drugs which are available in Western market qualify this more than 10%. Why we are taking hype and hope? Because in the past we have an experience of more failure than the success with anti-obesity. Many of us has used rimonabant, sibutramine, all of has been, and larcazepine. We all has been gone of the market. Even newer drugs are under the scanners of multiple safety aspects. So I'm talking about the newer drug which causes more than 10%, semaglutide, tirzepatide. I'm now going to surgical options and the others. So now comes to what are the hope and hype. Semaglutide. The first step 1 trial produced a 14.9% weight reduction, step 1. This creates a real hope as well as hype. Hope for me, more than 10%. I am agree to take. And this is not daily. The price barrier will remain, other things are there. But maybe I get from Bangladesh, Kamrul is my friend or others. Or might be Indian government might consider something else. Okay. Diabetes drug is different. And how to use? We start from 0.5 mg, up titrate every 4 weeks, 1 mg, 1.7, 2.4. And all of the anti-obesity trial produce more than 15% weight loss. That is important. So this is potent drug. This fulfill my hope. And the hype created was, you will be surprised to know, once this drug was in the market, such was the hype created by investors, celebrities, that the share price lead to estimation, valuation of Novo Nordisk more than its nation, Denmark. This is a Danish company, and its market value was more than the GDP of Denmark. This is surprising. So this is hype. And this was short in production due to hype created by celebrities, sports, and all these. So as I said, this is the hope, which is important to me. Hype was created by others. So let us see. So there was more than 15%. The other most common side effect, everybody knows the GI side effect, usually mild, but in Indian scenario, probably it is far more than the Western data. In my personal observation with anti-diabetic semaglutide, I have not used the injectable because it is not available legally. So now come the tirzepatide. Tirzepatide was marketed by a company, Eli Lilly. Just like Novo Nordisk, rocket launching of its share become once jab bound, not even jab bound, Mounjaro was available in the market. Its share prices is so high, the valuation of company become tripled by a single agent. So this is hype and hope. And this is weekly injection. It causes far more weight loss. It is equivalent to almost medical sleeve gastrectomy. It is called what we are calling metabolic surgery by drugs. So this is the hope. And we up titrate every 2.5 mg, start with the 2.5 mg every week, up titrate every month, that is 4 weekly, to 5, 7.5, up to 15. And weight loss was more than 20% when maximum dose was. And these are the trials. So you will see with 15% in SURMOUNT. SURMOUNT is actually weight loss program. SURPASS was an anti-diabetic. Because these agents were initially used as an anti-diabetic. 20% weight loss. And 20% weight loss from diabetes study you have seen, direct trial and all these trials, has set a remission of adiposity-based diseases. Day before yesterday, it was approved for obstructive sleep apnea associated with obesity. So it is not like that only obesity. We have to treat the whole scenario. But we are a greedy person. We are not happy with the available dosing. So, okay, let us go with the other dosing. Semaglutide, if you are using 2.4, because in diabetic agent you loses weight by 6 to 10%, 2.4 causes. Let us see the maximum with the further increment of the dose. A step-up trial is being carried out with 7.2 milligram. The results will be available by next year. Same with the oral. Oasis trial data has been published with 50 milligram, though mild GI side effects were seen in 80%, mind 80%. Though discontinuation rate was only 8.3%. So this is how the things are going. And with the 50%, almost 1/3 with the oral medication, losing weight, because injection barrier remains always in the treatment of any chronic disease in Indian scenario, be it insulin, be it any anti-obesity drugs. So if we see what is the drugs, basically all of our having a backbone available is GLP-1 and GIP-1 receptor agonist. These are mechanism of actions. There are few other drugs which in the pipeline has promised and given me the hope available as the oral, like orforglipron. This is by 45 milligram once daily you can use, and they have given a 14.7% weight loss, low GI side effects, and phase 3 trial is already on there in the pipeline with 3,000 patients. There are more drugs which has resulted in hype also rather than the hope. Hope is danuglipron. We know that it has developed already results are out of 2A study which has shown more than 10% weight loss, but there are drugs which were taken off the market, taken off the development program and the trials, like lotiglipron, because of hepatotoxicity. So there is hope, but we have to be cautious because not all things are high hope. Then there are other agents like cotadutide, which is a different from GLP-GIP. This is actually GLP-1 and glucagon receptor co-agonist. And it has been shown to reduce 15.5% weight loss. That is very significant. Same with the other, like synchronized trial has with this, seen with the survodutide, which has shown 18.7%. So every agent is giving me a hope of significant weight loss, that I can lose weight, I can be a healthy person. These are the hopes. And very promising data, as I already said, obstructive sleep apnea, there is a approval of tirzepatide. These are showing promising result, which we have a case of in the morning by PG students, steatohepatitis. Single agent, particularly co-agonist, whether dual or triple, has shown a great response. They are also offered not only obesity, diabetes, but other parameters, heart failure and all these. Similarly with the NASH. Triple agonist, as Nilanjan sir was saying, retatrutide. So retatrutide has been shown to a great weight loss. If you escalate dose, whether you are going for 1 mg up to 8 mg, there was a 17%, 16.94% weight loss, which is again anything more than 10% or 15% going me a great hope. Other agents in pipeline which is giving me is amycretin. This is basically a chimeric co-agonist of amylin. Then what is new? 2 days back, नया कुछ आया है क्या market में? Let us see the results, hype versus hope. 2 days back, Novo Nordisk top line news, the data trial was completed on 30th of October, and top line result for investor were given on day before yesterday, that CagriSema in its redefined 1 trial has shown a great response, 22.7%. Everybody should be happy. This is at par with tirzepatide, and you will be surprised to know the share prices of Novo Nordisk plunges by 24% because they created a hype. They set what I call commentary by the top companies. We will have a 25% weight loss. So if expectations are not met, if hype is not met, then there is a disappointment. Though share recurs, and almost 40% of patients lose more than 25%. But we should know tolerability of CagriSema only 57% of people were able to tolerate 2.4 versus 2.4. Not all patients. 14 centers were from India, 222 centers across the globe in this study, Redefine 1. So this is how there will be extension of this phase 3 trial, Redefine 1 extension, which will last for 97 weeks. This Redefine 1 trial was for 68 weeks. There are other hopes because 25% so crest, okay. But we are using as a cardiovascular safety with 800 patients, obesity with diabetes, 1200 patients in Redefine 2, and there is a head-on-head trial with tirzepatide with 7,000 patients already going on. Redefine 2 results will be available by April or May, I believe, because it is going to be completed by March 25. So this will give me further hope. Yeah, next 2 minutes. I'm not willing for even once weekly. Last month, Amazon Pharmaceuticals gave its top-line news to investors. The results in peer review article will be available by the end of month or next month. That's phase 2 trial of its agent, that is Maritide or previously known as AMG 133, can be given as a monthly or bi-monthly. You can take monthly or twice, forget daily, weekly, now monthly or 2 monthly. So there was a weight loss of 20%. And this is not the peak. There was no plateau yet. The results was going up. And this is 52-week results. So let us see the extension. And those who have lost more than 15% already enrolled in the extension arm of this. And there is 11% which is very big discontinuation rate due to side effects, though GI side effect was seen in 8%. So to summarize, GLP-1 agonist will be in the spine with the flanks by glucagon, GIP-1, amylin, and all these analog antagonists. So these are the others like neuropeptide Y and beyond. To conclude, obesity is actually a pandemic of this century. Options available in India do not address the problem effectively. They do not reduce more than 10%. 2 agents, tirzepatide and semaglutide elsewhere, they give a fire of hope to every treating doctor. And the phase 2, phase 3 trial of semaglutide, tirzepatide, retatrutide, cagrilintide, and other agents, these medications are effective and quite safe. So these newer therapeutic agents should be explored with enthusiasm, but with the realistic goal target, and they have given a hope to clinicians. Hype is created by pharma industry and the commercial stakeholder, which should not be there. So newer anti-obesity drugs are actually hope if we are setting our goal appropriately. Thank you all. So for this hope in ongoing quest against the obesity. Thank you. Yeah.
Good morning.
Good morning. Good afternoon, Akash.
Sorry, good afternoon. That was a very enriching talk, sir. So when we talk about, means my experience here is very limited. I would say maybe 2 years or 2.5 years. And fortunately, I have used most of the agent that is available to us. So what I have felt that obesity is a very complex disease, and more or less it's rooted somewhere in the behavioral part, and the lifestyle intervention part is also very too important actually. When we talk about medication, we often forget that most of these trials are based on a foundation of lifestyle intervention also actually. So the patients are on a particular diet, on activities, some stress management being going on actually. When we try to implement these medications, when we provide these medications free of cost actually. So what I have seen that the tolerability part, the side effect profile is huge. How we counsel our patient, navigate them through this journey, and the dietary intervention needed at those points are actually very important. It's not that we can just give the drug and relax actually. It's not like that. Thank you again for this wonderful deliberation, I would say, and I would hold on to that hope actually, because when you have nothing, you hold on to the whatever you have actually. So it's very hopeful for a complex disease like obesity, And thank you, sir. Thank you again.
Akash, all drugs has to be a foundation of lifestyle management for any chronic disease. It's not about only obesity or diabetes.
Sure.
One, you will see there are two different goals apart at these separate poles. One is response with the placebo. Even with the redefined one trial, 0.3% if you have gone through the clinical, this top line news, achieve weight loss with 25% with placebo. That is predominantly because of lifestyle.
Yes.
Second is, there is a subset of people who do not lose a single ounce of weight on GLP-1 RA. Could be a genetic propensity, I'm not going, but my personal experience, they do not lose a single ounce. So it is an ongoing quest. It is not a single day that you prescribe and sit back and relax. You have to reassess at every visit. You have to counsel even for side effect and the efficacy. If you do not lose weight 5% by 3 months, do not continue further.
Nicely
The further discussions off stage. And Dr.
Yeah, very short question. After achieving 20% of weight loss, when can we stop this particular class of drug?
No, let me tell you the problem with this. The weight loss is sustained till you continue the medication.
So are
it
we
regains if you stop. The things is how long we can create a deficit of significant weight loss, that is 10%. The time will tell, because it is quite easy and encouraging, promoting the patient once he loses 20% to maintain on lifestyle and continuation of drug. Weight loss will not sustain once you stop, and that is true for even bariatric surgery. If you forget dietary and these advice, even you adhere.
But we don't need the next surgery, isn't it? We need only one surgery.
We are talking about medication. The weight loss effect continue till you adhere to medication. It regains once you stop.
So we are not treating obesity. We are just controlling it.
Yeah, we are controlling.
Thank
Treatment is always by lifestyle.
Thank you, Dr. Umesh. I think you have a flight to take.
Close the
A
session.
big round of applause, Dr. Umesh Garg. And to the photo booth for felicitation. Chairpersons, please. Chairperson. And we now move on to the inauguration session for the Diabetes and Obesity Update Purulia 2024. Believe me, it will be a very short inauguration before we plunge into further and more interesting topics related to diabetes, its complications, about insulin and everything else. Housekeeping announcement, all delegates are eligible for a complimentary lipid profile test to the right side of the main gate to the auditorium. Please take advantage of that, even if you're non-fasting, because now we are moving into an era of non-fasting lipid profile being adjusted with certain parameters. There is a fibroscan facility also available with one of the pharmaceutical counters. Do feel free to go to those stalls and take advantage of the facilities available. For the inauguration ceremony, I would like to invite on stage President IMA Purulia, Dr. Manojit Mandal. Dr. Manojit Mandal, sir, on stage. Along with that, I'd like to invite on stage Professor Sabyasachi Das, Principal, Deben Mahato Government Medical College and Hospital, Purulia. With that, I would like to also invite Dr. Chinmay Lat, who is the scientific chairperson for this wonderful academic program. Dr. Akash Panigrahi, organizing chairperson for this program.
Requesting everyone on stage to please light the lamp on the left hand side of the stage. Lamp lighting, please, and the Ganesh Vandana on screen immediately. Ladies and gentlemen, this is the official inauguration of the scientific program of the Diabetes and Obesity Update Purulia 2024. A big A big round of applause for everyone. May the blessings of Lord Ganesh, the pioneer God, be with all of us. Requesting everyone to please take seat. Please take your seats. We have some wonderful things lined up for the inauguration program as well. Thank you, dignitaries, for lighting the lamp and official inauguration of the program. I would like to invite on stage one of very young participants in today's conference, Adrija Das Mandal, who is the daughter of Dr. Anita Das, senior gynecologist and faculty at the Department of Gynecology. She will be presenting a short dance as to mark this ceremony.
জমছে এক পাহাড় অসহ্য বিচার স্তব্ধ হয়েছিল তারা ব্যস্ততা হাজার তাই যে নাই খেয়াল পেছনে দেয়াল যে যেমন সে নিচ্ছি মেনে নাম দিয়ে কপাল কেউ মরণ কাল কেউ ভয়ে কাতর কেউ বা নিরুপায় বা সহায় হয়ে পাথর আর কবে 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 কণ্ঠ শক্তি পাবে আর কবে চিত্ত স্বাধীন হবে আর কবে সিক্ত হবে হৃদয় আর কবে শির উঠে দাঁড়াবে আর কবে 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 আর কবে
Thank you, Adrija and Anita madam, for bringing her all the way to Kushalpalli. And there is a small gift for Adrija from the organizing committee of Diabetes and Obesity. A big round of applause for Adrija Das Mandal, one of the youngest participants in today's conference, I believe. Next, we have a small poem recitation by who happens to be my son, Siddhant Singhania, a poem on diabetes and obesity, which is in Hindi. For all those who understand and speak Hindi, and for most of us, there will be a small poem on diabetes and obesity. Siddhant, please.
मोटापा और शुगर कॉम्प्लीमेंट्री टू ईच अदर. मोटापा जाने अनजाने आ जाता है, खान पान की ओर हर बार ले जाता है, बार बार बैठक से भी निकल आता है और साथ साथ अपने मित्र शुगर को भी ले आता है. फिर एक बार जब ये दोनों आ तो गए, बिन बुलाए मेहमान शरीर में समा तो गए, फिर ये जाने का नाम नहीं लेते. कितनी भी कर लो कोशिश ये जीवन हलाकान कर देते हैं. और तो और मेरे बाकी अंगों से दोस्ती कर लेते हैं, उन्हें भी अपने में समेट लेते हैं. कितनी भी कर लो कोशिश ये जीवन हलाकान कर देते हैं। अतएव इनसे निपटने हम यहाँ आए हैं, इन्हें प्यार से कैसे हराए ये समझने आए हैं, क्योंकि पहला सुख है निरोगी काया, बाकी सब तो मोह माया। धन्यवाद।
Thank you, Siddhant, for putting up the essence of the conference in that small poetry. And there is another moment, token of gift from Siddhant. We take this opportunity at Purulia to felicitate two people whom we consider one from one of our faculty members whom we missed last time in our thyroid update, Professor Shotinath Mukherjee. Sir, please, on stage. Professor Shotinath Mukherjee is Professor, Department of Endocrinology. Sir. Department of Endocrinology at IPGMAR Kolkata, happens to be my guide in my DM dissertation, always close to our heart. And I would request Professor Sabyasachi Das, who is another ex-student of Medical College, to felicitate Shotinath sir on behalf of the organizing committee of Diabetes and Obesity Update to Purulia. Big round of applause, ladies and gentlemen, for Professor Shotinath Mukherjee sir. And there is a painting which we have cherished with one of our friend, Barun Rajgadia, who has taken this himself, this photograph, and this is for sir. Thank you, Shotinath sir, for this wonderful appearance. Another person that we decided on behalf of the first ever Conference of Diabetes and Obesity Update 2024 Purulia to felicitate one of the legendary physicians of Purulia district with the first Lifetime Achievement Award of the Diabetes and Obesity Update Purulia 2024, who happens to be amongst us. Many of us have seen him, we've heard his name, and from a region of Purulia, he's almost like a common name, a god who has treated that place for more than 5 decades. Dr. Gopal Laik, Dr. G.C. Laik, who is a very senior physician, Sir Ashun, of Purulia district, to be felicitated with the Lifetime Achievement Award. I would request Dr. Manojit Mandal, President IMA Purulia, to read out the citation and felicitate our senior physician. Dr. Manojit Mandal. Sir,
Healthcare Foundation of Purulia on this Diabetic and Obesity Update Purulia 2024 proudly presents the Lifetime Achievement to Dr. Gopal Chandra Laik, Senior Physician, for his exemplary service to the sick and allying over more than 5 decades. We are privileged, sir. Today is the 26th December 24, and it is organizing here in Kusalpalli, Purulia. Dr. Laik, please.
Dr. Gopal Laik deserves a standing ovation from everyone present in this hall. Dr. G.C. Laik receiving the first ever Diabetes and Obesity Update Lifetime Achievement Award. Dr. G.C. Laik. In the end, I would request Professor Sabyasachi Das, Principal Purulia Medical College, to say a few words to everyone that has come over here from far and wide. Principal, sir, please.
Good afternoon. এইরকম ইভেন্ট কয়েক মাস আগে আমরা আরেকবার দেখেছি। Within a very short span of time, Dr. Pankaj Singhania দেখিয়েছেন যে কী করে পুরুলিয়াকে সায়েন্টিফিক সেশনের ম্যাপের মধ্যে আনা যায়। তো এই অ্যাক্টিভিটি রেগুলার চলবে এবং আস্তে আস্তে পুরুলিয়ার মানুষ, ডাক্তার, ইন্টার্ন, ছাত্র এরা সবাই ইন্সপায়ার্ড হবে, এদের কাজে লাগবে। ন্যাশনাল মেডিকেল কাউন্সিলের একটা ওয়ান অফ দ্য অ্যাট্রিবিউটস অফ এ ইয়াং মেডিকেল ইন্ডিয়ান মেডিকেল গ্র্যাজুয়েট হচ্ছে লাইফ লং লার্নিং। এই লাইফ লং লার্নিং কনসেপ্টটা থ্রু প্রফেশনাল ডেভেলপমেন্ট, সেমিনার, ওয়ার্কশপ এগুলোর মধ্যে দিয়ে আসে। ছাত্ররা যেমন পুরুলিয়াতেও পাশ করে এই রকম সুযোগ খুব একটা পেত না বা এর আগেও কখনো খুব পায়নি। তাদের প্রত্যেককেই কলকাতায় যেতে হতো এইরকম একটা এক্সপোজার পাওয়ার জন্য। তো এরপরে আশা করি আমাদের যারা ডক্টরস ফার্স্ট কন্ট্যাক্ট, যারা জেনারেল ফিজিশিয়ান, যারা নতুন ডাক্তার হচ্ছেন, তাদের কাছে এটা একটা বিরাট সুযোগ। তো আমি আরেকবার বলি যে পঙ্কজকে আমার sincere gratitude and thanks for arranging such a beautiful conference all through. And পঙ্কজের যে টিম, যেমন ডক্টর প্রিয়া, ডক্টর মিস্টার সন্দীপ, এরা পঙ্কজকে যে পরিমাণ সাপোর্ট দিয়ে থাকে বাড়িতে, তার জন্যই এটা সম্ভব হচ্ছে। আশা করছি ইন ফিউচার আরও বেশি পার্টিসিপেশন হবে, স্টুডেন্টরা আসবে, যারা ডক্টরস অফ ফার্স্ট কন্ট্যাক্ট বা জেনারেল ফিজিশিয়ান, তাদের নিয়ে আরও বড়োভাবে এটা হবে ইন ফিউচার। থ্যাংক ইউ।
There is one other thing which we need to do, the prizes for the paper presentation session. We have first prize as well as participation prizes. The first prize is an amount of 5,000 rupees, which has been unanimously decided by the judges, goes to Dr. Naushi Vidyadharan N for her PG paper presentation this morning. I'd request Dr. Akash Panigrahi to hand over the certificate and prize to Dr. Naushi. Along with that, I'd request Dr. Ramamurthy and Dr. Alamgir to please also come on stage to receive their cash prizes for wonderful papers presented this morning. Dr. Chinmay Lat could do the honors of giving away cash prizes of rupees 2,000 each to both the participants. All of you are equally good. In fact, the judges had a tough time and the winner was decided by a 2-1 consensus. So there were people in favor of the others as well. To end the inauguration, I would like to thank Indian Medical Association Purulia, President, Secretary, Treasurer and everyone, every member who is over here for their wonderful participation. Arogyam Healthcare, my unit, all the faculty members who've traveled from far and wide, students from medical college and everywhere who've come here, delegates, sponsors, our sponsors who have put up stalls and facilities for the delegates, the hotel and the wonderful premise, especially the CGM of this hotel, Mr. Shudipto, our travel partners, our printers for the various kiosks and hoardings that you're seeing, volunteers from both the pharmaceutical and the non-pharmaceutical industry, my family members, and finally and not lastly, God Almighty above for bringing us together and helping us do this wonderful conference. We will resume scientific program immediately after this. And there is a message from the scientific, from Dr. Sudeb Sinha from Bankura. He wants to read out a small line about diabetes. Dr. Sudeb Sinha, please. Dr. Sudeb is Secretary IMA Bankura. He has a one-liner.
Yes, good afternoon to everybody. আজকে আমরা যে ডায়াবেটিক্স যে একটা কনক্লেভ along with obesity আমরা অ্যাটেন্ড করছি, it is a really great privilege and astonished at the same time overwhelmed rather যে আমার পঙ্কজ এত জুনিয়র হয়েও বা এখানে পুরুলিয়ার মতো রিমোট প্লেসে এই ধরনের কনক্লেভকে অ্যারেঞ্জমেন্ট করা with the presence of Galaxy stars, my seniors, with my rigors, everybody. I like to convey one important message as my innovative things. So what is diabetes? D for drug, I for infection control, A for annual checkup, B for blood sugar estimation, E for exercise, T for to protect vital organs, E for eye checkup, and S for sugar control. At the last, I request Dr. Pankaj Singhania just to arrange any program in Bankura is very efficient because we are holding at present 163 members, all line members. And at the same time, I am holding the ex-state vice president and as well as now the central working committee members and central council members and honorary secretary in Baklor branch. We have been privileged that this day will be a milestone to diabetes and obesity not in Purulia but in entire West Bengal. Thank you so much.
Thank you, Sudev sir, for those encouraging words, and I'll get back to you regarding our next ventures. And I'd request the chairperson, the faculty on stage, to please come down. Thank you, sir. Moving on to quickly to the next session, which is on diabetic nephropathy, which will be chaired by Dr. Adrija Chatterjee. Dr. Adrija Chatterjee is from the Department of Nephrology at IPGMR Hospital, Kolkata. Dr. Falguni Chakraborty, Head of the Department Biochemistry, Deven Mahata Government Medical College and Hospital, Purulia, and Dr. Hori Prasad from Southeastern Railway Hospital, Purulia. Dr. Hori Prasad. Dr. Hori Prasad, please come. And the talk will be delivered by Dr. Anirban Majumdar, sir, Professor at the Department of Endocrinology, KPC Medical College, Kolkata. Sir is one of the senior endocrinologists in Kolkata, one of the organizers of the splendid IdeaCon conference each year, and sir will be taking us through diabetic nephropathy, what's new. Diabetes comes with complications, we know. Diabetic nephropathy is one of the most dreaded complications of diabetes, leading to dialysis, renal transplant and death ultimately. Let's see what do we have new for the treatment of diabetic nephropathy from Professor Anirban Majumdar, sir.
Okay, thank you. Thank you, and thank you, Pankaj, for your kind invitation. And we're going to talk about diabetic nephropathy. We'll touch upon a little bit of new things which we have learned very recently. Before I start, let us understand that we are progressively having more and more number of patients with diabetic nephropathy, and quite naturally it poses a real burden as far as total number of diabetic nephropathy and CKD, and also the renal replacement therapy. And being as is the India as a not so very rich country, it is often difficult to provide the renal replacement therapy to all the patients we have. Now, with this small introduction, let me start with a case I think that we always see in our clinical practice, and we can associate with this case in our day-to-day practice. Is a 48-year-old male with 8 years of diabetes, obese, and getting metformin 1 gram twice daily. Glycemic control is poor, and you have creatinine 1.5 and ACR 321. So I think many of you has this kind of patient, and we need to understand that what we are supposed to do when we have this kind of patient in front of us, and that should be our approach, with special reference to what we have learned recently in the last decade or last 5 years or so. So whenever you have this kind of patient, we need to categorize this patient as far as the renal issue is concerned. And nowadays, when we categorize our patient, it depends on albumin creatinine ratio or ACR, and also depends on the GFR. So we have the creatinine, and then we have to look into GFR, and we have the ACR. ACR is 321. So when we want to get an GFR, we have two main method by which we can calculate. I think it is very easy to calculate because you can calculate it through a calculator. Just download it in your mobile and put the values, and if you give the value, then that will give you the eGFR value, which is very easy. These are the two standard method, MDRD and EPI formula. Nowadays I mostly use EPI, so you can use either of the two, but most of the guideline, most of the trials is basically done on the basis of EPI formula, but it comes to very close, 53 and 57. The second important issue that we need to understand, that the calculation of the eGFR is sometimes fallacious. So even if it is fallacious, it's very difficult
to get the actual EGFR done unless and until you have measured cystatin C, which is not readily available across the country. So we have to remember that this is a possible that we may get fallacious EGFR, but even then we have to calculate the EGFR. For this particular patient, the EGFR is 57, ACR is 321, so we have to categorize it as A3 and G3A, and here is my patient. So you understand that this is the patient has a high risk of development of end-stage renal disease, and we know that if there is an end-stage renal disease, the patient not only will have more involvement as far as the treatment is concerned, it will be more costly, and we have limited resources available across the country. So therefore, we will try to prevent the patient from further deterioration of the renal function. That is our objective when we treat. But before we jump into the treatment, we need to rule out the non-diabetic kidney disease. That is the advice of American Diabetes Association. Please look into the possibility of non-diabetic kidney disease, rule them out, and then you jump into the approach or into the management of diabetes. Now, when we look into the management of diabetic kidney disease, then we have basically 6 pillars for the management. Now, I have intentionally is not going to talk about hypertension because it is a separate issue, so I'm not going into that. But we have these 6 pillars when we talk about the management of diabetic kidney disease. There is nothing new in the diet, but guidelines suggest, or if you look into ADA guidelines suggest, that give a protein restriction of 0.8 gram per kg of body weight, give restriction of the sodium so that you can manage very well as far as the hypertension is concerned. The second important issue is the glycemic control. We all know that the glycemic control is associated with significant improvement in the renal endpoint. So we'll try to achieve a good glycemic control. The data comes from UKPDA study. The data not only from UKPDA study, we have ACCORD data, we have advanced data, we have lots of studies which suggest that if we achieve a good glycemic control, it will give benefit in the renal outcome. So therefore, we try to achieve good glycemic control, whatever may be the method. But at the same time, we need to remember that if the patient has got a stage 4 or stage 5 CKD, H1C is not a good measure as far as the glycemic control is concerned. In most of the situation, H1C holds good, but in situation when the EGFR or when the CKD stage 4, 5, then it is better, but sometimes, if possible, we can look into the other parameter of glycemic control like CGM, continuous glucose monitoring, if available and if you can do it. Now, our third pillar of management is ACE inhibitor ARB. So any patient who have hypertension in the background of diabetes, or any patient who have microalbuminuria or macroalbuminuria, we are supposed to write an ACE inhibitor or ARB. I repeat, if a patient has got a hypertension, if a patient has got a ACR more than 30, then we have to write ACE inhibitor or ARB. Now, when we talk about ACE inhibitor and SGLT inhibitor, because of the fact these two drugs actually effective in 2 different areas. Now, when we talk about the RAS inhibition, it basically dilates the efferent arteriole. On the other hand, if we give SGLT inhibitor, it constricts the afferent arteriole, and therefore, these two actually have synergistic effect. So therefore, ACE inhibitor is a very important drug, or ACE inhibitor or ARB, in patients with diabetic kidney disease, but it is well known. We are writing this drug for a long period of time. It is not new. We have the data in favor of ACE inhibitor ARB, but we don't have data as far as head-to-head comparison between ACE inhibitor ARB. So it depends on your choice whether you will write ACE inhibitor or ARB. Among the ARB also, there is nothing much to choose, because you can see all the ARB has got significant impact as far as the progression of the renal disease is concerned. The new is in our understanding that whenever you are writing ACE inhibitor ARB, be careful about the potassium and the reduction in the EGFR. So please monitor the potassium. Don't stop the ACE inhibitor ARB just because of the fact that there is a sudden decrease in the EGFR. We have to rule out acute kidney disease. It is a last resort that when we are supposed to stop ACE inhibitor or ARB. So try to continue ACE inhibitor or ARB, even if there is a reduction in the EGFR more than 25% or 30%. Our fourth bet or fourth option is the SGLT inhibitors. As you know, these are the drugs which we are seeing in the market for the last 20 years or so, and we have lot of data in SGLT inhibitors, be it in cardiovascular outcome trial data, be it as a renal outcome data. If we look into the meta-analysis, it is very clear that the SGLT inhibitor has got a beneficial impact on the kidney endpoint. So all these SGLT inhibitors, especially when we look into the renal data, say for example, DAPA-CKD study or EMPA-Kidney study or the Credence data. So all these trials was actually done over and above ACE inhibitor or ARB. As just for an example, if you look into the DAPA-CKD, the 98% patient actually already had ACE inhibitor or ARB. So over and above, you have given SGLT inhibitors and you are getting the benefit. So therefore, the SGLT inhibitors is a very, very important drug as far as management of diabetic kidney disease. And that is why when we look into the American Diabetes Association 2024 guideline, it strongly suggests that let us have a look into the comorbidities. It is not the glycemic control, but it is the comorbidity that actually dictates us which drug we are supposed to use at the first instance. As you can see, if the patient has got a CKD, then our first choice should be SGLT2 inhibitors. So that is what they are saying. And then the second choice, if you look into, I'm sorry the pointer is not working. So the second choice is GLP-1 receptor agonist. So our fifth bet or the fifth pillar of the management of diabetic kidney disease is GLP-1 receptor agonist. And we have lot of data on GLP-1 receptor agonist, but almost all data is basically on cardiovascular outcome trial. Now, if you look into the cardiovascular outcome trial data, but we also have some analysis on the kidney outcome. And if you look into all the trial, wherever the kidney outcome was analyzed, was found that GLP-1 receptor agonist is quite beneficial, quite effective in the backdrop of diabetic kidney disease. So this is our fifth agents or fifth pillar in the management of diabetic kidney disease. Please remember that the patient, those who are suffering from kidney disease, they usually die from cardiovascular disease. They usually don't die from renal failure, they die from cardiovascular disease. And the GLP-1 receptor agonist not only improves the renal outcome, but also have significant beneficial impact on the cardiovascular outcome. Especially some of the GLP-1 receptor agonists, say liraglutide, say dulaglutide, say semaglutide, they have the benefit. But otherwise, all GLP-1 receptor agonists are quite safe in the backdrop of cardiovascular disease. And some of them, as I said, the liraglutide, semaglutide, dulaglutide, they have beneficial effect on cardiovascular outcomes. So in a single drug, actually you are preventing the progression of the kidney disease and also you are preventing the cardiovascular event. So, but these trials or data are actually not renal specific. So we only have one trial which actually have looked into the primary kidney outcome data, and that is FLOW trial, very recently published. And the FLOW trial was actually done in semaglutide. So semaglutide 1 milligram weekly dose is associated with significant improvement or significant benefit in the renal outcome compared to the placebo. So all other GLP-1 receptor agonists possibly will have beneficial effect, but we don't have kidney specific trial, but the semaglutide has a kidney specific trial suggesting the semaglutide is quite beneficial in the patients with diabetic kidney disease. So even in the patients with when the semaglutide has been done, trial has been done, you can see almost 96% patient actually already had background ACE inhibitor or ARB. So the benefit what we have observed is over and above ACE inhibitor and ARB. So all the three drugs, you can see the SGLT inhibitors, the GLP-1 receptor agonist, both are basically given benefit over and above ACE inhibitor on ARB. My So we have this flow kidney outcome trial with once weekly semaglutide showing first major kidney disease event was reduced. There is a first kidney specific composite event was reduced, and you can see the EGFR slope, which is more or less showing quite better with compared to the placebo. And that is why if we look into the KDIGO guideline, it suggested that our first line therapy will be the metformin. Then after the metformin, we should give the SGLT inhibitors as a first line therapy. But metformin, you need to look into the EGFR value to adjust the dose of metformin. I think all of you are aware about this, but metformin, SGLT inhibitor, and then you can see in the second line that the next best option in front of us is GLP-1 receptor agonist therapy to prevent the progression of diabetic kidney disease. My last pillar is finerenone. These data has been actually published very recently. We have the Figaro DKD trial, and we have another one. Which one is one? Fidelio. So ultimately, we have the Fidelio trial and Figaro, and the combined analysis was done in Fidelity. So Fidelity is basically a pooled analysis of both the trial, and these pooled analysis also suggest that they are actually quite beneficial in the backdrop of diabetic kidney disease. But you can see that all these trials has been done on the backdrop of ACE inhibitor or ARB. So over ACE inhibitor, ARB, the SGLT inhibitor is beneficial. Over ACE inhibitor and ARB, the finerenone is also beneficial. But we don't know if we add ACE inhibitor ARB plus SGLT inhibitor plus the finerenone. So that is not known to us, and unless and until we have this confidence trial data available to us, we do not have any confident answer to it. However, when we look into the holistic management of diabetic kidney disease as suggested by KDIGO guideline, we can see apart from lifestyle, the first line agent in front of us is basically SGLT inhibitor, and the second line agent is the GLP-1 receptor agonist therapy with where it is indicated and when the data in favor of renal event is available. And then we have to control the blood pressure by giving ACE inhibitor or ARB, and we have to use MRA or the finerenone for further prevention of progression of the diabetes. So therefore, if we come back to my patient who is 48 years old male, 8 years on metformin twice daily, and creatinine is 1.5, EGFR 57, and ACR 321 milligram per gram, then I am supposed to modify his diet. My first pillar, the control of the protein, then ACE inhibitor or ARB, will add SGLT inhibitor, will give a GLP-1 receptor agonist, which has got a proven benefit in the renal outcome. We will optimize the HbA1c so that a good diabetes control, glycemic control is there. We add the finerenone, and we have to monitor the blood pressure, HbA1c, creatinine, potassium, ACR to see whether these combination therapy is effectively preventing the progression of the kidney disease or not. Apart from these, there are many other things to monitor in the diabetic kidney disease, but this is beyond the scope of this lecture, so I am not considering, and I am not talking about hypertension, which has got a very, very important role in the prevention of diabetic kidney disease. Thank you very much for your patient listening.
If there is any question from the audience for Anirban Majumdar sir.
Yes. Yeah.
Almost 95% on ACE inhibitors, ARBs, only 15% on SGLT2 inhibitors.
I don't know, because at the time of inclusion, they have not specified that the SGLT inhibitor should be there, should not be there. So naturally, few patients with SGLT inhibitor, and I have looked into whether they have separate analysis of those who received SGLT inhibitor, those who have not received the SGLT inhibitor, but no such analysis was available. But please remember that the if you look into the other SGLT inhibitor related trial, then the in the EMPA kidney study, there is a good number of patients who were not on ACE inhibitor or ARB. Though, if you look into the DEPA CKG, EMPA kidney and Credence trial, there is almost all patients were actually on ACE inhibitor ARB, except in EMPA kidney study, where a significant but small in number was not on ACE inhibitor or ARB. But the effect of SGLT inhibitor was more or less same, whether the patient received SGLT inhibitor or not received. Unless and until we have this confidence trial data available to us, it is very difficult to answer this question.
Because very similar SOUL trial also, the number of people on SGLT2 inhibitors were very less in spite of having established cardiovascular disease.
Yes.
There were only 20% people on SGLT. So there is something they are actually trying to create a good result by not putting on SGLT inhibitor. The data.
Let us look into the confidence trial data, because all three are combined, and they are comparing it with only SGLT inhibitor and only your phenylenone. So one group will be 3, another group will be with phenylenone, another group will be with SGLT inhibitor, empagliflozin, for this confidence trial. So let us have the result, and then with the same subset of the patient, so we'll get the result, and we'll have the answer.
Thank you.
Yes, Amartya.
Yeah, thank you, sir, for the wonderful presentation. Just a comment on this. I think the FLOW trial, it spanned 3.4 years. Recruitment started way back in 2019-20. At that point of time, probably the beneficial effect of SGLT inhibitors on diabetic kidney disease was, it has just started, and probably that was one reason not all people were on SGLT inhibitors at that point of time.
Yes,
that might be one explanation.
Yes, I fully agree with this, because maybe it was not at that point of time, it was an universal guideline that you should put all the patient to SGLT inhibitors.
Yeah.
Yes.
And second part is just your personal opinion. So when we see a patient whose creatine GFR has gone down, albumin has started, so what do? Do you start both these drugs, SGLT inhibitors, if the patient is not, and the phenylenone together, or you wait and one after?
Yes.
There is no guideline, but I just wanted to know your opinion.
I understand your question. The issue is basically, we are concerned about the potassium. So quite naturally, I will not put all the 3 agents simultaneously from the beginning. So ACE inhibitor ARB is there. So let us have a look into the potassium and the eGFR. And once I am confident that potassium is okay, the ACE inhibitor ARB is not causing any problem. Lower the eGFR, higher is the possibility of hyperkalemia with the ACE inhibitor or ARB, whatever maybe agent you are using. So quite naturally, I will use one. Then if everything goes all right, then I will use the phenylenone. SGLT inhibitor we can add, it hardly matters.
Thank you, Anirban sir. Dr. Sudeb, we can have that. Sudeb sir.
First question.
Sudeb sir, we can have that question off stage. We are running a little late. Anirban sir, please. Thank you.
Okay,
thank you, Dr. Anirban Mujumdar sir. To the photo booth for the felicitation. And we quickly move on to our next session, which will be on a topic which is very close to my heart, amputation in type 2 diabetes or diabetes per se, diabetic foot. To chair the session, I'd like to invite on stage Dr. Amrit Khaitan, General and Laparoscopic Surgeon, Purulia, a very close friend. Dr. Sanjay Chatterjee, Senior Surgeon, Purulia, another close associate. And Dr. Jaideep Mandal, a very promising orthopedic surgeon from Purulia, another close associate. And to deliver this talk, we have none other than one of the persons who has the most descriptive, pioneering and work in terms of diabetic foot, Professor Shotinath Mukhopadhyay sir, Professor at the Department of Endocrinology, IPGMER, Kolkata. And sir will be talking on a topic which I thought is appropriate. Amputation is a shame. We do ampute legs, but amputation is a shame. And how can we salvage the diabetic foot? Professor Shotinath Mukhopadhyay sir.
Thank you, Pankaj, for the kind words, and congratulations on fulfilling an uphill task, literally and figuratively, taking all of us atop this miniature tabletop mountain in Purulia. So, amputation is a shame. Why is that so? This amputation, here we are not talking about traumatic lower limb amputations that you have following road traffic accidents. When you talk of non-traumatic lower limb amputations, diabetes remains the commonest cause, right? And you'll be surprised to know that 85% of such amputations are eminently preventable with appropriate strategies. Even then, it pains me when I get it from WHO that every 30 seconds a limb is lost due to diabetic foot ulcers. So as I'm making this presentation of 20 minutes, some limbs are being lost, some in some corners of the world due to diabetic foot ulcer. Why do people with diabetes develop foot ulcers? The pointer again may not be working. Okay, it's not. So basically you have three risk factors: diabetic neuropathy, which can be peripheral as well as autonomic. You can have peripheral artery disease, and you can have infection superimposed due to repetitive trauma, recognized or often unrecognized in presence of severe sensory loss, leading to diabetic foot ulcer. So your loss of sensation puts the foot at risk, and this is in the parlance of podiatry called loss of protective sensation. Due to loss of pseudomotor fibers, the skin becomes dry and skin cracks, so you have entry of pathogens, so that's another risk factor. And of course, compromised vasculature interferes with healing of an ischemic foot ulcer. That's a different challenge. Autonomic neuropathy also opens up arteriovenous shunts at the precapillary level, so you have bounding pulsation, whereas there is a poor tissue oxygen delivery at the capillary level, which is classically described as the worm ischemic foot. Now, we really do not have any treatment for diabetic neuropathy other than glycemic control. We do not have any agent. When you achieve good glycemic control, you have significant improvements in terms of the microangiopathic complications, i.e. retinopathy, nephropathy, and diabetic neuropathy, but there is no data to tell us whether intensive glycemic control impacts the outcome of diabetic foot ulcers. And here is an ongoing study where we are looking at this impact on a multi-center randomized controlled trial platform. But then at the primary care level, how do you identify a high-risk foot, right? And it's not difficult. It's not difficult at all. The only thing is you have to start examination. The head-to-foot examination, as they all say in the exams, should be foot-to-head examination. So you start your examination from the foot, right? And you easily pick up, in a 2-minute examination, high-risk fit. Okay, so how do you do it? Vibra TP is available on Amazon. It's $2. You can use it 500 times, and you can just check on the great toe whether the patient feels the vibration or not. It's a 5-second test, right? You need not really worry about all those complex tests which we do at the foot lab in our institute. So then you have this monofilament, everyone has access to it, and you can actually ask your patient to buy a monofilament 10 gram and check his or her feet daily before going to bed. Then we come to more formal tests, which is on the right, where a vibrometer is being used by my podiatrist to quantify the level of loss of vibration perception. This is how we test the thermal perception in our lab. Now coming to peripheral arterial disease and diabetic foot ulcer, if you talk about the risk factors, you see renal insufficiency tops the foot. And David Armstrong from the US, so he labels this condition as renal foot. Any diabetic with chronic kidney disease, you take a foot X-ray and you see vascular calcification, right? And you know that this patient is at a high risk of developing peripheral arterial disease and ischemic foot ulcers. Not only that, a calcified foot arteries also tell you that this patient may be having calcification in the coronary arteries and the carotids. So a poor man's coronary artery calcium score comes from here. So this is how we check the ankle to brachial systolic pressure index to quantify peripheral vascular disease, and you can see on the chart on the right, so 1.1 is normal and 0.1 to plus minus 0.1 implies impending tissue necrosis. So this tells you that your ABI parameters actually correlate with the severity of peripheral vascular disease. But having said that, I must reiterate that if you have a calcified peripheral artery, then that artery is not really compressible, and your ABI actually is falsely elevated. So if you get a figure above 1.3, you know that this patient may be having vascular calcification, and to mitigate this confounder, you need to fall back upon a test called toe brachial index, where you measure systolic pressure from the toe arteries instead of the ankle. And the toe arteries are usually believed to be free of vascular calcification, although that's not absolutely the case. We have seen patients having calcification involving the toe arteries also, but the importance of this TBI is that if you get a value less than 0.35 and the toe systolic pressure is less than 30 millimeters mercury, you know that this patient is having critical limb ischemia and needs to go for intervention, a CT angio, or if the patient has significant diabetic kidney disease, an MR angiography, which can avoid the use of nephrotoxic contrasts. So I don't know whether the video will run, and you can see Dr. Pankaj using the automated ABI, TBI machine in our clinic. That's essentially was his thesis. So you see in this instrument, you can capture the ankle brachial systolic index, the toe brachial systolic index, and you get all the results coming out into the bottom as a chart which gives you the ABI and the TBI. Oops. Okay. Now just quickly walking you through a couple of interesting cases. So 58 years male, diabetic for more than 20 years, hypertensive, smoker with a dry gangrene on the left fourth toe, as you can see. But now this fourth toe, as you will all agree, is not salvageable. This is a dead toe, right? But can you prevent gangrene in the other toes? So that's the big question. Dorsalis pedis pulsation is absent, posterior tibial present, and you do an ABI, and which is falsely elevated, 1.4, And immediately we did an X-ray, and as you can see, a nice trunk tract calcification. So both the posterior and the anterior arteries are calcified. So this patient has CKD, so this is a renal foot. So what do? You have to fall back upon TBI, like I said before. Look at the TBI, and this is hovering around critical limb ischemia. So then we, in a situation where you have this TBI low, but it's not low enough, not 0.3, what do? If you have access, so this is the transcutaneous oximetry, where we measure tissue oxygen pressure, and if it is less than 40, signifies critical limb ischemia. So I'm not sure if you can see it from there. So for this patient, the TCPO2 was 24, so critical limb ischemia. So this patient needs to be taken off for revascularization, be it angioplasty, plus minus stent. Below knee for infragenicular involvement, you cannot really put a stent there. So angioplasty or maybe a peripheral vascular bypass is the answer. Ultrasound can serve as a poor man's CT angio. On the right, you can see turbulence indicating peripheral vascular disease. So this is a CT angio for one typical patient, and you can see complete cutoff of blood supply below the knee on the posterior tibial. So we published recently the data on diagnostic accuracy of ABI and TBI, and as you can see, TBI performs much better in terms of sensitivity with a comparable specificity. I saw this patient only day before yesterday, no claudication, heavy smoker, diabetic for 15 years, 67 male, and we did a TCPO2 which was 25 bilaterally, and did a CT angio, and you can see complete cutoff of blood supply below the knee bilaterally. So a candidate for limb salvage through revascularization, whatever might be the strategy depending on the anatomy, so angioplasty or a bypass. So this is Dr. Pankaj's paper published in Diabetology and Metabolic Syndrome, highlighting the impact of toe brachial index in the initial evaluation of peripheral arterial disease in people with type 2 diabetes. Now, when you have a diabetic foot ulcer and it's infected, you have to decide on what antibiotic to choose. And this is our recent paper in BMJ infectious disease, where we have shown a high rate of nasal carriage of methicillin-resistant Staph aureus. High nasal MRSA carriage rate is associated with MRSA in the diabetic foot ulcer. And when you do an antibiogram, we found linezolid to be the most suitable oral antibiotic to start with in such a situation. I don't know how I'm doing in terms of time. Oh, we still have some time, okay. And infrared thermometer everyone has, right? During COVID, everybody checked patient's temperature. So non-touch technique. So you can use the same infrared thermometer to check the ulcer temperature. When the patient has a unilateral ulcer, you can check the temperature on the opposite foot, contralateral foot as a control, and if you have a temperature difference of more than 2.2 degrees centigrade, means underlying infection, you have to treat with antibiotics and offloading, but don't stop if the temperature difference minimizes to 1 degree. The guideline tells you that if the difference is less than 1 degree centigrade, you stop there. But this paper by Dr. Amrita Ghosh tells us that even after skin cover, if the temperature difference is more than 1 degree but less than 2.2, those patients have a recurrence of foot ulcer. So don't stop your intervention, your offloading, your antibiotics. Continue them till you achieve a temperature difference of less than 1 degree centigrade between the feet. Only then you can ensure complete healing. So I'll skip these slides in the interest of time. Prevention of diabetic neuropathy is a challenge because early diagnosis is a challenge, right? For retinopathy, you have your ophthalmoscope. Nowadays you have the fundus photography for, again, nephropathy, you have your albumin-creatinine ratio, so you can detect them early. And if you detect them early, your intensive glycemic control can actually make a huge impact on the progression of CKD and progression of diabetic retinopathy, as shown by multiple studies. The problem with neuropathy is that by the time we detect a loss of protective sensation, we've already missed the bus. We detect it very late. So can we have an early intervention? Well, this is a contraption called corneal confocal microscopy, arguably the only machine available in Eastern India at our institute, where we can directly look at the nerve fibers, their length, their branches, their morphology on the cornea, and this correlates well with sensitive parameters for diabetic peripheral neuropathy. So by looking at the cornea, you can actually quantify the amount of nerve involvement in diabetes at a very early stage. And we presume that intervening at such an early stage may make a good impact on the onset and progression of overt peripheral neuropathy in diabetes. So here you can see on the left, this is a normal control, and you can see the cornea is innervated with multiple nerves and branches. Then with long-standing diabetes, you have loss of corneal nerve fibers, and on the right, this patient is with advanced DKD and advanced diabetic neuropathy, and you can see hardly any nerve fibers, right? So you can easily quantify that. Then I don't think I have the time. This is an axonal signaling molecule which is associated with nerve growth. Levels are down in diabetes. So this is the paper where we have shown these netrin-1 levels to be down in diabetes, and so this opens up the possibility for a potential intervention if you can upregulate netrin-1, or I will show you in a second from now, this netrin-1 is regulated by an inhibitory microRNA, and which we have identified in this microRNA, which actually inhibits netrin-1. So now we have regulators for this microRNA. So you block this microRNA and upregulate netrin-1, prevent diabetic neuropathy. So that's the message here. So DFUs are highly preventable, highly prevalent but largely preventable. A 2-minute foot examination at each visit, and a comprehensive examination annually in a tertiary care center, which I'm sure Pankaj will set up over time. So all DFUs will heal with control of glycemia, infection, and adequate blood flow. Tight glycemic control is the only intervention shown to prevent onset of diabetic neuropathy and delays progression type 1 diabetes. But as far as type 2 diabetes is concerned, there is no clear correlation between glycemic control, like I said before, and the onset of neuropathy. Prompt referral of the high-risk foot, which you can easily identify with a 2-minute examination, and sending them over to the experts may prevent the loss of foot, limb, and lives. Thank you for listening.
Thank you, Professor Mukhopadhyay, for the excellent presentation and explaining in details about the diagnostic and treatment and therapeutic modalities in management of diabetic ulcers and diabetic foot. Now, I would like to open the floor to the audience for a couple of questions, if they have any.
Maybe I'm standing between you and the lunch.
Thank you.
So no
Thank
questions.
you so much, sir, for
Thank
that
you.
already descriptive talk. I request sir to please come here at the photo booth along with the chairpersons who would felicitate our speaker. We quickly move on to the pre-lunch session, which will be about fatty liver disease, and to chair the session we have Dr. Manojit Mandal, President IMA Purulia, Dr. Gobindo Banerjee, who is the BMOH of Muraddi Block Hospital, and Dr. Gautam De, pathologist and faculty at the Department of Pathology, Deben Mahata Government Medical College Hospital, Purulia. And to deliver the talk, we have a close associate and friend, Dr. Amarth Shankar Chaudhary, who is a senior endocrinologist from Durgapur.
এদিকে পয়েন্টেড আবার করি স্যার
এটাও চলবে কিন্তু এটা কি হয় মানে লাইটটা জ্বলছে কিন্তু লাইটটা ফোকাস হচ্ছে না মানে খুবই হালকা শুরু হয়ে গেছে মানে লাইটের ইয়েটা ফোকাসটা কমে গেছে এটা এখানে পয়েন্ট
কাউটা কি যাবে
এই যে পয়েন্ট ঘুরবে ঘুরে যখন চোখে ঘুরে আসবে ঠিক আছে শুরু করব নাকি শুরু Thank you, respected chairperson. Thank you, Dr. Pankaj Singhania. Thank you, Dr. Akash, for inviting me to this wonderful location for this Purulia update. So without wasting further time, I'll move on to my topic. Grade 1 fatty liver, is this significant, and an approach to MSLD. Now we all know, just like diabetes, obesity, MSLD is just another pandemic which is still growing. 1 out of 3 Indians are affected, and also the prevalence is rising in children, which is definitely a cause of concern. Now the histological spectrum of MSLD, it spreads across from just early steatotic liver disease, or previously the non-alcoholic fatty liver, then progresses to steatohepatitis, NASH, various stages of fibrosis, and then finally progress into cirrhosis with an increase in chances of developing hepatocellular carcinoma later on. Now, since 1 year, the nomenclature has changed. Earlier, you used to call it NFLD. It still exists, but yes, the better terminology is MASLD, or metabolic dysfunction associated steatotic liver disease. There should be a liver fat or steatotic liver disease of more than 5%, along with a cardiometabolic risk factor. So, the cardiometabolic risk factors are nothing but just like the components of metabolic syndrome. We have elevated triglycerides of more than 150, low HDL, patient with diabetes, prediabetes, obesity, and high blood pressure. So along with these, if any one of these present, then we can say the patient is having MASLD. But there are some other conditions where the patient might not be having a metabolic disease. And then we have to look into the alcohol content. If the patient has, if it's a female taking more than 20 to 50 grams of alcohol, it's a male taking more than 30 to 60 grams of alcohol daily, then the nomenclature changes to MET-ALD. If the patient drinks more than 50 grams of alcohol in female and more than 60 grams of alcohol in male, then it is an alcoholic liver disease. Neither of these, then we have to look for other causes. It can be a hepatitis C virus infections, it can be a cryptogenic SLD, it can be a drug-induced liver disease as well. Now coming to the ultrasound liver. Now before going into the grade 1 liver, whether it is significant, just like to highlight few points on what we see usually when we have a report of ultrasonography of the liver. So liver steatosis basically can be diagnosed when we have around more than 25 to 30%. Some of the studies have shown that if the liver fat content is more than 33%, ultrasonography has a sensitivity of identifying fatty liver. It is almost 90% of cases. So what we see in ultrasonography, we see the liver size of the liver, the amount of fat in the liver, and the distribution of fat in the liver. So this is, as you can see, if the pointer is working, yes. So this part is the right lobe of the liver. You can see the right lobe is enlarged. Cutoff is 15 centimeter. So here the cut of the length is around 17 centimeters, so definitely is enlarged. This part is the kidney. I'll come to the kidney part later on, but it has a lot of significance. So amount of fat, depending on the amount of fat, it is classified as grade 1, grade 2, grade 3. And the sonography description is based on liver echogenicity, liver-kidney contrast, gallbladder wall, vessels, and diaphragm, how clearly it is visible in the ultrasonography. So this is a normal ultrasonography, just to see how the pattern, the normal pattern works. You can see this part is the right lobe of the liver, and this is the kidney. This is the renal cortex. as you can see, the echogenicity of this is almost same. Liver and the kidney echogenicity is same. That means it is a normal ultrasonography of the liver. There is no increased fat. You can see the gallbladder here, and the gallbladder wall is clearly seen visible. You can see the portal vessels, and the vessels wall are clearly visible, and you can see the hepatic veins also, which is clearly visible. So if these other structures are clearly visible, there is no difference in echogenicity of the liver and the right cranial cortex, then definitely it's a normal ultrasonography. Now what happens in grade 1 fatty liver? Grade 1 fatty liver, there is diffuse increase in echogenicity of the liver. That means it's a bright liver compared to the echogenicity of the right renal cortex. You can see here now the echogenicity has changed. The echogenicity of the liver is increased compared to the right renal cortex. But at the same time, the diaphragm is clearly visible, and the portal vessels with the vessel wall is also clearly visible. So this is grade 1 fatty liver. Just to compare with the normal, you can see the echogenicity has changed in this picture of grade 1 fatty liver. Grade 2 fatty liver, there is further increase in brightness of the liver. Now, the diaphragm is visible, but it is less distinct. You can see the contour of the portal vessels, portal veins is now less distinct. The walls are not visible. So it is more brighter. Because of the brightness of the liver, there is posterior attenuation. Rest of the structures are not quite well visible. So this is grade 2 fatty liver. See, again, the gallbladder is visible, but the walls are not clearly visible. Grade 3, the attenuation of the ultrasound beam does not allow to visualize the diaphragm profile at all. So grade 3, it's only the liver which is being seen, the renal cortex is not seen, neither the diaphragm is seen, the portal vessels are not seen. So this is how they quantify basically the advanced steatosis, excessive steatosis on grade 1, grade 2, grade 3. Now, what implication does it have on us? So basically ultrasound is a screening tool. Based on ultrasound, we cannot say the patient is having fibrosis. It has limitations in establishing steatohepatitis, so early stages of fibrosis. Patient has progressed into advanced fibrosis, chronic liver disease. There are some certain points where ultrasound can pick up, but early stages cannot be picked up. So what next to be done? Now this is as per the latest guidelines. If we find steatosis in any imaging, we have to subject the patient to further test to know if the patient is developing MSLD with fibrosis. And this is again the AACE guidelines. The people who should be evaluated are those having obesity with any one of the metabolic parameters, type 2 diabetes, pre-diabetes, any steatosis in any imaging study like the ultrasonography, and those who are having a persistently high ALT, AST more than 6 months. So how do we proceed next to evaluate? We do a FIB4. This is probably the most easiest, cost-effective early screening of fibrosis. Only 4 parameters are needed: age, AST, ALT, and platelet. It's very easy. There are online calculators. Just write FIB4. It will come down. You can place these values. You can calculate the FIB4. So once you have the FIB4, you can follow this latest algorithm. This is published recently in September 2024 by the joint EASD-ESL. FIB4 less than 1.3, need not worry. You can just follow up every 1 to 2 years. FIB4 more than 2.67 is very high, indicates the patient is having fibrosis, needs further evaluation by hepatologist, gastroenterologist. Between 1.3 and 2.67, they need further tests. And the most commonly which is done is a vibration controlled elastography. The cutoff is 8 kilopascal. If it is less than 8, again, you have to control the comorbid conditions, better lifestyle, follow up. More than 8, again, needs further evaluation to rule out the fibrosis and evaluate for further management. Now, this is what is being done in most centers, the FibroScan, vibration control elastography. It is a non-invasive quantification of liver fibrosis and can also quantify the amount of liver fat. This is the basic cutoff, which is the machine based on the internal analysis. However, it varies depending on the etiology of the steatotic liver disease. But most common guidelines recommend 8 kilopascal as a cutoff to actually move forward with that patient is having fibrosis. Now, there is another recent update on the advantages of this non-invasive vibration control elastography. With the use of this, you can identify whether the patient is having clinically significant portal hypertension. If the LSM is less than 15 kilopascal and the platelet count is more than 150 or 1.5 lakh, it can be used to rule out that the patient is having portal hypertension. This is again very useful because it's a non-invasive test to identify whether the patient is having clinically significant portal hypertension. Now coming to the management, the mainstay of management definitely is lifestyle modification and exercise. We have had sessions on weight reducing drugs, obesity by Dr. Umesh Garg. managing comorbidities like type 2 diabetes and obesity, pharmacotherapy, and bariatric surgery is a very good option in those where definitely the surgery is indicated. So weight reduction is the key. We need around 7 to 10% of weight loss. Around 500 to 750 calorie deficit should be advised. Mediterranean diet has shown remarkable recovery. Coffee, black coffee in some observational studies have shown to improve non-alcoholic fatty liver disease. So a diet which is hypocaloric, low in fat, low in carb, Mediterranean diet, avoid ultra-processed food, avoid sweetened drinks. Now, we have a lot of evidence and trials on the benefits of intermittent fasting, time-restricted eating, ketogenic diet. But as of now, as per the latest guidelines, we do not have enough evidence to suggest these form of diet as a management in an MSLD or rather obesity and diabetes. Physical activity is very important. Avoidance of smoking is very important. Alcohol should be restricted. Smoking has been found to increase the progression of MSLD as well as development of hepatocellular carcinoma. So at least 3% of weight loss have shown to reduce steatosis. More than 10% has been shown to regress fibrosis as well. So you can understand the benefits of diet and exercise. Now, coming to pharmacotherapy, this is again as per the latest guidelines published in 2024. As of now, as of today, there is only one drug which is approved, FDA approved for the treatment of MASH, and that is resmetirom. I will coming to it in the later slides. The rest of the drugs we have is actually to control the other comorbid conditions, diabetes and obesity. If the patient has diabetes, we treat with GLP-1 receptor agonist or a GLP-1 GIP co-agonist like tirzepatide, SGLT2 inhibitors. Pioglitazone is one drug used in NFLD, metformin, and insulin. If the patient has obesity, definitely GLP-1 receptor agonists are preferred, and the patient has dyslipidemia, statin therapy. Now, all these drugs, basically, the MASH-directed therapy is only for non-cirrhotic MASH. Mind you, patient has gone into cirrhosis, there is no targeted therapy. All the targeted therapies should be avoided. Now, resmetirom, the newly approved drug, basically is an orally active thyroid hormone receptor agonist with high selectivity for beta-1 receptor. It is approved, again, I have mentioned, in non-cirrhotic MASH, and it has come with a guidance that once the patient develops MASH-related fibrosis, we need to refer to a hepatologist and gastroenterologist who should start this drug. Now, how does it act? Now, basically, thyroid hormone reduces hepatic steatosis by stimulating hepatic lipophagy, mitochondrial biogenesis, inhibiting hepatic lipogenesis. Thyroid hormones also interfere with fibrogenesis, interfering with TGF-beta signaling. So thyromimetics are getting developed, which have been evaluated, which acts on the beta subtype of the thyroid hormone receptor, and resmetirom is one such receptor acting on beta-1 subtype. So we have the clinical trial, the phase 3 clinical trial, the Maestro MASH, where resmetirom, patients receiving resmetirom, it was seen that around 29% there was NASH resolution with no worsening of fibrosis, and around 25% those who received resmetirom of 100 milligram, there was improvement in fibrosis by more than 1 point stage with no worsening of NFLD's activity score. In the US, it is being used at the dose of 80 milligram with those with the body weight of less than 100 and 100 milligram with the dose with the body weight of more than 100. And the most common side effects were diarrhea, nausea, pruritus, and vomiting. Semaglutide, a lot of things have been mentioned already by Dr. Umesh Garg. This is again a very exciting time for semaglutide. The ESSENCE trial results will be published in 2025, and semaglutide has also demonstrated significant benefit in resolution of steatohepatitis as well as regression of fibrosis. And the company has already announced that they will apply for a regulatory approval in the first half of January 2025. Similarly, tirzepatide has also shown a lot of promise and probably is another drug which will be approved in the near future. There are a lot of other trials and drugs on the pipeline. The scope is limited because of lack of time. I won't go into the details. There are a lot of other trials, drugs which are being tried and probably might be available in the near future for the treatment of MSLD. Now, for the Indian context, we have pioglitazone, which is approved in patients with type 2 diabetes with MSLD. It can be given. Pioglitazone has its own side effects, and we need to individualize the treatment. Now, coming to the Indian drug we have. Even the new recent guidelines, ESD-ESL, mentions saroglitazar, which is a dual PPAR alpha and gamma agonist, which has shown to improve insulin sensitivity, reduce insulin resistance, liver steatosis, and liver enzyme. It is approved in India for the treatment of NFLD. It was approved in India since 2020. We have small biopsy-proven studies with saroglitazar. This is a one-year study on saroglitazar, where it was seen that the drug was able to reduce NFLD activity score by more than equal to 2 points in 52% of patients without worsening of fibrosis. So for Indian context, we do have saroglitazar. Then there are a lot of other off-label drugs for the treatment of NFLD. They have not shown significant benefit in reduction in fibrosis, and therefore they are not approved for the treatment. But we have vitamin E, which was in PVENS trial, had shown that in patients without diabetes, vitamin E is beneficial, not with diabetes. Then obeticholic acid is another farnesoid X receptor agonist which had been tried, but because of increasing side effects of pruritus, hepatic dysfunction, these drugs are used less. Now, this is another category which I need to discuss probably. We are all concerned with obese MSLD. Now, this is a group where it is a normal weight MSLD where patients are having steatotic liver disease, but the BMI is low, less than 23 as per Indian standards. Now, they have also a high prevalence of insulin resistance, visceral obesity, and decreased muscle mass. Even in these group of patients, 3 to 5% weight reduction has led to remission of MSLD in 50% of individuals. And the current guidelines recommends 3 to 5% weight loss as a treatment or management of normal weight MSLD as well. Now, finally, once the patient progresses to cirrhosis, the pharmacotherapy is very limited. We cannot give any MASH-directed therapy. Diet, lifestyle, nutrition, preventing sarcopenia are the mainstay of therapy. And this is the standard recommendation, again, usage of diabetic medications in the most recent article. Metformin can be used in compensated cirrhosis. We have to stop in decompensated cirrhosis. Sulfonylureas should be avoided because of hypoglycemia. GLP-1 receptor agonists have evidence of safety in child A category. SGLT2 inhibitors can be used in class A, class B child category. Statins can be used in chronic liver disease. Do not stop statins if the patient develops chronic liver disease because they have very higher risk of cardiometabolic or cardiac events. We need to control dyslipidemia. And the final slide, based on the latest ADA 2025 guideline, is a complete summary of how we should approach the treatment of MSLD. Stage 1 or F0, F1 fibrosis, patient has MSLD but does not have fibrosis. We treat comorbid conditions of diabetes and obesity with the available drugs, GLP-1 receptor agonist, in diabetes, GLP-1, SGLT2 inhibitors, pioglitazone. We do not need MASH pharmacotherapy at this point of time. Fibrosis stage 2, stage 3, along with drugs for obesity, diabetes, we can use resmetirom. For Indian context, we have saroglitazar, which is approved for the treatment of MSLD with fibrosis. Compensated cirrhosis, again, we have to stop MASH therapy. We can continue treatment of diabetes and obesity. And in decompensated cirrhosis, we have very limited role of pharmacotherapy. For treatment of diabetes, we can only use insulin. It's only diet, nutrition, and supportive measures. So with this, I thank the organizer once again. I thank you for your patient hearing. I must acknowledge the help of my colleague, Dr. Aniket Mondol, who is a consultant radiologist, for giving me the ultrasound pictures. And my knowledge of ultrasound is only 3 days, as old as my PPT. So don't ask me too many questions on ultrasonography. So Dr. Aniket has given me a lot of ideas about ultrasound liver. And Dr. Umesh, I think we should all thank him for the timely, he always has the time to send the articles because articles are not easily available. He always has the time to send the articles, even at midnight. Thank you all for your patient hearing.
Thank you, Dr. Amurthu, for that enlightening talk on one of the ignored complications of diabetes.
Thanks, Dr. Amartya Shankar Chaudhary, for very elaborate presentation. Now I open the case to the House for any question or query.
If there are none, Satrajit has a question, I believe. Please.
If there is none,
Satrajit has a question.
Because where the cost is an issue.
That's why the later slides, if you can look, like semaglutide is still not approved. They will apply for regulatory approval in 2025. It is just the ESSENCE trial is still not published. It is the interim results which have been presented in one of the conferences. Right. So once it is approved, definitely we can use in those who need it. But again, cost is definitely an issue. So for Indian context, we have to still stick to the drugs which are cheaper. Pioglitazone is definitely, it's approved by ADA. The problem with pioglitazone, all the trials and studies where pioglitazone has shown benefit is 30 milligram or 45 milligram. 45 milligram we never use, even 30 milligram are used less. 15 milligram in one study, they had shown improvement in liver transaminases, reduction of steatosis, but no improvement in fibrosis. So at least some benefit we'll be offering. Secondly, again, saroglitazar is there. Even the ESD, ESL acknowledges the presence of, they have not approved, they have acknowledged the presence of saroglitazar as a drug which is approved in India for the treatment of NFLD. We do not have long-term data. The data which is there for 52 weeks, we have to be cautious. We can give for 1 year, then probably a gap is needed, because the earlier PPAR gamma, this combined agonist, the mudaglitazar had a lot of cardiac side effects. Even though in saroglitazar the PPAR gamma action is less, probably because of that the cardiovascular actions or side effects will be less, but still we need to be cautious. But as of now, probably pioglitazone, saroglitazar, weight reduction, which I have already mentioned, these are the only options we have other than control of comorbid conditions.
Thank you.
Dr. Manojit Mandal has a comment.
The problem is this term is the non-alcoholic fatty liver disease we are using for last 30 years. Now for last 3-4 years we are using MSLD because it is associated with the metabolic disease. And in this situation, those drugs still we are using like ursodeoxycholic acid, obeticholic acid. This is very unfortunate because this drug has no role at all. Saroglitazone is still some role and still many of the studies is going on. The problem is lean subject with MSLD. Obese with MSLD, its treatment is to some extent easy. A lean subject, what will prefer?
Excellent question, sir. I think this is probably a query not for you, but for everyone, and probably it is for the first time in the joint ESL-EASD update published in 2024 September. They have specifically added a group of normal weight MSLD. It was not there. And probably in Indians, we have a more of normal weight MSLD, and that is definitely because of the increased visceral fat. We are thin fat Indians, that this visceral fat is bad, which has high insulin resistance, less insulin sensitivity, promoting MSLD, promoting MET-SLD. Even in these group of patients, the studies have shown, as I've mentioned, even a 3 to 5% body weight loss. So the patient is around 60 kg. If the patient loses 3 kg weight loss, it has shown that the MSLD component has come down by 50%. And that is the recommended treatment as of now for diet and lifestyle. And whatever the approved drugs we have, for example, if resmetirom is available, then resmetirom, saroglitazar is available, then saroglitazar. These are the drugs that definitely can be tried in this group of individuals as well, whenever indicated.
Thank you, Dr. Amurtho. And yeah.
If you have a grade 1 fatty liver and no NASH, how will you treat them?
Yeah,
or will you
see,
treat them or not treat them?
very good question, because lack of time, I cannot go into the details of what. Ultrasound is just a screening, I'm telling you. And the mass screening is still not approved or advised. So because of some other diseases we have done an ultrasound shows USG fatty liver. Only thing approved in the guideline and algorithm, you have to do a FIB4. If FIB4 less than 1.3, you sit and enjoy your meal.
Thank you, Amurtho, and to the photo booth with the chairpersons. Chairpersons and Amurtho to the photo booth for the felicitation. A big round of applause for Dr. Amurtho Shankar Chaudhary. We will break for lunch and we will meet sharp again at 3 p.m. for the post-lunch sessions, which I promise are equally interesting. At the end of the CMEs today, we have also arranged a cultural program, the Chau Nach program of Purulia district, right behind us, behind the hall. And lunch is being served downstairs at the back gate in the vintage hall, vintage lawn. Please enjoy your lunch and be ready for the post-lunch sessions and get back by 3 p.m. please. Thank you, and we'll meet again.
Good afternoon, everyone. Good afternoon. I welcome you all to this post-lunch session. We are about to begin, and I promise we still have a couple of sessions which are as tasty as the lunch which was laid down, and you will be gaining from whatever will be discussed in the sessions hereafter. We have a thrilling debate lined up for this immediate post-lunch session to be moderated by our organizing chairperson, Dr. Akash Panigrahi, a budding renowned endocrinologist from the neighboring city of Jamshedpur.
I couldn't understand what to say.
Good afternoon, everyone. I hope you have enjoyed the lunch. And because it's post-lunch, we will spice up it with little bit of debate to keep the crowd awake. We all have used sulfonylurea for pretty long times, and we know these are cheap and effective medication, obviously with some demerits. But should they retire altogether with all the new molecules coming up with better safety profile, better organ protection? Do sulfonylurea need to retire? That is the question we have today. And we have today two very good speakers with us. I would like to introduce Dr. Binay Dhandania sir, who is a senior secretary and chairman elect of RSSDI Jharkhand. Sir is a renowned speaker and have lots of publications. So sir will be speaking for the motion actually. And against the motion, we have Dr. Satrajit Roy, who is HOD, Department of Medicine, Central Hospital, ECL. So he will be speaking against the motion. And at the end, we will take some audience questions and maybe a poll. So to begin the debate, I request Dr. Binay Dhandania sir to speak for the motion. Sir, the time limit will be 8 minutes, and you will get 2 minutes for rebuttal.
Good afternoon. At the onset, I would like to thank the organizers for this opportunity. It's not going to be a debate which you see in televisions these days. I'm not anyone like Republic TV or Aaj Tak TV. I'm just going to present the facts, not stories. So diabetes and obesity update Purulia, a big congratulations to the organizing team. The topic here is sulfonylurea should retire. And I say yes. Is old always a gold? Now, how many of us are using this phone? Anyone? Can you please raise your hand? You must be having something like intercom connection or somewhere in your house, but definitely very few people are using this phone. It's still there in everyone's house. And maybe you can have options which can help you for multitasking. So every one of us are using this, any type of phone which is available today. And why we are using? Because we have added advantage to it, isn't it? That is the why people are using 2 phones and 3 phones as well at one time. So sulfonylurea should retire and live life of a patron. This is what is very, very important to understand. It should not die. It has a role in controlling plasma glucose with poor durability. We have UKPDS data with sulfonylurea, and which has shown that it actually lowers your blood glucose and helps in controlling HbA1c, but beyond that, nothing else. Sulfonylurea fails in multitasking, like CAD prevention, heart failure prevention, NAFLD, obesity, CKD, and in fact, it causes more of hypoglycemia, which is very, very detrimental. So if you see, there is no other role of sulfonylurea beyond glycemic control. And that also is a very poor durability, has a very poor durability. These are the drugs which are available today: sulfonylureas, GLP-1 receptor agonists. You heard so many lectures: DPP-4 inhibitors, metformin, glitazones, SGLT2 inhibitors. Then what is important and different between sulfonylureas and other drugs? Except insulin and sulfonylurea, most of the drugs hardly cause hypoglycemia. Most of the drugs actually address some pathophysiology of type 2 diabetes, unlike sulfonylureas. So these are very important differences which we have with other drugs in the basket today. And this is how there's an evolution of anti-diabetic medications. There are a lot of concerns with sulfonylurea. Is hypoglycemia, weight gain, belief that they accelerate beta pancreatic cell failure. There are questionings regarding the cardiovascular safety, durability of the action. The tendency to cause hypoglycemia is very well established, and this is very, very critical in patients who are elderly. And believe me, 40 to 50% of your patients in clinics are elderly. Patients with CKD or early CKD can have very, very severe hypoglycemia and very difficult to revert them. You need to hospitalize them. The cost of therapy is remarkable. It takes 2 to 3 days time to revert back their hypoglycemia. You have to use drugs like octreotide. Chronic liver disease, you heard in the previous lecture, you should avoid sulfonylureas. Heart failure, CAD, and people with multiple comorbidities, you would avoid these classes of drugs. Weight gain, no one would like to have weight gain today, especially in people who are obese or overweight. And there's again a very lot of data to support that weight gain again becomes a risk factor for multiple comorbidities. And drugs like sulfonylureas are known to cause weight gain. Now, even failure of sulfonylureas is very well established. If you see even the UK PDS data, the UK PDS data was having 3 arms, sulfonylurea one arm, metformin another arm, insulin another arm. And people who were in receiving sulfonylurea received a second drug earlier for maintenance of HbA1c in the intensive arm. So durability of action is a real big concern with sulfonylureas. The another example of durability with sulfonylureas is the ADOPT trial. Though the ADOPT trial was done in comparison with rosiglitazone, but ADOPT trial was very, very informative in the sense the sulfonylureas have poor durability. So questions regarding cardiovascular safety of sulfonylurea is again a big concern, and this is one of the data which came from UGDP, where the genesis of sulfonylurea CV controversy was started out. The drug was tolbutamide. It was available by the name of rastinon, which is now no more available today. And this led some experts to conclude that sulfonylureas as a class were associated with increased cardiovascular mortality, with others criticized the design and analysis of UGDP. Even this meta-analysis very clearly suggests that sulfonylurea therapy had a higher risk of major cardiovascular risk compared to other glucose-lowering drugs. So you can imagine we have enormous data to suggest that sulfonylureas should be used with caution or avoided as far as possible. So drug choice in even type 2 diabetes, you will find that the priority should be different. I have missed a slide where you will see that the ACE guideline, AACE guideline, or the ADA guideline has kept sulfonylurea at the lowest possible place after GLP-1 and SGLT2 and DPP-4 like that, as the lowest rack of use of sulfonylurea in clinical practice. The poor choice is because of not addressing these problems of prevention of heart failure or even CKD, CAD, no benefits in obese type 2 diabetics, patients with NAFLD, CLD, or even they have a lot of drug interaction. And believe me, cost is a real big challenge. People talk about sulfonylurea is cost effective, and I can challenge you, you buy a tablet of diamicron XR Max, one tablet of 60 milligram with 500 milligram of metformin is 20 rupees, and you buy a tablet of UDAPA-M, which is SGLT2 inhibitor plus metformin, it's 10 rupees a tablet. So cost is no more a barrier today. In fact, a lot of combinations of sulfonylurea metformin are expensive than the other drugs which are easily available today. So even the combination of DPP-4, metformin, SGLT2 inhibitors, and metformin combination, the triple drug combination come at a cost of 20 rupees. Unlike other drug combination with sulfonylurea, they are very, very expensive today. So this is the place of sulfonylurea in the management of type 2 diabetes. You have to replace with metformin, gliptin or gliflozin, GLP-1 receptor agonist, or other drugs. And if you find if your HbA1c is very high, then instead of adding sulfonylurea, you can add a basal insulin. So these are the profiles. This data suggests a consensus slowly but increasingly aligning with the current national indication of dismissing sulfonylurea for the treatment of type 2 diabetes. So this is how it's been compared with other drugs. And if you see the benefit and the risk, the pro is good glucose lowering agent, low cost and long clinical experience, but you will find at a very high cost of hypoglycemia, very expensive hospitalization with hypoglycemia in a city like Ranchi will cost you almost 25 to 50,000 rupees. Weight gain, controversy, CV safety, and no other benefits as far as cardiorenal benefits are concerned. So I thank you all for your patient listening, and I hope I finished in time. Thank you.
Thank you, sir. Please have a seat. Now I request Dr. Satyajit Roy. He will be speaking against the motion.
Good afternoon, my respected teachers, delegates. Thank you for this opportunity for the Purulia Diabetes and Obesity Upset, especially Pankaj Singhaniada for giving me the opportunity. Today, Dr. Dhandania has told and described the sulfonylurea should retire. So I will talk against the motion. I think that sulfonylurea shouldn't retire. Why? There are several, when we are choosing a drug, basically we have to think whether the drug is safe and is there any trial or data in favor of the drug. Basically, the discovery of the sulfonylurea is an accident. When it was trying for discovery of the medicine against the typhoid, they discovered the sulfonylurea, which causes the reduction of blood glucose in the animal model as well as later on the human being. How many of you here who are practicing diabetes here using sulfonylurea? Everybody is sulfonylurea. All the endocrinologists, they are using the sulfonylurea. Okay, so when we are using, we will see the efficacy, we will see the safety and the vascular benefits. There are several trials regarding the efficacy and safety and obviously vascular benefits. First is the UKPDS trial, the post-trial monitoring of the randomized control trial of the intensive glycemic control in the type 2 diabetes extended from 10 years to the 24 years. And the results, and the interpretation of the trial, early intensive glycemic control with sulfonylurea or insulin or with metformin compared with the conventional glycemic control appears to confer a near lifelong reduced risk of death and myocardial infarction. Achieving near normoglycemia immediately following the diagnosis might be essential to minimize the lifetime risk of diabetes-related complication to the greatest extent possible. So UKPDS is always in favor of the sulfonylurea. Now what are the medication, oral agent used proper to the treatment of the diabetes? Commonly metformin, sulfonylureas, thiazolidinediones, DPP-4 inhibitors and SGLT2 inhibitors. Commonly we use. What are the HbA1c control? We see the highest HbA1c control is with metformin, either with the sulfonylureas. A trial study conducted in Denmark showed the efficacy of the anti-hyperglycemic agent. The trial is a population-based trial that shows the HbA1c reduction with the sulfonylurea is better than the DPP-4 inhibitors. Now come to the advanced trial. What is the advanced trial say? The primary study outcome were a composite of the macrovascular event with the composite of the microvascular event considered both jointly and separately. The 4 out of 5 patients achieved HbA1c less than 7 in the advanced trial, where we used the glycoside XR 60. It's not good. The intensive treatment regime with glycoside XR based regime provided the efficient glycemic control irrespective of the patient profile. So there is decrease in the vascular events as per the advanced study. There is 10% relative risk reductions of the primary endpoints with intensive glucose control with glycoside MR. There is improvement in the renal outcomes also. As per the advanced study, there is a significant improvement in the renal outcome also. And as advanced on study, they show the legacy effect, 46% reductions in the ESRD when we are using the sulfonylureas in a 10 years follow-up. Now come to the question that arises by Dr. Dhandania regarding the weight gain. The weight gain, as Accord and UKPD is showing, there is some few weight gain, but as per advanced trial, there is no weight gain is documented. Regarding the CV outcome of the glimepiride and metformin, linagliptin compared in the Carolina trial, that showed that non-inferiority from the 3-point measure of the linagliptin versus glimepiride. So the risk of CV mortality or overall mortality was not different between the groups. The GRADE trial is also shown. There are the comparative effectiveness of the glycoside modified release versus sitagliptin as a second line in the treatment of the after metformin monotherapy in patient with uncontrolled T2DM that showed that there is also a reduced risk of hypoglycemia. The Z register in the over the Asian patients that also showed the beneficial role of the sulfonylureas. In Asia, sulfonylureas are popular oral glucose lowering class and often combined with metformin, good glycemic control, safety profile associated with the issues including glycoside support their position as a key treatment option in the patient with type 2 diabetes mellitus. As per the Z register, glycoside-based treatment is associated with improved quality of life compared with the other issues used in the Asian patient with type 2 diabetes. Glycoside can be used in the CKD patient. Even patient is not in dialysis, we can use in the stage 3, stage 4 or stage 5 CKD patient the glycosides. And there is some genetic variation at the SU receptors. I am not going into the details of this. And also the precision medicine with the sulfonylurea study conducted by Dr. Mohan and Dr. Soumik Goswami. This is the study here, so the certain populations where the sulfonylurea works better with this. And overall the ICMR data in DAB study that showed in spite of the availability of the all medication, still the maximum number of Indian patients, they are suffering from the uncontrolled diabetes. Their HbA1c is still more than 7. So still in India, when we are treating our patient, in spite of there are so many contraindications, or you can say there are so many questions with the weight gain, CV mortality, all other things, the sulfonylurea is still the drug of choice. We can say, Professor Shamul Kundu is here, sir, told us that it's a poor man insulin. When we are treating a patient in the Purulia, Asansol, Bankura, we are giving the patients and saying, suppose they are patient in the Ajodhya part, will they follow the insulin? They will not follow the insulin. Our treatment is the OAD, among the OAD, sulfonylurea is still the treatment of choice. Thank you everybody for your patience sharing, and I am acknowledged Dr. Soumik Goswami and Professor Shamul Kundu for this lecture. Thank you.
Yeah, thank you. Now it's time for rebuttal. Dr. Dhandani.
Dr. Satyajit, good job. Congratulations. Few things. UK PDS study is definitely a landmark study, and as I said, sulfonylureas only have a role in glycemic control. And that is what from UK PDS, that newly detected type 2 diabetic patients, if you have an HbA1c less than 7%, you have benefits in microvascular complication. That's it. But how many of us are sitting here using glibenclamide or chlorpropamide? They started with chlorpropamide and they ended with glibenclamide. Are we using both these sulfonylureas? We don't. He's talking about advanced study where there is no weight gain. But he has also quoted 2 of the studies where there is weight gain. But all of them are not using the same sulfonylurea. But if you see the SGLT2 inhibitors, you use any SGLT2 inhibitors, you get weight reduction, you get blood pressure reduction, you get benefits in heart failure, irrespective of the type of SGLT2 inhibitors you use. Use DPP4 inhibitors. This is one drug which can be used blindly to each and every patient. You pick up linagliptin, CKD, any stage, liver function, any stage, diabetes, any stage, you can add this class of drugs blindly. No jhamela, nothing. This is the type of drugs which we are talking today. This was not there in the era of UK PDS. This was not there in the era of advanced study and ACCORD study. That is the reason you had a bad data in ACCORD study. They had to stop this particular study in between. But if you see studies like Credence, you had such a fantastic data, beech mein band karna pada study ko itna badhiya data, it need not continue also. So what we are talking today is that sulfonylureas should retire and live like a patron. We are not saying sulfonylureas should die. When you need only glycemic control, you use it. But when you're talking about pathophysiological mechanisms of diabetes and preventing cardiorenal outcomes and NAFLD and liver disease in diabetes today, you are understanding the pathophysiology better and better with times to coming. They don't have much place today. They should be having a place lower down. Even the best associations, if you see the ACE guidelines, the ADA guidelines, they have kept sulfonylurea like a patron at the lowest end of the tertile. So we don't say we don't use sulfonylurea, but not as a first drug after metformin. Much, much below that, we have better drugs, safer drugs, better patient compliance, And let me tell you, once the patient gets hypoglycemia, अरे यार ये दवा खा के तो मैं मर ही जाता था. He will go to Ramdev Baba and some alternative therapies. अरे ये इसको तो छोड़ो किनारे. This would have taken my life because of these medicines. So this is what the feedback of the patients are. So if you have a drug like DPP-4, SGLT2, which hardly documents hypoglycemia along with metformin, why to start with sulfonylurea, metformin and other drugs?
Yeah, thank you, sir. Point well taken. Now it's time for Dr. Satyajit for the re-rebuttal.
Sir has mentioned again the drawbacks of sulfonylureas. But you don't put all sulfonylureas in the same bracket. Glibenclamide, glimepiride, glycosides, all are not same. Hypoglycemia, weight gain, CV mortality, this is very less with the use of glycoside XR. The advanced trial, even the advanced on trial that has proved it. There are so many trials. Not only that, when a patient coming to us with a high blood sugar level, what is our approach? Our approach is to control the blood sugar. We have to control the blood sugar. We have the minimal options. We have the minimal option. Among the minimal option, we have to start the sulfonylureas unless there is the severe any contraindication. We have to start the sulfonylureas. Although there are few drawbacks, even paracetamol has been some drawbacks, some contraindications also. So we are not using the paracetamol. We will use the sulfonylureas. Still, the very other alternatives comes and other cheap alternative comes to us. Thank you.
Yeah, thank you. Thank you both. Now, all of us, we admit that sulfonylurea are not the best in class, or I would say not the best widely available, but obviously they do have a place. Now, I will invite one or two audience reaction. Yeah, sir, please. Yes, sir.
Yeah, I congratulate Pankaj for including this thought-provoking debate, and both of the debaters have done exceedingly well. I do agree with Vinay that DPP-4 inhibitors are the easiest class of anti-diabetic agents to prescribe, KFE prescription. Having said that, we all gloat about the pleiotropic benefits of GLP-1 agonist, SGLT2 inhibitors, so on and so forth. At times, this is an advice to the juniors. We forget that any pleiotropic benefit is on top of glycemic control. So first you have to achieve glycemic control, and sulfonylureas remain efficacious, and the modern one remains efficacious and reasonably safe agents for glycemic control. Maybe they do not have the pleiotropic benefits, or their pleiotropic benefits have not been highlighted, but let's not be carried away by the pleiotropic benefits of the newer agents, because the first thing first comes effective maintenance of glycemia, then the pleiotropic benefits.
Yes, sir, rightly pointed out. When the going gets tough, actually we do depend on sulfonylurea on many times. Any other audience reaction? Yeah, sir. This will be the last, then I will just sum up. Yes, sir, please.
Yes, good afternoon to everybody. There is a very wonderful explanation regarding the genesis of sulfonylurea. We know very well in the initiation of diabetic therapy, the newly patient has been diagnosed and the patient has been given sulfonylurea for the first time, with the education to the people, particularly the rural people who is not providing with any glucometer. The hypoglycemia is the event. But nowadays, most of the patient, I seen in my career of 52 years of surveys in this field, that I've seen many patients are having sulfonylurea for a long time. If there is OHA failure in the primary drug, we'll go for DPP-4 inhibitor or SGLT2 inhibitor. One thing is to remind, particularly the patient should be educated, patient is mobilized for the advent of hypoglycemia with a chart of diet chart, and niche lekha thakbe যে আমরা যদি ঘাম ঝরে, আমরা কিছু দুর্বলতা ভোগ হয়, মাথা ঘোরে, তাহলে কিন্তু সঙ্গে সঙ্গে চিনি খাবেন বা সুগার খাবেন, চকলেট খাবেন। এইটাই হচ্ছে আমাদের ইন্ডিয়ার ইকোনমিক সিনারিও। সেই ইন্ডিয়া ইকোনমিক সিনারিও সালফোনিল ইজ দ্য বেস্ট ওয়ান ফর দ্য ইনিশিয়েশন অফ primary diabetes mellitus patient.
Yes, sir.
Thank you.
Thank you, sir. Point well taken. Thank you, everyone, for this wonderful session. Now I request the speakers.
The speakers with the moderator for the photo session at the photo booth. And we quickly move on to the next session for the day in the therapeutic section, which will be chaired by Dr. R.K. Ravi, BMOH, Bari Block Primary Health Center. Dr. R.K. Ravi. Dr. Ravi is around. Yes, Dr. Ravi, please. Dr. Apurvo Mondal. Dr. Apurvo is here. And Dr. Priyadarshi Josh, BMOH, Kolloli BPHC. These all Block Primary Health Center BMOHs have spared time from the busy schedule while they man the BPHCs and the peripheries to come to us for this conference. And for the deliberation on this session, a very interesting session, we now finally move on to something non-oral, insulin. We have none other than one of my mentors, teachers, Dr. Rana Bhattacharya, currently Associate Professor at Department of Endocrinology, Medical College, Kolkata, a very ardent speaker, clinician, researcher, and everything. Dr. Rana Bhattacharya, for my patient needs insulin, how to initiate.
Thank you, Pankaj, thank you, Akash, and your wonderful team for this invitation. So, in brief, I will discuss, I think the timer needs adjustment. Needs insulin, how to initiate. You know, when a patient needs insulin, a patient is on insulin, it's possibly easier to continue with that. However, when a patient needs insulin and that initiation is possibly the most difficult hurdle that you have to overcome. And this is very practical thing, so I kept my discussion very clinical. So we all know the benefits of insulin, and before insulin, the life of patients with diabetes were very difficult. And I'll just discuss briefly 4 cases. First, a 35-year-old gentleman, not known to have diabetes, first time presented to you with osmotic symptom, weight loss, generalized weakness. However, the BMI is on higher side and there is acanthosis nigricans. His fasting, PP and HbA1c all are sky high. The second patient, a 30-year-old lady in pregnancy, 22nd week, not known to have diabetes again. Oral glucose tolerance test, as you can see, there is mainly post-glucose hyperglycemia. And after therapeutic lifestyle changes with diet and exercise, repeated after 2 weeks, that what we usually do, and still the post-meal values are beyond control. It's much higher than what is needed. A third patient, a 65-year-old gentleman, type 2 diabetes for 17 years, currently on multiple drugs, and fasting and PP, as you can see, is very high with HbA1c 9.2. And a fourth patient, a 57-year-old lady, recently detected with pulmonary tuberculosis, already on 4 oral anti-diabetic drugs in their optimal doses, and although blood glucose level is not that high, but A1C is still 8.1. So one thing we can agree upon, that in most of these patients we need insulin. But when you decide to use insulin, the questions that should come to our mind, as well as to our patient's mind, that why insulin is needed, how much insulin is needed, and how to give that insulin, and what insulin to begin. Now there are so many kinds of insulin, human insulin, analogs, and they are starting from ultra short to ultra long. So which one to give, and for how long? So let's see how these questions need to be addressed in a practical day-to-day scenario. So first is, why do we need insulin in a patient? So first, I'm talking about type 2 diabetes mostly, because that's what you see most commonly in day-to-day clinical practice. So glucotoxicity, that is if the blood glucose level is very high, it causes both impairment of secretion of insulin and insulin resistance. So if you can reduce blood glucose level drastically, there is marked improvement in your glycemic status. And that leads to improvement in insulin secretion and insulin resistance. So much lower drug of oral hypoglycemic drug can act in this situation. Then of course the other spectrum is oral anti-diabetic drug failure. Now there are so many drugs, but you are using all in their optimal doses depending on their patient's situation, but still the glycemic control is not optimal. Sometimes you do know a wonder drug like metformin, some patient cannot even tolerate a 500 milligram of dose. So intolerance to oral anti-diabetic drugs is another issue. And a patient who is apparently well controlled but landed up in hospital with say a severe infection, a pneumonia, then you need insulin to tide over that crisis. And again, surgery with general anesthesia, often they need insulin, particularly if they remain NPO for few days. And of course, pregnancy, if we suspect that this patient won't get controlled with lifestyle and metformin, we do give insulin from the very beginning, or otherwise, if the patient is on metformin, not getting controlled, again insulin is needed, because in pregnancy, the target blood glucose level is pretty strict. It's much stricter than your type 1 or type 2 diabetes patients. And of course, many complications of diabetes forbids use of many drugs, like say a patient with eGFR of 15, you cannot use drugs like SGLT2 inhibitor, you cannot use drugs like glimepiride. Likewise, if there is a history of osteoporotic fracture, or you are suspecting a heart failure, you can't use pioglitazone. So in those situations, along with oral drug, you often need insulin. So there are many reasons why we need insulin for a particular patient. But the second question is type 2 diabetes, how long should we give insulin? This is a very important question you should address in the very beginning, because not all patients of type 2 diabetes needs lifelong insulin. The situations I described, depending on that, you decide, okay? So it's more important to have a clinical scenario in your mind rather than the absolute level of glycemia. As for example, the patient I said newly onset diabetes with acanthosis, obesity, with osmotic symptom, of course you need a shorter duration of insulin therapy there. You need to explain this clearly, okay? So when you know that how to use and when to use insulin, then you have to overcome the barriers that you are having. And one of the very challenging barrier is the patient-related things, because many patient thinks that the injection is very painful, I won't do it. A very simple step, just to demonstrate a recent, either with a syringe or with a pen, the needle is so tiny, many of the patient actually agrees if you demonstrate that. This is a very practical point. Dependence on others too. Many patients says that, so you must make the patient understand that the insulin is for self-injection. Other than a very few rare situation like a very disabling arthritis, or maybe even with hemiparesis, patient can inject themselves. So this is something you need to discuss with your patient. Concerns about storage. In Purulia, you think in this summer season it's very difficult to preserve insulin, but there are studies in desert areas in Saudi Arabia and Sudan where the using of just Ziar pot within the room in a dry condition, in a dry heat, it just simple two clay pots can reduce the temperature by 10 degrees of Celsius. So you can imagine how great that device is. Very simple, it's cheap, almost it costs nothing. So that you need to make your patient that you do not need a refrigerator, okay? Duration of insulin therapy, again I discussed, this is one of the barrier, and how you will address, I already discussed, that depending on situation you need to discuss with your patient that possibly for how long you are giving this insulin. And regarding side effect, hypoglycemia, again this is relatively lesser with more modern insulins. And there of course a very common myth that many patients will tell you that Dr. Amar insulin lagche mane amar ki shesh stage. But as you have seen in many patients, this is not so. From the very beginning, we can give for a short duration, and many studies have shown that that leads to long-term preservation of beta cell effect, so that you can use OADs for even a longer period. So again, you need to address that as well. And of course, someone thinks that something is injected is kind of addiction. So once I give it, I used to give it for eternity. Again, you need to address this myth properly. Now, the third question is, now you have explained all this, but now question is, with what? So there are many kinds of insulin, as I've said. You have basal insulin, you have prandial insulin, you have premixed insulin or co-formulation, mixing two types of insulin together. You have a basal bolus kind of regimen, and plus you have GLP-1 and insulin in a single pen. Now, with what you should initiate? And now, very soon, possibly we'll have once a week insulin as well. That will be marketed possibly in India in just a few months. So, the first thing, most commonly, what you do in a patient with OAD failure is basal insulin supported oral therapy. What is that? Now, basal insulin means it's an insulin which mimics the physiological basal secretion of insulin throughout the day. So by definition, it's a long-acting insulin. In PH, we have very cheap, relatively older. We have insulin glargine, we have insulin detamir, we have insulin degludec, and also glargine, the two formulation, 100 and 300 units. Then, which OADs can be used with insulin? Almost all of the insulin all of the OADs can be used with basal insulin, like sulfonylurea, meglitine, D4 inhibitors, SGLT2 inhibitors, and even oral GLP-1 analog and injectable GLP-1 analog. With pioglitazone, use of insulin is not absolutely contraindicated, but we have to be careful about salt and water retention. That's it. Otherwise, that is also not an absolute contraindication. Who is the ideal candidate? Type 2 diabetes mellitus who is failing on OAD alone. Why I have highlighted that failing point? Because many a times we tend to start insulin very, very late. So you should not start basal supported oral once the A1C is very high, you are unable to maintain with multiple oral drugs, you are seeing for months together. It's not that. Once you decide that this is the patient's A1C, and with this amount of drug which are possible to use, possibly the blood glucose control won't there, then and there you should start basal supported oral therapy. Okay? So that way it works even better. And please remember, in a patient who have a huge difference between fasting and post-meal glucose, like say in the range of 80 on an average, say fasting is say 160 and postprandial is 310. In this situation, basal supported oral may not be ideal if patient is already on multiple oral drugs. So there you need other kinds of insulin. And the patients who are severely hyperglycemic and grossly insulinopenic and having a coexistent infection, very severe kind of infection, or these conditions like myocardial infarction, the use of basal supported oral is not sufficient. There you need multiple subcutaneous insulin. Okay? So what's the principle of this basal supported oral? The principle is very simple. As you can see here, this is your ideal blood glucose level and this is the fasting glucose level. And if the fasting glucose level is high and the gap between fasting and postprandial is not very high, oh, it's not working. Anyway, if the gap between fasting and postprandial is not very high, if it is less than 80, then if you reduce the fasting blood glucose level, the postprandial glucose level will automatically come within your target. The second option is premixed insulin. So it is possibly most of you are most familiar with this kind of insulin. It contains a mixture of an intermediate acting and short acting or rapid acting insulin. So that with a single injection you can take care of both fasting and postprandial blood glucose level. And it can be started with once daily or twice a daily along with oral anti-diabetic drugs. and the same insulin can be used for subsequent intensification. So this is the principle of premixed insulin. As you can see here, this is the normal meals, and you can see there is a peak of prandial part of this insulin followed by a relatively flatter profile of NPH insulin. Similarly, if you give second injection, this works like this, okay? So in many patients, this is sufficient to control blood glucose level throughout the day. But as you can imagine from this profile, the patients where this second peak may not be that prominent, so after lunch some patient can have increased hyperglycemia. So you may need some additional agent there in some individuals. So these pharmacokinetic properties are very important to remember. And as I have said, in a more severely distressed patient or the patient who are more severely insulinopenic, you need multiple subcutaneous injection. What is that? For the basal insulin, you inject one long-acting drug, and on top of that, to cover these prandial things, you give shots of bolus insulin. And what is basal plus? This is basal plus 1 or 2 bolus insulin. It's the same thing. When you use 3 bolus insulin to cover 3 different meals, we call it basal bolus therapy. I won't go into detail of this list, but this basically summarizes that various advantages or disadvantages of different kinds of preparation. Just to give an example, the fasting control, of course, is much better with the basal insulin and basal bolus preparation, where basal is a component. Similarly, post-meal control is best with prandial insulin and basal bolus, and premix figures somewhere in between. Regarding flexibility of dosing, prandial has a very good flexibility, particularly the mealtime flexibility, right? And the same goes with basal bolus regimen. Whereas premixed insulin, you need to have a fairly regular schedule of meal intake. So I'll come back to the cases that I have discussed in the beginning. So this 35-year-old gentleman, not known to have diabetes, I have already discussed. You can either give multiple subcutaneous insulin with oral drugs, and then within 1 month, you can just take off insulin. You continue with the oral drugs. Or you can give, if the patient can afford, GLP-1 plus insulin to begin with. And likely duration to be short. Within this pregnancy, it's unlikely to be controlled with metformin only. So as the fasting is already within target, which we usually consider as 90 milligram per deciliter, so it's already there. For post-meal, to reduce the post-meal blood glucose, we need only prandial insulin in an individual like this. The third patient, a 65-year-old gentleman with OAD failure, with a relatively higher fasting glucose level, with a less gap between fasting and postprandial. So the best regimen here would be basal supported oral, okay? And my last case, a 57-year-old lady with pulmonary tuberculosis. As you can see, the fasting is 143 and PP is 228. Then twice a day premix would be most practical, and we often take out sulfonylurea because there is increased chance of hypoglycemia in that situation. So, to summarize, insulin is often indispensable in a patient of type 2 diabetes. It is often needed in many phases depending on the situation, and convincing an otherwise healthy patient requires motivation from your end as well as in the patient's end, and good counseling is very important. So initially you should discuss the various pros and cons of various regimens which you think is most suitable, and probable duration of therapy, and the painless injections that is there with the modern insulin injection techniques. And of course one should be sensible and caring about the concern, fear and misconception about insulin. You should be empathetic, so that we can discuss these points very well, and those are usually taken by the patient well as in most of the situation. And you should choose a regimen depending on your insulin preparation. As I've said, there are so many kinds of preparation now. You have to be aware with pharmacokinetic of each and every insulin. This is very important, so that you can formulate a particular regimen for a particular individual. And very importantly, initiation of insulin, of course, is not an end. You need to adjust and you need to modify your therapy depending on the situation. And insulin therapy is, of course, an art as well as it's a science. So my tribute to all the 4 individuals who are the main pillars of discovering insulin. Of course, there are many other individuals, but these are the 4 main persons who discovered insulin. Thank you for your patient here.
With the permission of the chairpersons, sir, what about a patient who is controlled on a combination of OADs, but is catabolic or maybe comes back every time with continuing weight loss? Typically that his HbA1cs are between 6 and 7 on every visit. His fasting and PPs are also good, but he says he's losing 1 or 2 kgs every time he comes to you, and people keep telling him, আপনি কিন্তু অনেক রোগা হয়ে যাচ্ছেন, চেহারাটা বড্ড খারাপ হয়ে যাচ্ছে. Is he a candidate for insulin?
Right. A very good question. Now, first we have to, again, the counseling is very important. If you feel the patient's weight is within the normal range and there is no catastrophic weight loss, and of course there is no other associated condition that is causing weight loss like tuberculosis or some other conditions like carcinoma. Pancreatic carcinoma is very common in diabetic population, so relatively more common rather in diabetic population. So you have to keep these things in mind. If those are excluded, SGLT2 inhibitor, GLP-1 agonist, and in some patients, metformin can cause drastic weight loss. So it's not in all individuals, very few, but these drugs can cause drastic weight loss. So what you can do, you try and take out these drugs. Then if you need, you can supplement with insulin. But if you feel the patient's body weight is well within the normal range and it has stabilized a bit, then you can counsel the patient to continue with the therapy.
Thank you. Thank you, sir. I'd request, sir, to come to the photo booth and
Thank
the
you.
chairpersons,
Thank you.
please. Dr. Ravi, Dr. Josh, and Dr. Apurva Mondal, please come to the photo booth and felicitate our fantastic speaker and my teacher, Dr. Rana Bhattacharya. A big round of applause for Dr. Rana Bhattacharya and all our 3 chairpersons for this session. Quickly moving on to the next session, which is a session on another session which will primarily possibly highlight the benefits of insulin and the need for it. To chair this next session, we have amongst us Dr. Ajit Prasad Murmu. Dr. Ajit Murmu is Secretary IMA Purulia branch and a very close friend. Dr. Debashish Biswas, if he is around, and Dr. Shubhankar Bhattacharya. Dr. Shubhankar Bhattacharya is senior endocrinologist, very vocal about obstetrics, tight control of obstetric glycemic status and all. And the speaker for this session is Dr. Indira Maisnam. Madam is assistant professor at Department of Endocrinology, IPGMR, one of my teachers while I was doing DM training over there, and always a very friendly and helpful person. Indira, madam, please.
A very warm good afternoon, respected chairpersons, learned audience. Thank you, Dr. Pankaj and the entire organizing committee for having me here. So in hospital, management of hypoglycemia is actually quite a big topic. So I will try to be as concise as I can be. So this is my outline of presentation. So hypoglycemia in a hospitalized individual is defined as blood glucose level more than 140 milligrams per deciliter. And if the admission HbA1c is more than 6.5%, then possibly there is a pre-existing diabetes. Then we also need to know about the definition of hypoglycemia, where there are level 1, that is the glucose concentration between 54 to 69, level 2 hypoglycemia, glucose concentration less than 54, and level 3 hypoglycemia, any degree of glucose that impairs the altered mental status or requires the assistance of another person. Also, there is hyperglycemic emergencies, which I'm not going to deal with in present. So this is the mechanism of hyperglycemia that occurs in the hospitalized setting. Again, I shall not go into the details, but when a patient has hyperglycemia in the hospitalized setting, so we need to connect the type of collect the background information about the type of diabetes, the anti-hyperglycemic regime the patient has be on, the chronic glycemic status, how the monitoring is being done, what is the indication for admission, the nutrition in the hospital, whether it's oral, enteral, and other comorbidities. So the prognosis is worse actually in new onset hyperglycemia compared to, let's say, in people who did not know they had diabetes. So coming to some cases of non-critical care setting, this is very, very common in our practice. Let's say a 56-year-old type 2 diabetes, 7 years admitted with a community-acquired pneumonia. The vitals are stable, has a pneumonic patch in the right lower lung, and patient is started on IV antibiotics. These are the home medications. Patient is on metformin, glimepiride, sitagliptin, atorvastatin, and telmisartan. And so the Ramden's CBG is 290 milligrams per deciliter. The HbA1c was uncontrolled, as we can see, is 9.8%, and patient also have neutrophilic leukocytosis. So we will concentrate on the glycemic management of this individual. So the goals is avoid severe hyperglycemia. So to understand what is severe hyperglycemia, we need to know our targets. Avoid hypoglycemia, ensure adequate nutrition, timely and proper transition of the glycemic regime during the step-down care, and appropriate education at the time of discharge. So we have to set our targets. So target is typically between, the pre-meal should be less than 140, and any other measure should be 180, so 140 to 180. If we can go, if it is possible, we can go at a lower target of even 100 milligrams per deciliter. And typically we would do a point of care monitoring by a glucometer. Sometimes if the patient has been using a CGM, could continue, but if the hospital has the expertise to use it. Otherwise, most of the time it would be with a glucometer, and the glucose lowering treatment could be insulin or non-insulin. So monitoring all pre-existing diabetes has to be monitored. All patients without a history of diabetes but with a CBG of more than 140 milligrams per deciliter. All patients, even if normoglycemic earlier, or glucocorticoids or octreotide and on tacrolimus, and all admitted patients should have at least one laboratory blood glucose testing, and all patients with non-diabetes and hypoglycemia should have HbA1c tested. So how do we monitor baseline HbA1c? And I have already talked about the point of care monitoring. How frequently do we monitor? It depends on how we are giving the insulin regime. So it typically is pre-meals and at bedtime. And if the patient is on parenteral nutrition, NPM, or on enteral nutrition, there is a RALS tube feeding, it could be 4 to 6 hourly. If patient is on IV insulin infusion 1 hourly, and more frequent monitoring after medicine or discharge. So CGM, if the patient was using, if the hospital has the expertise, we can continue. So insulin is the most effective treatment for inpatient hyperglycemia because it is adaptable to increased requirement, adaptable to any requirement. Basal insulin administration can prevent excess glucogenesis and ketogenesis. And insulin regime in the non-critical care, what are the regimes we may use? It could be a basal bolus, Rana Bhattacharya sir has already alluded to. Correctional insulin, intravenous insulin infusion, sliding scale, mostly controversial, mostly not advisable, and basal with a DPP-4 inhibitor. So the basal bolus regime has already been discussed, and we give something known as a correctional dose if required. What about the sliding scale insulin? So it is mostly discouraged as it is a retrospective step because insulin is given after the hyperglycemia has set in, and it does not cover the basal insulin coverage. But recent evidence, which came in 2021 in the Journal of Hospital Medicine, says that we can use in certain situations, that is, if there is always a mild hyperglycemia with CBG less than 180 milligrams per deciliter as a dose-finding strategy in patients with type 2 diabetes, but to be strictly avoided in type 1 diabetes, pre-insulin admission requiring insulin, pre-admission insulin requiring type 2 diabetes and severe hyperglycemia. But if patient goes above 180, then we should at least go to a basal bolus. Sometimes if the patient is on a pretty well controlled, we could give a basal insulin with a DPP-4 inhibitor. Now the intravenous insulin infusion, critical care typically we need, but in the non-critical care we may have to give in severe hyperglycemia, perioperative care, NPO status, uncontrolled hyperglycemia as dose finding strategy. And sometimes even if the patient is on an IV insulin infusion, basal insulin at a low dose could still be given. So there are many options of giving insulin in the hospitalized patients. So, in that patient, the typical regime would be a basal bolus injection. Now, in case 2, this is a 58-year-old person, type 2, admitted for type 2 diabetes for cystoscopy on linagliptin and metformin with a random CBG of 178 and HbA1c 7.1%. How do we manage his hyperglycemia in the hospital? So in patients, actually, in select adult patients with mild hyperglycemia and type 2 diabetes, hospitalized for a chronic non-critical care illness, we could actually continue the home medications because he has been admitted for a small procedure, and just because he has entered the premises of the hospital does not mean he will have to be shifted to insulin. So the non-insulin therapies we have typically used in the are the DPP-4 inhibitors in the hospital. SGLT2 inhibitors we could use in heart failure, but if there is a plan for surgery, we have to stop 3 days before surgery. Metformin to be avoided in those at risk of lactic acidosis, that is those with heart failure, liver failure, or those with renal failure. Sulfonylureas preferably not preferred. Type 2 TZDs are also not preferred. And GLP-1 receptor agonists, if we use in the hospitalized patient, it should be stopped 1 week before surgery. So what type of regime we give in the non-critical care setting depends on the baseline characteristics of the patient, for what purpose the patient admitted, what was the medication the patient was taking at home, what was the level of the glucose, and therefore the measuring of the HbA1c is extremely important, so also the point of care monitoring. Now we need to fit the insulin regime to the type of nutrition. Now if the patient is feeding, basal bolus is very good. Enteral feeding, we could do a basal and a correctional dose insulin. If the patient is on a total parenteral nutrition, even then we could give an IV insulin infusion, or patient could still be on a basal insulin or a correctional dose insulin, which could be given 4 hourly in the case of rapid acting analogs and 8 hourly in the case of 6 to 8 hourly in the case of human insulin. Now once the patient, let's say the pneumonia patient we just discussed, patient was on a basal bolus and patient has been controlled from the pneumonia, and also now we want to transition. So when do we transition? Or let's say the patient was very ill and we had to actually had very poor glycemic control and the patient was on intravenous insulin infusion. So when we transfer from the intravenous insulin, we do so when the hyperglycemia has improved and stabilized. We shift to a basal bolus regime, and then how do we calculate the basal bolus regime? The last 24 hours or 6 hours requirement of insulin into 4, that is, we calculate the last 24 hours, 80% of it is a total dose of insulin, and we give 50% as bolus in 3 divided doses and 50% as basal. And please remember, when you transition from an intravenous insulin to a subcutaneous insulin, it's important there is an overlap between the subcutaneous insulin and the intravenous insulin, because intravenous insulin has a very short duration of action of only 5 minutes, and if there is not an overlap, then there could be a rebound hyperglycemia, which is very common in the critical care as well as the non-critical care setting when patient has been given when there has been no overlap. And again, there are no specific thresholds for hypoglycemia, but I have already talked about the different levels of hypoglycemia, and to avoid the hypoglycemia, we should reduce the dose of insulin when the calorie intake is reduced, delayed, or the glucocorticoid dose is decreased in somebody who has got a glucocorticoid. So the calorie intake could be reduced because, let's say, the patient is vomiting or the patient is NPM for a radiological or an imaging procedure. Also avoid aggressive targets, mostly avoid sliding scale unless the patient has a very, very well controlled glucose of always less than 180 milligrams per deciliter, and the therapy should be reassessed when the blood glucose is less than 100 milligrams per deciliter. The management of hypoglycemia, if it is severe in the ICU setting, we may have to give the 25% dextrose. Otherwise, if the patient is not severe, then we ensure that the patient takes his or her meal, and we may have to give an oral rapid acting agent. Now, discharge planning in adult patients with diabetes who are hospitalized for non-critical illness, we suggest providing inpatient diabetes education as part of the comprehensive diabetes discharge. This is by the ADA. And if the patient HbA1c was at target at the time of admission, then patient could go to his or her regime in which the patient was following. But if the HbA1c is above target, then we'll have to intensify the home regime. Now, briefly on the critically ill, when to treat and until what. So the American Diabetes Association says that we start treating when the CBG monitoring is more than 180 milligrams per deciliter, and the target is by 140 to 180 milligrams per deciliter. But recently, as recent as 2024, by the Society of the Critical Care Medicine, they said that we could initiate treatment if the CBG is at a higher level, let's say above 200 milligrams per deciliter. And these guidelines they have said based on the findings of a particular study, which I shall discuss briefly. Lower targets may be used provided hypoglycemia can be avoided, but mostly the target is 140 to 180 milligrams per deciliter. So the intensive control is harmful because there is a higher risk of hypoglycemia. Yes, there could be a decrease in the length of the ICU stay, lower infection risk, but it does not convert into decreased mortality in the medical ICU, so also in the surgical ICU, except in a particular study. So the targets, even in the surgical ICU, could be 140 to 180 milligrams per deciliter. And the conventional, it has been found in certain studies that it increases the length of hospital stay, but again, that has not been extrapolated in every studies. So this is the study I'm talking about, the tried glucose control fast study, where they took about 9,000 individuals and targeted to an intensive control of 80 to 110 milligrams per deciliter, or a more relaxed target of around 180 to 200 milligrams per deciliter. And what they found was that there were no difference in the length of hospital stay or in the mortality outcomes. And therefore, based on this, the Society of Critical Care Medicine has said that our targets could be very well at 200 milligrams per deciliter. Oh, sorry, I'm going back. So another thing is, whether IV is more beneficial or subcutaneous insulin is beneficial. Again, there has been no mortality benefit with the use of IV insulin compared to the subcutaneous insulin, even the length of hospital stay even. But what is important is that in the IV insulin, we are getting the glycemic control more rapidly. We know that when we give an insulin, IV insulin infusion, the glycemic control can occur within a few hours rather than when we give a basal bolus, which it takes longer. So typically in the critical care setting, many times in severe hyperglycemia, we may have to use an IV insulin. And subcutaneous insulin in the ICU already discussed, and there are again many protocols. I'm not going to discuss the details of the protocols. So the typical protocols we use are the Yale protocol, and there are already simplified protocols where there is a chart. So you could have a protocol that is such a chart maintained for your ICU and stick up to the wall of your ICU and then follow it accordingly. So whatever it is that every hospital, every intensive care setting should have a protocol for them to follow. Again, there are computerized algorithms. Typically in the practical setup, we are not doing so much. What we are following is the standardized protocol, whichever protocol we are following. And the frequency of monitoring depends on how we are treating. So definitely if it's an IV insulin, at least it should be 1 hour, typically sometimes even every 30 minutes. In a subcutaneous form, in the form of a basal bolus, we could give it pre-meals and at bedtime and sometimes post-meal also. Again, CGM, we do it if the patient has been using, but otherwise there is no additional benefit. Role of HbA1c, it tells us the status of the glycemic control of the patient. It tells us whether the patient has a pre-existing diabetes in somebody who has a prior history of, new onset hyperglycemia in the hospitalized setting. It also helps us plan our discharge in somebody who will be ultimately okay and plan for discharge in the hospital. Nutrition, as far as possible, preferred oral is preferred to enteral oral, normal oral eating in over Ryle's tube or enteral feeding or parenteral feeding. When you give a TPN, total parenteral nutrition, so there are many protocols. Sometimes you could charge the insulin in the IV insulin in the bag, but typically I think it is preferable to give either an IV insulin infusion or a basal insulin with a correctional dose insulin every 4 hours or 6 to 8 hours. Because when you charge it in the TPN bag, also if there could be a chance of a infection also if protocols are not maintained. So regarding the glucose, don't be strict, be direct, IV more than subcutaneous because it's convenient, but no mortality outcomes. Don't deprive calories, use simpler regimes, check frequently. And so to conclude, hypoglycemia is frequently present in hospitalized patients. Goal of proper hypoglycemia management is to address the hypoglycemia because poor glycemic control is associated with poor infection control and also poor osmotic dysregulation and imbalance of metabolites. Avoid hypoglycemia through appropriate nutrition, fluids and insulin regime. Various regimes exist, and when the patient is ready for discharge, educating the patient is very important so that readmission does not take place. Thank you.
Thank you, ma'am, for that wonderful overview of a very big topic, possibly critical as well as non-critical. I think I have a question, madam. For all those patients initiated insulin in the hospital for whatever reason, is it mandatory that they be discharged on insulin?
No, it is not mandatory. That's what I was saying. That so it actually depends on what. Let's say the patient is completely cured or control the reason for which he was admitted. Let's say a pneumonia, and patient just needed at the time of the hospital admission. So the background HbA1c is very important. So if the HbA1c was a target, then we could very well discharge the patient on the regime the patient was taking. But if the patient was not a target, then we have to intensify the regime, and intensifying the regime may or may not be with insulin. So it depends on for the reason the patient has been admitted.
Thank you, madam. If there are no further questions, ma'am, we'd request you to come to the photo booth to accept our gratitude. And quickly moving on to our next section, which is a panel discussion on a very common topic. In fact, this is more of a question from patients and their relatives, rather from doctors, about artificial sweeteners or sugar-free, as we all say in one of the brands. Non-nutritive sweeteners is the various terminologies to be used. And to moderate the session, I'd request again on stage Professor Nilanjan Sengupta sir. Nilanjan sir is a professor and head of the department endocrinology, NRS Medical College, Kolkata. And as panelists, we have Dr. Amitabh Soor, senior endocrinologist, Kolkata, attached to Peerless Hospital. Amitabh, Peerless Hospital, Kolkata. Dr. Abranil Dhar, a beloved colleague from the Department of Endocrinology, IPGMER, Kolkata. And Dr. Neha Agrawal as the third panelist. Dr. Neha Agrawal is from Health World Hospitals, Durgapur, endocrinologist at Durgapur. Three young panelists led by head of the department through artificial sweeteners, or as you can already see, sugar-free.
Right. So we have a few slides prepared by Obronil, but it will be more of an interactive session. Slides are just to stimulate discussion. Now, definition, or may I ask Obronil, the youngest panelist, to start with, what do you mean by artificial sweeteners, low-caloric sweeteners, non-caloric sweeteners? Are they equivalent? Yes, please help them with the cordless microphone.
Has someone taken the mic with them?
The mic
the
is stolen. Okay. So, okay, right. Got it, but I think that would be too cumbersome. In the meantime, try to find a caller. Oh, the mic is here, out here. do you mean by, are they synonymous?
Sir, artificial sweetener is a broad heading which contains the two terms nutritive and non-nutritive sweeteners. These are actually chemical or natural substances which produce the same amount or rather more amount of sweetness just like our normal table sugar, because it's more potent but with reduced or sometimes no calories at all. So we can gain the same amount of sweetness with reduced calories.
With very much reduced calories, so practically they turn out to be no caloric sweeteners. Actually they do may have a little bit of calories too, which is clinically insignificant. So that's what we have said. So Neha, could you enumerate the common artificial sweeteners that we use in India?
So artificial sweeteners can be nutritive as well as non-nutritive. So nutritive sweeteners, as we can see in the picture, it includes sugar, alcohols, polyols which are present in the cold drinks and all. And non-nutritive sweeteners which we commonly prescribe, which we commonly ask our patients to take, as they are low calorie or zero calorie sweeteners, they include the chemical compounds like aspartame, asulfame, neotame and saccharin and all. And the natural non-nutritive sweeteners is a stevia. So
actually I think what we prescribe our patients, we have sucralose, aspartame, stevia mainly as a tabletop sweetener, and maybe saccharins. The use of saccharin has come down, and in various sweetened beverages like the diet colas and all these things, they have aspartame or acesulfame. May I ask Amitav, among them, if the patient wants, I want to cook, now which one of them are thermostable and which are thermolabile?
So ideally none of them are thermostable in true sense, but then aspartame, the heat stability of aspartame is the lowest. It actually gets unstable even when the temperature is more than 30 degrees Celsius. From in the range of 30 to 80 it becomes unstable. But a positive side is when aspartame becomes unstable, its sweetness goes, but at least the byproduct which come out after its inactivity is not toxic in that sense. So therefore the message is aspartame should be used in food which after cooking, after the food gets cooled and down. But for sucralose also, the temperature at which sucralose gets deactivated is higher. It's around 80 to 100 degrees Celsius based on literature available. But the problem is once sucralose gets denatured, it gets converted to chlorinated products which can be actually toxic to the body. So probably during cooking none of them should be used. But if what you are eating is relatively hot, then probably you should give sucralose. And if it is cold, you can give both sucralose and aspartame.
I think while cooking, it's better to give sucralose, but with the caveat that you do not boil with sucralose. Maybe after cooking, you add it. The difference would be with sugars, after cooking, you can add it.
Maybe we can use stevia because it's a natural sweetener and we can...
No, but stevia is just a tabletop sweetener. Stevia is also heat labile. So it will be, the sweetness will be lost on heating. That's the problem. Yes. For that matter, if you are adding after preparation a little bit of cooling, then you can also use stevia. But if you are very Puritan, you have to use sucralose in a hot preparation. So now it comes to the very important part, what would be the accepted daily intake? Because as we will see subsequently, there are meats, but as we'll see subsequently, that in extreme dosage, no non-nutritive sweetener maybe is safe. But what is the safe and accepted daily dose of sucralose or aspartame, which are the commonly used, or maybe stevia? Amitav?
Sir, although these are not very much established, but the accepted figure is for aspartame, it is up to 40 milligram per kg per day. Some literature also mention 50 milligram per kg per day. For saccharin, which is not used that much, and sucralose, it is 5 milligram per kg per day. And for acesulfame, which is not available much in India, it is 15 milligram per kg per day.
Obrunin, I don't understand as a patient what Dr. Amitav Shur has said. So how much tablets or how many cans of cold drinks can I consume?
usually aspartame is available or used in diet soda or diet coke. So if we see the commonly used diet soda, 1 can of diet soda usually contains 180 milligram of aspartame. So in that case, if we see a 75 kg weight body weight person, then the acceptable intake per day will be like around above 3,500 milligram. So it takes about 20 to 21 cans per day. So it's much higher than the normally used dose of.
So you can well understand, you can allow your patients to consume diet soda, Sprite Zero or whatever, or maybe added sucralose with tea or coffee, but not to the extent that the patient is consuming 20 cans of Sprite Zero or Diet Coke Zero or Diet Coke or whatever. Now we come to some of the myths. Neha, do they cause cancer? Because I've found many of the nutritionists telling our patients, no, you don't take them, this causes cancer.
Saccharin has shown to cause bladder cancer in the rats, but there is no evidence in the humans. And aspartame has recently, it was with the limited evidences that has shown to cause liver cancer. And hence, some recommendations from the WHO has come that not to use non-nutritive sweeteners because of there is a risk of having cancers. But we have got very limited evidences for this.
And that too in very high dose. So what is very important is that when we advise our patients on non-nutritive sweeteners, that those advice should come with the adequate caveat that you can take it probably to your benefit, but not in unlimited amounts. So some concerns. That is really a scientific concern. Obronil, there have been certain recent studies which have tried to show that if you use lot of low-calorie sweeteners, that instead of inhibiting our sweet receptors, tend to stimulate our sweet receptors, that increases the sweet craving. Ultimately, the person ends up in consuming more calories altogether and putting on weight. And that can also have adverse cardiovascular effects. What's your take on that?
So actually, this is a little bit controversial, as various studies have shown various kinds of reports, but many studies have shown increased risk of weight gain, metabolic syndrome, as well as type 2 diabetes or glucose intolerance as well. Mostly the impact is on the dysbiosis. As you said, the intestinal receptors are there which may alter the gut microbiome, and ultimately there may be a chance of glucose intolerance. Another possible mechanism related to aspartame is that there is a chance of the normal regulation of the hunger and satiety may be altered as well. So as per the studies have been concerned, one of the most important studies which has been published in 2023, NutriNet SAND study, was actually a review in France, which has shown some association with the type 2 diabetes, which has been linked to the aspartame as well as the sucralose. So there are some concerns with the use of non-nutritive sweeteners as well.
Another very practical issue when it comes to a diet cola or a fizzy drink that contains only the non-nutritive sweetener and nothing else. But many a time I think if confectioneries, cakes, sweets are made with those low-calorie sweeteners and they advertise that it doesn't contain sugar, or chocolates, these patients tend to gorge a lot of them thinking that they are sugar-free, without any sugar, but they also do contain other carbohydrates maybe, and most importantly fats. So that adds to the fat calories. So that is another thing which of course has not been highlighted in literature. What has been highlighted is gut dysbiosis and hunger, satiety and the sweet receptors. But I think for our Indian patients, the practical thing when put into confectioneries is that many patients tend to think that, okay, since we are not having sugar, we can take it ad lib. So that cannot be done. So these are some of the studies I think you had pointed out. So I think, Amitabh, so replacing caloric beverages with water or diet beverages for weight loss. So, is that a good idea, you think? Means, if the patient has to take some beverage, especially in hot climate, the best thing would be, plain water. But many of our patients would love to have some sort of tastier thing. Plain water is insipid. So that tastier can be made either by sugar or a sugar substitute. So what about this study? Means
I do agree. If patient has to take something and patient is not convinced to take just water, then of course this non-nutritive sugar containing beverages are way better than sugar sweetened beverages, because sugar sweetened beverages are something which is, all of us know, is established risk factor for diabetes, obesity, and most importantly metabolic associated fatty liver disease. So at least they are better in that sense, but if we can convince patient not to even take this, then probably it will be better.
Neha, another thing which is fortunately not a problem in India, but in the West, many, corn syrup contains fructose and sorbitol and xylitol, and many gums, they have those xylitol base. They are also available in India. So if they are consumed, especially in children, many parents give those gums thinking that they do not contain sugar. So how good they are for gut health or metabolic health?
These xylitols and all, it has shown that they itself leads to one of the causes for childhood obesity if they are consumed in the excess amount, because xylitol itself has got some amount of calories. These are not calorie-free sweeteners. So they have also shown to alter the gut microbiota. They can promote metabolic
and cause osmotic diarrhea also, without altering the gut microbiota. And so also carry steam, because they are not 0 calories, they are low calories. So, Obronil, what about the guidelines? What does ADA say? What does WHO say?
As far as the guideline is concerned, mostly that is unchanged from the ADA 2024, also in the recently published 2025, that the non-nutritive sweeteners, the low calorie or no calorie beverages can be an alternative for the sugary beverages or the caloric beverages, as they can produce low calories or no calories or reduced carbohydrate intake, but they haven't recommended it for the control of body weight or any glycemic control. So that part we have to keep in mind.
And what does WHO has to say?
WHO strictly recommended against the use of these non-nutritive as well as nutritive sweeteners for the control of body weight actually.
So I think there is a dichotomy on this. If you go by WHO, this is strictly no-no, especially if you want to control body weight. ADA is softer, saying that it is better to use it in place of, glucose containing sweeteners, and especially for if glycemic control is in mind, but probably not if you want to lose weight. But I think the practical thing is that if you ask our patients not to take anything, do not take any sugar or sugar containing beverages. If you say do not at all take any non-nutritive sweeteners or sweeteners based drinks or foods, which many of our nutritionist colleagues say, there would be a break point and compliance would be compromised. So I think we should tread the middle path. We should not encourage them to consume these sweeteners too much, but we should say that they are definitely preferred over foods and drinks that are loaded with glucose or sucrose. It is definitely better than that, but do not take unlimited, again the same thing, unlimited amounts. Now, do you have any other questions from the audience? And Pankaj, we have done with 20 minutes.
Yeah, you are done, and if there are any questions about this extremely common and thought-provoking topic, we have 3 panelists and a wonderful moderator to answer questions.
Yeah.
There is a question, I think.
Common man who is using that, what do you say in English, gur.
Good. It's a very good question. So, Neha, gur instead of sugar or honey instead of sugar?
So they are equal almost in terms of calories if we talk about, and in terms of nutritive values also, honey, as it is a natural source of natural source of sweetness, so it could be somewhat beneficial in terms of nutritive value, but it's almost same in terms of calories. So ideally we should avoid using all these things for all our diabetic patients as well as for the ones who are trying to lose weight, because they all fall into the same category of carbohydrates.
Yeah, same for gur. Gur, the only additional thing in jaggery is that it contains a little iron. So when you are taking sugar, you are getting only calories and no nutrition. With gur, same calories, but maybe a little bit of fiber and little bit of iron. But calorie-wise, there is nothing to choose between them.
Thank you.
So if there are,
one more myth. Is it a myth actually? Sugar is the new age toxin.
Sugar is the new age toxin. Amitabh, anybody?
No, this is not a myth. It is actually true, but of course there is a moderate amount if the patient is consuming and patient is not diabetic. Even if diabetic and consuming in a very moderate amount, then it's not toxic in that sense.
Everything that help increase the taste of food, sugar, salt, and not only new age toxins since ages, since generations.
I would say it's a new age addiction.
Right, yeah. So I would thank all my panelists for an excellent job, and I would hand over to Dr. Pankaj Singhania for final wrap-up and transitioning into the next session.
Thank you, panelists and moderators. Sir, request the panelists, Amitabh, Obronil, and Neha to come to the photo booth for our gratitudes. And quickly moving on to the next session, we have a couple of sessions left. We now move on to the gynae obstetrics part of diabetes and obesity. And for the next session, to chair the next session, we have Dr. Akash PK. Dr. Akash PK is obstetrician and gynecologist at the Southeastern Railway Hospital, Adra. Dr. Anita Das. Dr. Anita Das is senior obstetrician and gynecologist, faculty at the Department of Obstetrics and Gynecology, Deven Mahata Government Medical College and Hospital, Purulia. And along with that, I'd request Dr. Priya Singhania, senior obstetrics and gynecology, to co-chair the session. Dr. Akash, please. And to do the deliberations, we have none other than Dr. Sunetra Mandal, a very promising and renowned obstetrics endocrinologist from Durgapur till Kolkata and everywhere in between. And Sunetra is a very close colleague, and she will be talking about probably pregnancy with some amount of hyperglycemia.
Yeah, thank you so much. Should I start? Okay. Good evening, everybody, and I thank you, Dr. Pankaj and Dr. Akash, for this kind invitation. So today morning we went to the Durga Falls. We rock climbed down and up, but thankfully I did not break my leg, but I broke my voice. I'm very sorry for that. So I'll start with the case, 28-year-old female. So from some rural area in Purulia maybe, so her first booking visit is at 25 weeks. She has a past history of stillbirth, and her fasting plasma glucose is 168. So as we all know, diabetes in pregnancy could either be pre-gestational diabetes mellitus, as in a pre-existing diabetes, we know of that, any type, type 1, type 2, or any other type, or it could be hyperglycemia that is first being detected in pregnancy. This again could be overt diabetes, which was not diagnosed before, being diagnosed for the first time in pregnancy, or this could be the so-called gestational diabetes mellitus. Standardly, it is diagnosed, gestational diabetes is diagnosed around 24 to 28 weeks, but over the past few years, there has been a lot of discussion on this term, early GDM, which is diagnosed in the first trimester. And as it comes, diabetes complicating pregnancy, which is basically overt diabetes in pregnancy, the clinical implications differ from GDM in that in GDM, there is the diabetic complications, especially the vascular complications to the mother, as well as the placental vasculopathy are less common, as are the diabetic embryopathies, which occur in the first trimester, of course. In straight, the focus of treating GDM is to prevent macrosomia, difficult labor, and other concerns for the obstetricians. So briefly, the pathogenesis, as we know, in the first trimester, due to the increased beta cell hyperplasia due to action of estrogen and progesterone, as well as increase in plasma volume, fetoplacental glucose utilization, there is basically some drop in the fasting plasma glucose in early pregnancy, but in the later parts of gestation, due to the placental hormones like HPL, growth hormones, HCG, etc., and other adipokines, there is insulin resistance, increasing insulin resistance in the different organs. And although there is some amount of beta cell hyperplasia as well, but although in normoglycemic individuals it is enough to cope up with the insulin resistance, but those who are at risk for developing GDM, it is not. And we all know the results of the HAPO study, which first showed a continuous relationship between any maternal glucose levels and adverse feto-maternal outcomes without any specific threshold. And the IADPSG recommendations first formulated in 2010 based on the HAPO results, in which they recommended first prenatal visit, we have to do a fasting glucose, A1C, or a random glucose in all women preferably, or at least in high-risk women. If results indicate overt diabetes, I'll come to the cutoff later. Of course, it is overt DM, we treat that. And if the results are not exactly normoglycemic, but not exactly overt diabetes, it could be GDM. So if it is diagnosed early on, it is early GDM. And if the glucose is even lower within the normoglycemic cutoffs in the first trimester, we test for GDM again at 24 to 28 weeks. And again, we could diagnose either overt diabetes or GDM or normoglycemia. Now we all know there are so many different ways to test for GDM, the 1-step, 2-step, 50 grams, 75 grams, but I believe most in this hall go by the ADA guidelines of a 75 gram OGTT for standard GDM, and the cutoffs we consider is 92 for fasting, 1 hour 180 and 2 hour 153. Some of the obstetricians still prefer to use DIPSI. Of course, it's convenient because it is non-fasting but has its own set of controversies as well. But when it comes to diagnosing overt diabetes in pregnancy, the cutoffs are less controversial. A1C more than 6.5, random glucose more than 200, or fasting more than 126 anytime during pregnancy is overt diabetes. So talking about risk factors, who should we screen for in the first trimester? Of course, those with a past history of GDM, strong family history, maternal age more than 35, PCOS, of course, but also in high-risk ethnic groups. And as we all know, we all belong to that high-risk ethnic group. So ideally, we should screen for a fasting and HbA1c for all women, at least in the first trimester, if not preconceptionally. So there are many opportunities for screening for hyperglycemia in pregnancy. I don't know why the letters are not coming. It could be preconceptionally or in the first trimester for those with risk factors, if possible in all women. And of course, GDM for all pregnant women. Briefly about early GDM, fasting glucose between 110 to 126, A1C between 5.9 to 6.4. There is controversy regarding whether or not to treat this early. But yes, recently this meta-analysis, they have shown that early intervention does not improve most pregnancy outcomes except neonatal respiratory distress and a possible reduction in macrosomia. So Our Lady, fasting glucose 168, there is no doubt, I guess, this is a pre-existing or overt diabetes that is complicating pregnancy. This is not GDM, whatever be the time when she is diagnosed with. Now, I will not go into the complications. We all know maternal short-term complications, preeclampsia, hypertension, infections and all, long-term in the form of recurrence or having type 2 diabetes and other metabolic diseases. And for the neonates also, I will not go into this list. All of us know that. And again, this hypothesis, why this occurs, we know maternal hyperglycemia goes into the fetus, increases its insulin levels, and the insulin levels, hyperinsulinemia in the fetus is what causes macrosomia, chances of neonatal hypoglycemia, and in the long run, childhood obesity and diabetes. And if the mother gives birth to a daughter with the same features, she will go on to give birth to another daughter, and thus a vicious cycle of GDM and diabetes would go on, and we could just put a stop to that by targeting the mother early. Talking about effect of the pregnancy on diabetic complications of the mother, yes, there is progression of diabetic retinopathy, some effect on nephropathy as well, and ischemic heart disease, usually the risk is increased during the peripartum period. Other complications, there is no strong evidence to suggest that it increases during pregnancy. So this lady, we missed her during the preconception period. So all the tests that we should have done preconceptionally, including screening for her comorbidities, because she is having overt diabetes, I would do now, except possibly lipid profile, because anyway, I'm not going to start her on statins. So diabetic retinopathy, as we know, there is a high risk of progression as well as of new onset diabetic retinopathy during pregnancy. So all pre-existing diabetes, dilated fundoscopy should be done pre-pregnancy in the first trimester, every trimester after 1 year postpartum. Anti-VEGF inhibitor is contraindicated because of possible vasculature damage to the fetus, but lesser photocoagulation we could do for high-risk period during pregnancy. So this lady, regarding her complications, creatinine normal, urine ACR slightly high because of her pregnancy. Lipid profile I did not do, but she was having PDR. So what's next? How do we treat her? Of course, we cannot forget lifestyle modification. Briefly about the diet, no definitive research to suggest that the nutrient calorie requirement of mothers with GDM and without GDM are different. Usually, we calculate the pre-pregnancy calorie requirement and we add 300 to 400 calories. No evidence to suggest low carbohydrate does any good. In fact, at least 175 grams per day of carbohydrate should be given to the mother. Protein at least 71 grams per day, and some amount of fats, 20 to 40% of the total calorie requirement should come from fat, with maximum of 10% from saturated fat. For micronutrients also, although we give folic acid and all, there is no sufficient evidence to suggest micronutrient requirement of GDM versus non-GDM mothers are any different. Now, a lot of discussion on gestational weight gain, especially in overt diabetes or those with GDM. So there are very clear recommendations on how much gestational weight gain to be a mother should have, depending on her pre-pregnancy BMI, which we should not exceed. And exercise 30 minutes of moderate intensity at least 5 days a week, or a minimum of 150 minutes per week. Usually we ask them to walk for 10 to 15 minutes after each meal. I believe nobody in this house is against the fact that insulin is the recommended treatment, the best treatment that we could offer to mothers of diabetes or gestational diabetes, and almost all guidelines are in sync with this now. The total dose could range from 0.7 to as high as 2 units per kg of the pregnancy body weight. If the fasting is high, better to give intermediate or long-acting insulin at 50% of this total daily dose. If the postprandial glucose is high, as Rana sir just discussed, we have to fix the fasting first. Then we can start with 1 unit for every around 10 grams of carbohydrates. If possible, we can calculate that, or we could give short-acting insulin and titrate according to the post-meal CBG. And as we all know, for rapid-acting, apart from regular insulin, Lispro and Aspart have been extensively studied in pregnancy. NPH, of course. Among the long-acting, we now have data for Degludec in addition to Detamir. Glargine, although no data is there, but several case reports and several years of experience to suggest it can be used safely in pregnancy as well. Just to remind ourselves, insulin requirement rises this much during the later half of pregnancy to as much as 60–70% increase in the dose might be needed. So for our lady with pre-existing diabetes in pregnancy, along with lifestyle modification, I started out on insulin premixed with close monitoring of her glycemic and gestational weight gain. Regarding oral anti-diabetic agents, ADA does not recommend. ACOG and NICE still have some place for metformin. Glyburide not usually preferred, only if intolerance to metformin and the patient strictly refuses insulin, only then. And regarding a few important trials of metformin, the MIG trial, which showed 50% of women on metformin would go on to require supplemental insulin. There is no difference in neonatal morbidity or maternal complications, except that the metformin group had lesser gestational weight gain. The MIG-TOFU study showed that at 9 years after birth, the babies of the children of metformin-treated mothers were larger, had higher body weight. The MITI trial showed metformin use could slightly increase the risk for small for gestational age infants. And this meta-analysis showed that we favored insulin over metformin if there is a chance of SGA. And if you are adding metformin to insulin, again, there is a lesser odds of having a large for gestational age infant, but it does not really reduce the composite neonatal adverse outcome. So I tried to summarize if the mother is having type 2 diabetes or gestational diabetes, what metformin does is reduces the insulin dose requirement, chances of macrosomia, neonatal hypoglycemia, and gestational weight gain, but increases the risk for preterm baby, small for gestational age, and possibly childhood obesity. And so for this woman, on her anomaly scan, she was having slightly large for gestational age baby. So we may consider adding metformin to her also, although this is not in the guidelines yet. Talking about glycemic monitoring, HbA1c should not be monitored. We know it is due to increased RBC turnover, it could be lower. If at all, less than 7% is reasonable. Rather, we focus on the blood glucose values, pre-meal less than 95, 1 hour 140, and 2 hour less than equals to 120. Self-monitoring blood glucose is the most important monitoring tool during pregnancy. CGM, continuous glucose monitoring, is very much recommended in type 1 diabetes. In type 2 diabetes, there is insufficient evidence, and if at all, it should be used in addition to self-monitoring of blood glucose, and the target range is between 63 to 140, not 70 to 180 as we do for non-pregnant women. So after 2 to 3 weeks, this lady was having good SMBG, so does our work end there? Thankfully, our excellent obstetricians colleagues take care of the rest of the things like hypertension, need for aspirin. Just for our knowledge, the target blood pressure during pregnancy is 100 to 135 by 85, and aspirin should be added for all mother having pre-existing type 1 or type 2 diabetes during pregnancy to lower the risk of preeclampsia. So by 34 weeks, she now has some symptoms of pruritus, high ALT, AST, high bile acids, possibly having obstetric cholestasis or intrahepatic cholestasis of pregnancy. Several studies have shown there could be a link between GDM and ICP, and GDM aggravates the adverse outcomes due to ICP. And for women with ICP, usually the delivery is done just at term or just preterm, so they would need antenatal corticosteroids, and then the insulin dose has to be increased by around 25 to 40%. Regarding the mode of delivery, well controlled by medications, we could wait to 39 completed weeks, but with complications and of course with obstetric cholestasis, she may need delivery before 37 weeks. Intrapartum, continuous CTG if possible, every 1 to 2 hours monitoring, insulin infusion may be needed, metformin ideally should be discontinued, and post-delivery, close monitoring again. The target blood glucose now is fasting between 90 to 130, 2 hour post-meal less than 180. Insulin can be discontinued in GDM, but for pre-existing diabetes, the requirement is much reduced. Now, anybody in this hall can tell me what is this photo about? What is this? The square waves on the sea. Pardon? No, these typical square waves, they are said to predict tsunami. So they basically predict the calm before the tsunami. So any mothers over here would believe like me that pregnancy and immediate postpartum period in the hospital is like a calm period before the real tsunami starts, once the child comes home and starts to move. So during this postpartum period, the glucose monitoring by the mother becomes very difficult amidst this tsunami, but there is they need monitoring for hypoglycemia because of breastfeeding, because of so much movement, but nevertheless, we should encourage breastfeeding in all of them. So this lady delivered a healthy baby at 37 weeks, slightly macrosomic, insulin dose was reduced postpartum, and she was doing well otherwise, but our work again doesn't end here. Of course, she will be monitored, but even for mothers with GDM, we need to rescreen at 4 to 12 weeks with OGTT and lifelong screening for pre-diabetes and diabetes. And briefly about type 1 diabetes, if she presents with a similar blood glucose levels of 168, now she is presenting with vomiting, dehydration, just to remind that pregnancy is a ketogenic state and there is a high risk for decay development during pregnancy. So type 1 mothers should be taught about decay education, about its detection as well as prevention. All such mothers should be on CGM. And again, there are amongst many risk factors, hyperemesis, insulin non-compliance are there. And if there is decay in pregnancy, it is very important that the fluid contains dextrose, not just fluid, but it has to be a dextrose containing fluid. And bicarbonate is strictly contraindicated, and decay is not necessarily any indication for immediate delivery. So euglycemic decay is very common during in type 1 mothers during pregnancy. Another thing, of course, glucokinase modic, if the OGTT values are normal, only the fasting is high. Of course, not this high like 168, but up to 140 can be expected during pregnancy. It's very important to avoid insulin in such cases if we are suspecting glucokinase modic in a mother. So take-home messages, we should screen preconceptionally, preferably in all mothers, at least in early pregnancy, in addition to the standard GDM screening. Insulin is the treatment of choice. Metformin may be added if there is a concern about macrosomia. Early intervention in the first trimester for early GDM, it is still controversial. Postpartum follow-up is very important, and type 1 diabetes mothers may present with euglycemic decay. I'm very thankful for the wonderful endocrinologist obstetrician couple and the way their wonderful hospitality, so that the way they're living happily ever after. A good collaboration between a good obstetrician and endocrinologist can give a healthily ever after to a mother and child and for generations ever after. Thank you so much.
Thank you, Dr. Sunetra, for your nice discussion. Now it is...
If there are any questions.
Give thanks to audience also for their patience hearing. Now I want to ask you one question. Now you just discussed that metformin can be continued during pregnancy.
Selected cases, yes.
Beneficial in a obese mother or polycystic ovarian lady just get pregnant. So how long this metformin can be continued?
Actually, we can continue till delivery, but if we go by the guidelines, they have recommended to discontinue metformin, not to continue, because even in PCOS, metformin use has not been found to prevent GDM. It prevents excessive gestational weight gain, but it doesn't really prevent GDM, even in PCOS
Another
mothers.
question is, you just told about the aspirin.
Yes.
The aspirin, there are 75 milligram and 150. Which one is preferred during pregnancy?
I think obstetricians follow 75 milligram, we go by that, we just continue that. Yes, 150, okay.
We are giving now 150.
Okay.
And madam, as far as metformin is concerned, we do not have any evidence of teratogenicity with metformin.
Yes,
Continue metformin throughout pregnancy. The MIG-TOFU trial and the other trials which have come are showing reduced incidence of large babies, reduced adiposity in women, PCOS women conceiving, continuing metformin even till the day of delivery or even after delivery, the issues are none.
We still practice that, though it is not recommended in guidelines.
Only FDA approved drug for GDM is insulin. There is no other drug approved by FDA for treatment of GDM or diabetic mothers. But metformin, we use it, we have used it till today and we will continue to use it. Thank you. Thank you, Sunetra, for that wonderful discussion. And we request Sunetra to come to the photo booth for our gratitudes, and we'll quickly move on to the next session on gynae and gynecology and diabetes. And to chair this session, we have Dr. Deepak Chaudhary, who is treasurer and a senior treasurer IMA Purulia and a senior obstetrics and gynecology. A very close colleague, Dr. Hari Mohan De, Dr. H.M. De, another senior obstetrician and gynecologist from Purulia, and Dr. Jayanto Chandru, a very close friend and a very senior gynecologist also from Purulia. This session will be deliberated by Dr. Neha Agrawal. Dr. Neha Agrawal is a senior endocrinologist at the Health World Hospital, Durgapur, a colleague and also from the same institute that we have done our postdoc from. Dr. Neha Agrawal. And I'd request everyone to stay back. We just have 2 more sessions before we move on to the wonderful evening snacks, high tea, along with the traditional Chau Nach of Purulia to be deliberated right in the hall behind you where you had lunch. Dr. Neha.
Good evening, everyone. First of all, I would like to thank Dr. Pankaj Da and Dr. Akash for the kind invitation and for organizing this excellent program. And as we are moving towards the end of the program, I would not keep you waiting for long. So let's quickly begin with the topic, that is PCOS and metabolic syndrome. Are they the same? So why this comparison matters? It is because of the presence of similarities and dissimilarities. Similarities includes insulin resistance, obesity, which is central, mainly presence of chronic inflammation, hormonal imbalance, and the increased risk of cardiovascular disease and type 2 diabetes. But there are dissimilarities. PCOS is mainly a reproductive and endocrine disorder which affects mainly women of reproductive age. It is associated with infertility, menstrual dysfunction, and hyperandrogenisms like acne and hirsutism. While metabolic syndrome, it's a metabolic condition which involves the multiple organ. It affects both men and women, and again it leads to increased risk of cardiovascular disease and other metabolic conditions. So the prevalence of PCOS is 6 to 10% depending upon the various diagnostic criteria applied. It is one of the most prevalent endocrine disorder among the premenopausal women, and it is more prevalent in overweight or obese women and in specific ethnic groups. While the metabolic syndrome, it is a constellation of risk factors like, which includes altered carbohydrate metabolism, obesity, dyslipidemia, endothelial dysfunction, and arterial hypertension. And there is increased risk of cardiovascular disease, type 2 diabetes, sleep apneas, and cancers, and even psychological issues. The prevalence of metabolic syndrome in the Indian PCOS is around 38 to 50%. And the most common component which is being found in the PCOS women is the low HDL and the increased waist circumference. So what is the common factor, or what is the common link between these two diseases? It is the insulin resistance, and it is defined as decreased ability of the insulin to mediate the metabolic action, for which increased amount of insulin is secreted or needed to achieve a given metabolic action. So in addition to the type 2 diabetes, presence of insulin resistance can lead to various other metabolic diseases like hypertension, dyslipidemia, type 2 diabetes, and obesity, acanthosis nigricans, PCOS, hyperuricemia. So when we look at the pathogenesis of metabolic syndrome, presence of central obesity and insulin resistance leads to the onset of dyslipidemia. Hyperinsulinemia can itself increase to the sympathetic overdrive, stimulates the RAS system, leads to the onset of hypertension, and obesity leads to the chronic low-grade inflammation, decrease in the adipocytokines, and promotes atherosclerosis. So basically, central obesity and insulin resistance play a central role in the onset of metabolic syndrome. Similarly, if we look at the pathogenesis of PCOS, we can see here presence of insulin resistance increases the risk of type 2 diabetes, cardiovascular disease, and other metabolic conditions. And not only this, insulin resistance worsens the hyperandrogen. It increases the secretion of androgens, which we'll see in the subsequent slide, the mechanisms through which it causes hyperandrogenemia. And this hyperandrogenemia further worsens the insulin resistance. And so there is a vicious cycle between the hyperandrogenemia and the insulin resistance. And it has been seen in the studies that 95% of the women with PCOS and central obesity has got insulin resistance, 75% of the lean PCOS women has got insulin resistance, and even the normal weight PCOS women have got the insulin resistance. So we can say that insulin resistance is present in all PCOS women, invariable of the BMI. Now, as I was talking about the mechanisms through which hyperinsulinemia can lead to androgen action, the mechanisms include: first, insulin acts as a co-gonadotropin. It promotes the actions of LH, and it itself stimulates the androgen enzymes, that is the PC450 enzyme, and promotes the androgen secretion. It has got, in the presence of hyperinsulinemia, there is a phenomena called ovarian paradox, where the ovary remains sensitive to the insulin while the peripheral tissues are resistant to the insulin, and because of the hyperinsulinemia, there is more androgen action secretion because the ovaries are sensitive to the insulin. And in the peripheral tissue, because of the insulin resistance, there is decrease in the amount of SHBG, which increases the free androgen levels or the free testosterone levels, which further promotes the hyperandrogenemia. Insulin also has got a central role. It acts on the hypopituitary gonadotropin axis. It stimulates the GnRH mediated anterior pituitary secretion of FSH-LH. It also upregulates the GnRH expression in the hypothalamic GnRH neurons. Now, this is a schematic picture which shows the cellular actions of the theca and the granular cell under the insulin influence. So, as we can see in the figure, as you can see here in the figure, that in the presence of hyperinsulinemia, there is increase in the activity level of the epimerase, and epimerase is the enzyme which converts the MI to the DSI. These are the types of inositols. So if there is increase in the epimerase enzyme, there is increase in the secretion of DCI. Now this dichiroinositol, it increases the activity of the androgen secretion. So more and more testosterone is secreted inside the theca cell through this epimerase activity. On the other hand, as I said, that it acts as a co-gonadotropin, it stimulates the action of LH. So under influence of this, more and more LH activity is increased, and more androgen levels are being formed in the theca cells. And these androgen levels, this testosterone gets transfused to the granular cell, and insulin in the granular cell also stimulates the action of the FSH, increases the androstenedione formation, which further converts into androgens. And under the influence of hyperinsulinemia, there is decrease in the activity of the aromatase, so this testosterone to the estrogen conversion doesn't happen, and overall there is hyperandrogenemia under the influence of hyperinsulinemia. The other pathogenic factors are the genetic factors and the disruption in the post-receptor insulin signaling pathways. Now moving on to the diagnostic criteria, as per the IDF, presence of this 3 out of 5 criteria classifies to be a metabolic syndrome, among which presence of increased waist circumference is a must criteria, and the other 2 criteria could be increase in the high blood pressure, high triglyceride level, high glucose, or the low HDL values. While for the PCOS, we have got different diagnostic criteria. Starting from the year 1992, NIH proposed that the presence of both hyperandrogenemia and ovulatory dysfunction is needed. In the year 2004, both the European and the American reproductive guidelines suggested that presence of any 2 of these 3 criteria, which include hyperandrogenemia, ovulatory dysfunction, or polycystic ovaries, can classify to be PCOD. While in the year 2006, Androgen Access Society suggested that we need both the criteria to be present. First, it could be hyperandrogenemia, or it could be presence of either ovulatory dysfunction or the polycystic ovaries, or both. But till date, through the evidence-based guidelines and all the international guidelines, they still fixed to the Rotterdam criteria, which includes androgen access and ovulation and the polycystic morphology. So if there is presence of 2 of these 3 criteria, then it classifies to have a PCOD. So this is a picture of an hairy lady which I have taken from, which was put up in a book called Nuremberg Chronicle, which is a book regarding the world history. And this is how a lady with hyperandrogenemia looks like. So the clinical definition of hyperandrogenemia is presence of hirsutism, acne, alopecia, frank virilization, or there could be biochemical testing through which we can establish this hyperandrogenism. For this, we need to measure total testosterone. Which is a first-line recommendation. Ideal method of testing should be LCMS, and it is preferred over enzyme or the radioimmunoassay. Free testosterone should be calculated as the other methods have got less reliability, and the free androgen index can be calculated by using testosterone and SHBG. In PCOD women, we found it has seen that the SHBG is low. The other markers which we can use are androstenedione and DHEAS if the testosterone or the free testosterone cannot be done. And this biochemical testing should only be done if there are clinical absence of the signs of hyperandrogenemia. And this testing should be ordered between day 2 to day 5 of the menstrual cycle, or at any time if we suspect an ovulatory cycle. There are still no clear cutoffs, but the accepted cutoffs include the accepted cutoffs are testosterone value of more than 55, or free testosterone of more than 9, or the free androgen index more than 4.5, and these are the usually accepted cutoff. There is a limited role of repeated testing if the patient is on COCP, but if we need to re-evaluate, then we need to stop the COCP for at least 3 months. Moving on to the imaging diagnostic criteria through ultrasonography, if the patient had got clinical symptoms of PCOD, which includes oligomenorrhea or irregular cycles and the clinical features of hyperandrogenism, then we do not need to do imaging. But if any of this one criteria is present, so to fit for the diagnosis of PCOD, we need to do imaging. And the ultrasonography criteria for the PCOM is the increase in the ovarian volume of more than 10 ml on either of the ovary, or increase in the number of follicles, that is follicular number per ovary should be more than 20, or the follicular number per section should be more than 10. And the modality, the preferred modality is transvaginal sonography. This transabdominal sonography is an older technology and it gives poor imaging quality, and with this we cannot do the follicular number per ovary because it becomes cumbersome. And imaging is not needed for adolescents. AMH can be used as a surrogate marker if USG is unavailable or inappropriate. Now this is the current classification which we follow. According to this, there are 4 PCOS phenotype. The PCOS phenotype A, B, C, they have got
the PCOS phenotype A is a more severe phenotype. It has got all the three features of PCOS, that is anovulation, hyperandrogenism, and as well as it has got PCOM, it fits into the PCOM criteria. While the phenotype B and C, they are different. In phenotype B, the PCOM criteria doesn't fit, and in phenotype C, the patient has got PCOM criteria and hyperandrogenism, but there is no anovulatory cycle. So PCO type C is also called as ovulatory PCOS. Now what is this phenotype D? In phenotype D, there is no biochemical or clinical hyperandrogenism. It is a non-hyperandrogenic type of PCOS, and there is only anovulation, and the patient has got PCOM in the imaging criteria. So how does it differ in terms of complication? PCOS phenotype A, B, C, they are at higher risk of developing metabolic risk because they have got hyperandrogenemia, while PCOS phenotype D, they have got, it is mainly an ovulatory reason, or it's a ovulatory reason behind having PCOD, and there is no hyperandrogenemia, so there is lesser risk of having metabolic complication in the long term. Now this is a newer classification which was suggested by a European group which is working on the molecule inositol, and they have proposed a newer classification where they have made a slight change. They have said that they have classified phenotype A, B, C as an endocrine metabolic syndrome, and they have found that in phenotype A, B, C, as I have said, there is increased risk of metabolic disorder. So they have found that if we use the molecules which reduces the insulin resistance, then probably we can provide more benefit, and in this group, COCP should be considered as a second line, and while the insulin resistance reducing drug or the insulin sensitizing drug should be considered as a first line. While for the phenotype D, they have suggested that insulin sensitizers doesn't work. And again, one more change, they have suggested that the original phenotype C, they have classified as PCO-EMS type 2 because there is an absence of menstrual cycle alteration, and in PCOF phenotype B, there is absence of PCOM imaging criteria. So they have classified EMS type 1 as phenotype A, EMS type 2 as phenotype C, and plain EMS as phenotype B. So this is the main person who is involved in this study, Unfer et al., and he has redefined subgroups A, B, C as endocrine metabolic syndrome, and on the other hand, the clinical subgroup D was classified as ovarian PCOS, which present as a gynecological issue, typically in the absence of metabolic tissue, and the proposed pathogenesis for the PCOS phenotype D is a defects in the signaling of the insulin-like growth factor, which is recently described by Dye and colleagues, and it was a proposed possible explanation for the arrest of follicular growth and maturation. Now moving on to the lifelong complication of PCOS, it varies depending upon the age. In the early age, it is mainly reproductive complication, and as per the age advances, there is increased risk of metabolic complications. Now moving on to the incidences of metabolic complications, approximately 30% of the adolescent PCOS presents with impaired glucose tolerance, and 3 to 10% develops frank type 2 diabetes. In obese PCOS, on the other hand, in non-obese PCOS, the incidence of type 2 diabetes is less than 1%, but still there is higher incidence of impaired glucose tolerance. The incidence for dyslipidemia is 70% in reproductive age PCOS women, and there is increased risk of development of whole metabolic syndrome too. Now, what about the cardiovascular events? The lifetime risk of CVD in PCOS women is high, that is more than 50%, and mostly it is preventable. On the other hand, in the metabolic syndrome, there is 3 to 6 higher risk of developing CVD with a 12% increase in mortality. We need large-scale prospective study to assess the actual magnitude of the impact of metabolic syndrome in PCOS on cardiovascular events. Now regarding cancers, PCOS women are at increased risk of developing endometrial cancer. However, studies have not shown any increased risk of developing breast cancers or ovarian cancer. On the other hand, metabolic syndrome itself leads to increased risk of many other cancers like colon cancer, endometrial cancer, breast cancer, pancreatic cancer, and so on. Regarding obstructive sleep apnea, there is a high prevalence compared in the PCOS compared to the control, and it is independent of BMI, and the assessment should be based on symptoms, screening questionnaire, and a formal sleep study. Now, as I was talking about the increased risk of metabolic diseases in PCOD, this study have shown that PCOS type A, B, C has got higher risk of developing metabolic diseases compared to the control, while the PCOS phenotype D has got almost similar risk of developing metabolic disease as compared to the control group. So this is an area of research, like what type of agent should be used in phenotype D to cure or to treat the PCOS. Now, regarding the recommendations for screening of metabolic risk factors, all PCOS women should be assessed or should be evaluated for metabolic risk factors. At every visit, we should check for blood pressure, and yearly we should go for lipid profile and for diabetes screening. Ideally, OGTT should be done, but if it is not available, then we can do fasting blood sugar and HbA1c, but it significantly reduces the accuracy of the latter. As all PCOS women are at high risk of developing severe risk, overall, though the risk is low, but in premenopausal women, but as the age advances, the risk of CV diseases increases. So PCOS should be included in the severe risk prediction and the assessment tool for females. And most importantly, there is no role of insulin assays. Now, moving on to the management, we all are talking about the lifestyle modifications since the beginning of the program, so I won't go into detail. The only thing I would like to highlight here that we should promote 5 to 10% of the weight loss in all PCOS women to reduce the insulin resistance. And these are the dietary recommendations. To cut it short, we should promote well-balanced, nutrient-rich diet, and it should be less carbohydrate, there should be moderate protein intake, and it should be less fat intake. Now, regarding metformin monotherapy, it should be considered in adult PCOS women with higher BMI of more than 25 kg per meter square for anthropometric and metabolic outcomes. It can be considered in adult PCOS women with BMI less than 25. It can be considered in adolescent at risk with limited evidences. Studies have shown that it doesn't provide any superiority over lifestyle modification, but if LSM fails, then we can add metformin therapy. And the recommended dose is to start with 500, the maximum dose is 2.5 gram per day. But we should keep in mind that it leads to GI side effects. Regarding combination therapy, COCP plus metformin has found to be non-superior compared to the COCP plus lifestyle modification, along with the increased risk of GI side effects. COCP with metformin leads to additional benefits in terms of weight loss, anthropometric benefits when given in higher BMI patients. It can be considered in adults with BMI more than 30 when they have got metabolic risk factors or having established impaired glucose tolerance or diabetes. Or we can give metformin when COCP is contraindicated or not tolerated for patients having irregular cycles. Regarding myoinositol,
Madam, please conclude.
Yes. A few slides. Regarding myoinositol, it can be used in any forms in women with PCOS except the phenotype D with limited evidences. This one more molecule, alpha lipoic acid, has shown that it improves the insulin sensitivity. Regarding anti-obesity pharmacotherapy, the recommendation is same as the obesity guidelines. And regarding SGLT2 inhibitor, it has shown that it improves the metabolic, anthropometric, as well as it has shown to improve the testosterone levels also. Regarding again the bariatric surgery, the recommendation is same as per the obesity guideline. So this is the newer EGO classification. They have suggested that for phenotype A, B, C, we should use insulin sensitizer, but for phenotype D, insulin sensitizer doesn't work. So I have got a clinical case, a 19-year-old, this case I have seen a few months back. A 19-year-old female who presents with complaints of oligomenorrhea for the last 1 year, having weight gain and decrease in appetite. She achieved menarche at the age of 10 years. She's a known hypothyroid, well controlled. She has got a family history of diabetes with hypothyroidism in mother. Her current BMI is 31. She doesn't have any other features of hirsutism or galacturia or Cushing. Her lab value shows that she has got impaired fasting glucose with higher values of insulin with low HDL. Her USG shows that the ovary volumes are on the higher side. So she fits into the PCOS phenotype D, non-hyperandrogenic metabolic syndrome with impaired fasting glucose. I started him on lifestyle modification with metformin, 500 mg per day. When she came into follow-up after 3 to 4 months, I found that her cycles got regularized and she has even lost weight with no psychosocial issues. So the key takeaways are PCOS and metformin are part of the same metabolic syndrome. Etiopathogenesis, there is a paradigm shift from the mere reproductive causes to the more insulin, to the more metabolic causes. So I would say PCOS is tough, but so are you. Every step towards better health is a step towards a brighter future. Thank you.
Thanks, Neha. We all know that this is not a short subject. and you covered it all in this short time. And again, thank you.
Thank you, sir.
Thank you, Dr. Neha, for that wonderful talk. You tried to cover up. And the key message is I always tell my obstetric colleagues that please do not test serum insulin. It's of no use. Please do not test serum insulin. And another message which I keep telling them, that PCOS is not a treatment for 3 months or 6 months. It is a treatment for a lifetime, sometimes years, and sometimes throughout the lifespan of a woman. These are because patients often come to us with taking COC pills for 6 months, 9 months, stopped records. So it's a treatment of a lifetime. Thank you, Dr. Neha. Please come to the photo booth for a photo session and some gratitudes. We now move on to the last session for today's Diabetes and Obesity Update Purulia 2024. To chair this session, I request Professor Shyamul Kundu, sir, Professor and Head of the Department, Medicine, Bankura Shommiloni Medical College, Bankura. Along with him, I would invite to chair Dr. Partho Banerjee, who is a senior physician and radiologist, a senior IMA member of Purulia, a very close friend, and Dr. Shaumik Bauri, who is BMOH Banda BPHC, another BPHC in Purulia district. And thankfully, I am the speaker for this session.
Thank you. I take this opportunity not as a speaker, but you all know me, and so let's not waste time in introductions and niceties. You all know me, and I first mainly thank everyone till late this evening, on this winter evening, having spared time, all of you. It's lovely. I'll be talking briefly about semaglutide, which is a GLP-1 receptor agonist, and it's primarily in discussion in India because it's available orally. Other GLP-1 receptor agonists are primarily available as injectable drugs. So the financial disclosures are none, and the agenda is obviously the weight and cardiovascular risk in diabetes. Most diabetics die of cardiovascular disease. Most diabetics are obese. And so how early weight reduction and CV reduction can help in reducing both morbidity and mortality, and how you can tackle the trinity, weight, diabetes, and etc. This whole thing, how you can tackle CV risk, tackle it together. So what is the dual epidemic? You know, uncontrolled HbA1c and excess weight together. We are talking of one. Now we talk of two things. Because the conference itself says diabetes and obesity update. So there are two things put together, and you put the third thing into it, the CV risk, and you make it a trinity. It's not the holy trinity, it's rather the unholy trinity, which will take away the life of a diabetic patient quite prematurely. And there are overlapping risk factors, we know. The same risk factors, the lifestyle issues, the genetic issues, they are common to all the diabetics, the overweight subjects, and those with cardiovascular risk. We test them for similar things. We test them for glucose, we test them for blood pressure, we test them for lipid profile, we test them for a highly sensitive CRP, we test them for other markers of atherosclerosis. So that pathogenesis or the etiopathogenesis possibly is similar, as Neha was talking in the previous talk, PCOS and metabolic syndrome, the etiopathogenesis is similar. So ultimately insulin resistance, metabolic syndrome, and everything else in diabetes and obesity are also similar. And what the pathophysiology thing, as you can see, as I was talking about, systemic inflammation, atherosclerosis, hypertension, endothelial dysfunction, and everything else associated with diabetes and obesity are there in the picture that we are discussing. So the unholy trinity of diabetes, obesity, and cardiovascular disease. And actually, as we've had long discussions since morning whether sulfonylureas are adequate, whether you can start the patient on insulin, when should you start the patient on insulin, what should be the renal complications of diabetes, what are the liver complications of diabetes, children with diabetes. We have discussed everything at length since 11 a.m. today in the morning. And we now have come to a conclusion that a diabetic patient is not just a patient, it is a whole package. It's a package of the complications that come with diabetes, which may be present from the first day of diagnosis. So we have to treat the patient, not just the glycemic status, not just the glycemic control of the patient, we have to treat the patient with drugs, with lifestyle measures, with agents, which will not only reduce glucose, will protect his kidneys, will protect his liver, will protect his heart, will protect his eyes, will prevent stroke or CVA in him, and ultimately lead to a better life for our diabetic patients. Not just a good fasting PP and HbA1c, we need much more than that. So in order to address these issues, we have also come to a conclusion that the weight, the excess weight in our diabetic patients is probably the harbinger of all of this. The obesity, the central obesity, the visceral obesity, everything that we see in our diabetic patients is perhaps the harbinger of inflammation and atherosclerosis present in these patients. We are worried about these two things, inflammation, atherosclerosis, and organ dysfunction. So if we can address these issues, we will probably be doing good in our diabetic patients. And in order to doing this weight reduction, we have now come across some of the trials, the direct or the remission clinical trial, which was a trial in diabetic patients where hypocaloric diet was being given, around an 800 kilocalorie per day diet was given, where it was seen that more than 50% of type 2 diabetic patients went into remission. That is, not requiring any drug of diabetes for continuous 3 months with an HbA1c of less than 6.5 with a hypocaloric diet. So, and the look ahead trial where exercise and physical activity was associated with improved outcome in diabetic patients. And we also have data that the greater the weight loss is, the greater the improvement in overall health and complications of diabetes. We know overweight is associated with kidney disease independently, overweight is associated with MASLD independently, overweight is associated with cardiovascular disease independently, overweight is associated with CVA independently, and overweight is associated with all-cause mortality, including causes of carcinogenesis or cancer overall. So we now come to what has been the new game changer in terms of weight reduction. In the talk by Dr. Umesh Garg, you must have seen, he was talking about anti-obesity medications which are available. Frankly, today in India, we only have Orlistat as the only anti-obesity drug which is available. We use Orlistat in our patients, but Orlistat has a limitation as to the amount of weight that can be reduced with Orlistat. Even with more than 1 year of therapy, with 120 milligram thrice daily Orlistat tablet, you cannot achieve a weight loss of more than 5%. Today we are talking about a weight loss of 10%, 20%, 25%, and we are probably targeting bariatric range weight loss in our diabetic patients, and that can come only with GLP-1 receptor agonists, semaglutide, or the dual receptor agonist, that is tirzepatide, or maybe the triple agonist that we are looking at in future, or the other oral agents which are available. But the biggest problem is the approval in our country is not available for most of these drugs, number one. Number two, they are injectables when you are talking about weight loss. It's Wegovy, not Ozempic for semaglutide, and they are costly. But there is a solution currently that we have in India for some who can afford, that is oral semaglutide. Oral semaglutide is available in India for the treatment of diabetes, mind it. It has not yet been approved in India for the treatment of obesity. We use that drug sometimes off-label for the treatment of obesity, and mostly in our obese patients with type 2 diabetes. And we often have stories about weight loss being circulated in our WhatsApp groups of endocrinologists, that patients having lost 20 kgs in 6 months with oral semaglutide, 25 kgs, 10% weight loss, remission of diabetes, remission of MASLD, remission of lipid profile parameters, blood pressure reduction, and so on and so forth. And with the FLOW trial coming for the renal outcomes in terms of use of semaglutide, we now know that semaglutide is, or GLP-1 receptor agonists are as good in renal outcomes of diabetic nephropathy as well. So this is the oral semaglutide, the foundation stone for oral GLP-1 receptor agonists. This is currently available in India for treatment of type 2 diabetes only. Co-formulation, as you know, how did we turn the the protein into the pill was attached to snack, which is an absorber and does not allow the protein to be degraded in the gut. It causes the absorption through the gut, the villi, and once it goes inside, it acts. Obviously, the doses required are much higher compared to the injectable drugs. So it is the world's first and only orally available GLP-1 receptor agonist. We have newer drugs like orforglipron, which may be available soon. Those are non-peptide oral GLP-1 receptor agonists. And the co-formulation does not change the chemical structure of either semaglutide or snack. They remain as distinct entities. So these are the clinical programs: 19 trials with oral semaglutide, 1 phase 2 trial, 12 phase 3 trials, 1 phase 3b trial. So many patients enrolled on these trials. And the pioneer group of programs, we moved into pioneer 1, 2, 3, 4. We are now into the leading series of pioneer programs, where all these programs with oral semaglutide were tested for various groups of patients, for diabetic patients, diabetic adolescents, diabetic elderly patients, diabetic patients with cardiovascular disease, pre-existing cardiovascular disease, and across all groups it was realized that oral semaglutide causes greater reduction of HbA1c in comparison to any other drug used in the comparator arm. 1.5% reduction of HbA1c was seen with oral semaglutide across most of these trials. And so clinically relevant weight loss, we've just talked about weight, overweight, obesity in type 2 diabetes. So weight loss with oral semaglutide was also seen across the pioneer programs. Up to 5 kg weight loss, we are not talking of 5 kg, this is the limited duration of the trial that it was. We are talking of 10%, 20% weight loss, which can happen with this oral semaglutide. And a 3-fold greater reduction of mean fat over lean body mass was seen with semaglutide. Exposure-related relationship both with oral and subcutaneous semaglutide. As I said, it's basically a problem with the dose. A 14 milligram of oral semaglutide is kind of equivalent to 1 milligram of subcutaneous or parenteral semaglutide, and that is what the 14 milligram dose is what we try to achieve in our patients over a duration of few months for treatment of type 2 diabetes, and that becomes equivalent to 1 milligram injectable semaglutide, which is the recommended dose for treatment of type 2 diabetes. So semaglutide reduces weight loss obviously through appetite suppression. It acts here and it acts in the gut, GLP-1 receptor agonist, and reduces weight by reducing appetite. It also acts at the central level, some astrocyte glial levels in the brain, also causing suppression of appetite. So it has shown cardiovascular safety, reduction in risk factors for cardiovascular disease. And how does the data fit into the Indian scenario? The pioneer real data, the real-time data or the real-life data of the pioneer is also available, where it has been seen that oral semaglutide has been well accepted as a drug of choice for managing early diabetes in India, preserving beta cells and preventing the long-term complications of diabetes. So practical considerations with treatment of oral semaglutide: robust reduction in HbA1c, clinically relevant weight loss, providing the efficacy of a GLP-1 receptor agonist in an oral formulation. Like we say, the peptide in a pill. It has proven cardiovascular risk reduction, targeting cardio-metabolic risk early in diabetes. As you've said, the metabolic memory thing about diabetes, you treat diabetes early, achieve good glycemic control early, you will have better outcomes later in life. No dose adjustment required in renal and hepatic impairment. There is very little or no risk of hypoglycemia. And taken first in the morning with 120 ml, we say half a glass of water, and 30 minutes you need to eat nothing after you've taken the oral semaglutide tablet, and that is how it works. Thank you so much for your patient hearing for that talk on semaglutide. If there are any questions, I would be happy to answer, or I'd move to Akash, who will be the last speaker for the day. Sir.
Thank you, Pankaj.
Madam has a question, I think. Yeah. Madam, mic it. Please come to the floor, mic, madam. The talk was a little rushy, I believe, because I do not want to stand between you and the lovely high tea and the chow nach. Madam, please.
Whether it is tested on pregnant mother or not?
No, madam. No, madam. No, madam. No. Absolutely no. This is absolutely contraindicated. Pregnancy, lactation, and children are not allowed. Thank you, madam.
One question from my
sir,
side.
Sir.
So, in look ahead study,
Yeah.
Weight loss based lifestyle intervention did not reduce the cardiovascular risk.
Yes.
Whereas semaglutide, when the weight is reduced, it is extrapolated as reduction of cardiovascular risk. How do you explain that?
Sir, actually, the lifestyle interventions, whether it is diet or exercise, may not take care of inflammation and atherosclerosis to that extent, by which, because the weight reduction quantum which happens with lifestyle or with weight reduction diet may not be that much that we are targeting with semaglutide, and a number of questions about semaglutide are yet to be answered, how it causes so much of pleiotropic benefit in terms of all kind of mortality reduction, and we are probably looking at more trials in future where we'll be able to have more data, but it does reduce.
There is a post hoc trial on this look ahead, which showed that those patients who develop weight reduction of more than 10% within 1 to 2 years, they did benefit in reducing the rest.
It actually, so there are two things: the amount of weight reduction and how early you do, whether you are doing it early in diabetes or whether you're trying to do it maybe 10-15 years after you have diabetes. Thank you, sir. Akash, Shubhankar has the last question, because before Akash takes the stage to degludec.
And obese PCO or obese adolescent PCO, can you use?
Yes, why not? We can use PCOS, as Neha was talking.
Because they are reluctant to do exercise and diet control.
They are reluctant to do exercise. Yes, they can be used with the age of approval. We still have not approved in India, basically, other than diabetics. Once it is approved in India,
Novo Nordisk India te kon এনেছে কি একটা brand এনেছে দেখলাম তো।
they are planning. The Novo people are over there,
Rivals
but I still do not have any idea whether they are approved for anything other than type 2 diabetes in India.
Okay.
Thank you.
Common side effect?
GI side effects.
Okay.
Some people tolerate it very badly: nausea, vomiting, constipation, and maybe you feel bad throughout the day. Dr. Rama has a question.
As you are saying, it is acting centrally on our hunger center.
Yes.
So if we use an elderly patient,
If you use in
geriatric patients,
geriatric patients,
they already told ki madam খেতে ভালো লাগে না, খাওয়া কমে গেছে, তো এই এটা ইউজ করলে কি
the geriatric patients, if you're talking of someone who is more than 60 years or maybe 70 years and all, initiation of a drug like this may not be a very good idea in those patients. They may have gastroparesis, they may already have constipation, they may have GERD or other GI issues with them. Like you said, they do not feel like eating already. So unless they're very obese and you're not targeting bariatric surgery, you may give them. But for many other geriatric patients who are doing otherwise good with their type 2 diabetes, with the usual drugs that we're using or a combination of insulin, we may not be using semaglutide for them.
Actually, it is best for the younger age group.
It's for young, new diabetics, obese, young women, PCOS, and everyone else. Thank you so much. Thank you. Akash, please.
Yeah. Good evening, sir. I would like to answer that question, that lifestyle intervention actually. So just one point actually. So the dose matters. In lifestyle intervention also the dose matters. And it's difficult to quantify the dosing in a lifestyle intervention actually. So Dr. Ornis and group, they have done many lifestyle intervention trials in CVD, cardiovascular diseases, where they have shown atherosclerosis reduction, angiographically atherosclerosis reduction in proven CVD patients actually. So they have followed up the patients for around 5 years and they have shown atherosclerosis reduction also.
No, it's not the dose, because in look ahead study, it is based on the weight reduction. So how much weight is reduced?
Agreed, sir.
That is not the dose.
Agreed, sir. I am talking about other studies where they have shown CV benefit. Dr. S.L. Stein and group, they have done that.
Darwin study and a few or many other studies are there which showed that there is benefit.
Sure. Good evening, everyone. So it will be the last talk, and as you know, it's a sponsored talk, and the slide set is being provided by Novo Nordisk, and I will be little quick. So we'll be discussing about insulin degludec and its co-formulation, that is IDEG ASP. So these are the financial disclosure. So coming to the case study 1, so it is about Mr. Ajit, who is 50-year-old, an engineer, and diabetes duration is around 11 years. HbA1c we can see it's around 8.8. The patient is obese with a BMI of 27. The fasting blood sugar is 188 and PP sugar is 218, so a difference of around 30. LDL cholesterol is elevated, the patient's eGFR is 55 and urine albumin excretion is also high. And we can see that the patient regularly takes alcohol, although he is a non-smoker, and exercise is irregular. And coming to his medication, the patient is on antihypertensives, statins and cardiac drugs. And he is presently on metformin 2 gram OD, empagliflozin 25 and also liraglutide 1.8 milligram. Now, what are the challenges ahead? If you see these patients, he is an engineer, he is working class at present, there is uncontrolled hyperglycemia, the patient is developing complications, and also he has a hectic work life and fear of insulin initiation. Now he travels often, so insulin dose flexibility become an issue in these kind of patients. So what next in this patient? We all know that adding a subsequent OAD due to the convenience or acceptance by the patients or the limited time constraints on our part is the most possible way forward that we look at. But we see with successive OAD addition, the progressive HbA1c reduction actually lessens. So what will benefit him most is insulin initiation, as you have already discussed in previous talks. Now, which type of insulin actually? So obviously the patient is a candidate for basal insulin. I have discussed this is a case of OAD failure. So we will be initiating basal insulin. And why basal insulin? Because the postprandial excretion is only 30 units. So if we control the fasting in this patient, if we fix the fasting, then the hyperglycemia will take care of itself actually. And between the basal insulin, we have our NPH insulin, detamine insulin, glargine U100, glargine U300, or the newer generation degludec. If you see the first generation analog insulins, they are not truly once daily. So the efficacy somewhere wanes off at the end of the period actually. If you talk about glargine, maybe the last 4 hours, between 20 to 25 hours, the efficacy gets lessens. There is higher variability, the fixed timing of dosing, they are not truly pickless, and there are issues with nocturnal hypoglycemia also. So coming to insulin degludec, which is a second generation insulin, and if it's an insulin naive patient, then we can start with 8 to 10 unit of insulin degludec straightforward. And if we are switching from other basal insulin or twice daily basal insulin, we can think of 20% dose reduction. If we compare degludec with glargine U300, which is the other second generation basal insulin available, then degludec has shown less hypoglycemia. It's actually ultra long acting, so its onset of action is between 0.5 to 1.5 hour and duration is more than 42 hour. Whereas with insulin glargine U100, the duration is between 30 to 36 hours. And there is unparalleled flexibility actually. So degludec, we can maintain a gap of between 8 to 40 hour actually. So this provides a lot of flexibility. With glargine U300, we have a flexibility of plus minus 3 hours only. So degludec provides a lot of flexibility, particularly for busy professional who will miss their insulin doses. So degludec comes as a boon. And there is also lower day-to-day variability, and they are also more potent. So if we may summarize, degludec fits the bill. It is almost ideal to a basal insulin. It's a flat and pickless activity, minimizing the risk of hypoglycemia, specifically the nocturnal hypoglycemia. It's actually long duration of action, and there is minimal variability. Coming to the second patient, here the profile is same, but the postprandial blood sugar is also high. So we need to add something else to this kind of patient actually, and as discussed by Dr. Rana Bhattacharya, a premix insulin or a basal plus insulin will be a good way to go. So we have discussed this. So PPG control is also important, and when both fasting and PP both are elevated, we might plan a bolus basal plus insulin like Ryzodec, or a premix insulin, be it biphasic human insulin or analog premix insulin. So I'll be discussing little bit about IDEC ASP, that the co-formulation of insulin aspart 30% and degludec 70%.
Now we know it's a unique formulation, no other formulation is available there. Because it's a clear formulation, we need not mix it, and it's a stable formulation. Plus it gives us a flexibility of covering a meal also in a single injection. So it is efficacious, it is safe, and it also improves the quality of life. If we compare it against glargine U300 or U100, it has shown better glycemic efficacy, and particularly when we talk about Indian diets which is carbohydrate rich, we often face this issue of postprandial glucose control actually. The fastings are controlled but the PPs are pretty high, and we need something to control that. IDEG-ASP has shown less hypoglycemia compared to basal insulin, and also the quality of life has improved. Now coming to the flexibility in dosing part, if you see glargine U100, we need to initiate with 10 unit insulin, and it can be given any time of the day, but we need to fix our time to that time of the day actually. With glargine U300, we have a flexibility of plus minus 3 hours, but with IDEG-ASP, which is a co-formulation, we need to initiate with 10 unit, and it needs to be given with a major meal. So we usually initiate with the major meal, which can be the lunch or dinner. For some patient, it is their breakfast also. And I would also like to highlight that in those patients, when the carbohydrate content is high in more than one meal, we can give it twice daily also. Coming to the male mean concept, we need to see what is the carbohydrate content of the patient actually, or we can see the postprandial glucose elevations. So this we have discussed. So when to intensify, now normally we use IDEG-ASP once daily as a basal plus regimen, but if we see that the daily doses are going beyond 30 to 40 or the HbA1c is not controlled, we can think of giving it twice daily also. In that case, we will be dividing the doses between the two highest carbohydrate rich meals actually. And it has also shown safety and efficacy in elderly, those with renal impairment, hepatic impairment, even during religious fasting, something like Ramadan, or those patients who are on only 2 meals a day kind of scenario. This IDEG-ASP twice a day works like a wonder actually. So to summarize, IDEG-ASP is an ideal choice of insulin initiation. It is backed by evidence and guideline, and we should make use of these innovative formulations for the betterment of our patient. With this, I thank you.
Thank you, Dr. Akash. Chairpersons, if there are no further questions, I'd request Dr. Akash to please come to the photo booth, and we would like to express our gratitude as the organizing chairperson for this wonderful CME. A big round of applause for Dr. Akash Panigrahi from Jamshedpur. Chairpersons, to please express our gratitude to Dr. Akash. And Dr. Akash would please do the honors of felicitating our 3 chairpersons, Professor Shamul Kundu, Dr. Shaumik Bauri, and Dr. Partho Banerjee, all so close to us. This brings us to the end of this Diabetes and Obesity Update Purulia 2024. I do not have words to express my gratitude to everyone present in this hall, behind this hall, or those who are on their way back home for being with us in this journey. As I promised in the thyroid update in May that we will come up with something more, today I again promise that we will come back with something more, better maybe, or at least of a similar magnitude. We have a wonderful high tea with some snacks, chart, etc. laid down just behind this hall, and a Chau Nach team which is waiting for our gracious presence and patronage. Thank you, good night, and see you again. Thank you so much.